Hello everyone, and welcome back to another chapter of Advanced Pathophysiology. Today we're talking about chapter 25, the alterations of the female reproductive system. This is one of the longer chapters, so without much further ado, we will jump right on into it. Alterations of the reproductive system have a wide range of clinical presentations, from delayed sexual development and suboptimal sexual performance to structural and functional abnormalities. Many common reproductive disorders carry potential serious psychologic and physiologic consequences. Sexual or reproductive dysfunction, such as impotence or infertility, can dramatically affect self-concept, relationships, and overall quality of life. Conversely, organic and psychosocial problems, such as alcoholism, depression, situational stressors, or chronic illness, and medications, all can affect ovulation and menstruation, sexual performance and fertility, and may be risk factors for the development of some types of reproductive tract cancers. Diagnosis and treatment of reproductive system disorders are complicated by the stigma and symbolism associated with the reproductive organs and the emotion-laden beliefs and behaviors related to reproductive health and fertility. Treatment and diagnosis for related problems may be delayed because of embarrassment, guilt, fear, or denial. So, abnormalities of the reproductive tract and its developments. As discussed prior in chapter 24, normal development of the female reproductive tract requires absence of testosterone during the embryonic and fetal life. The resulting fusion of the two paramesonephric ducts produces the normal cervix and the uterus with internal cavity. The distal portions of the paramesonephric ducts remain independent and form the two fallopian or uterine tubes. Alterations in the normal process include errors in the cellular sensitivity to testosterone or failure of cell line migration, resulting in changes in the structure of the reproductive organs. Your androgen insensitivity occurs in its most extreme form in about 1 in 20,000 people, and is discussed briefly in this chapter because of the often resulting female phenotype despite a male genotype. This syndrome is caused by an X-linked genetic mutation in cellular androgen receptors that results in an end organ insensitivity to testosterone, which normally acts as a catalyst for the development of the male reproductive system in embryonic development. Complete androgen insensitivity syndrome is characterized by external female genitalia with a 46XY genotype, whereas partial androgen insensitivity syndrome presents with an ambiguous genitalia and varying genotype. Children with CAIS or complete androgen insensitivity syndrome often have testes within the labia majora, inguinal ring, or abdominal cavity that produce testosterone in normal range levels. Breast development may be normal, but pubic and axillary hair is often sparse, and the cervix, uterus, and ovaries are absent. A short vagina that ends without a cervix also may present. These individuals are often undiagnosed until puberty, when menarche does not occur. Both CAIS and PAIS carry an increased risk for gonadal tumors and malignancies. Gonadectomy and hormone replacement therapy are recommended for all individuals with CAIS and those with PAIS who are living as females. There remains controversy about the optimal timing of gonadectomy. Other abnormalities of the uterus, cervix, and fallopian or uterine tubes are caused by the Mullerian duct abnormalities. These have multifactorial origins, often the result of an interaction between the genetic predisposition and environmental factors. Some medications, chemicals, and toxins have been implicated as a direct cause of uterine abnormalities. For instance, udithiostilbestrol was prescribed from 1938 until 1971 as a drug to prevent miscarriages. Although it was not effective at preventing miscarriages, DES affected cell development, causing abnormal internal reproductive anatomy that resulted in uterine malformations and a predisposition to cancer. Disorders of the Mullerian tube's development include agenesis, a complete absence of uterine and fallopian tubes, or fusion abnormalities resulting in a duplicate bicornate or septate uterus. About 7% of the general female population has some sort of uterine abnormality, but the rate is much higher in populations of women who have experienced infertility or miscarriage. Uterine abnormalities often developed when the woman has menstrual abnormalities or presents with sexual dysfunction. In other cases, these abnormalities are diagnosed during the diagnostic workup for infertility. Because the uterus is capable of menstruation but may have difficulty supporting a fetus. So here's a good spot to hit pause so you can see the different types of uterine malformations. I'll leave that up for just a second longer. If you ever feel like I'm going too quickly, please make sure you hit the pause button. During pregnancy, uterine malformation are usually diagnosed by ultrasound or with an MRI. The prognosis of these pregnancies depends on the severity of the malformation and the location and size of the placenta and fetus. Some abnormalities can be surgically corrected to improve the outcome of subsequent pregnancies. Abnormalities of the lower genital tract can also result in women having two vaginas or a vaginal septum. For most women, this does not create functional problems but can be surgically corrected if necessary. That brings us to the alterations of sexual maturation. The process of sexual maturation, or puberty, is marked by the development of secondary sexual characteristics, rapid growth of the body, and ultimately the ability to reproduce. A variety of congenital and endocrine disorders can disrupt the timing of sexual maturation, causing puberty to occur too late or too early. Both scenarios involve a disrupted onset of sex hormone production by the gonads. The age of puberty is multifactorial, involving genetic and environmental components. The normal range for the onset of puberty is now at 8 to 13 years of age and appears to be decreasing for girls. Girls of African descent and Hispanic Latina girls may begin puberty up to 1 year sooner than the average young female. This early onset appears primarily in breast development, not age of menarche, and 5% of white and 50% of all girls will begin puberty before the age of 8. Both precocious puberty and delayed puberty have implications for the child's social interactions and self-esteem. In addition, obesity has been shown to accelerate the onset of puberty, making it difficult to determine the impact of race on pubertal timing. Delayed puberty. About 2% of children in North America experience delayed development of secondary sex characteristics. In girls, the onset of puberty is usually marked by the thelarche, or breast development, which normally begins by age 13. Delayed puberty is diagnosed if there is no breast development by age 13, which is 2 to 2.5 standard deviations greater than the mean age of pubertal onset. Pubic hair may be present because that is largely dependent on adrenal rather than gonadal function. Clinical diagnosis can be made in the absence of menarche by age 15 or 16. Although delayed puberty may have significant psychosocial implications and carries a risk of inadequate skeletal development and mineralization, puberty is a time of rapid skeletal growth, with the majority of bone development and mineralization achieved during adolescence. Estrogen plays a major role in this process, and a lack of circulating estrogen puts individuals at risk for inadequate bone density in adulthood. In most cases, delayed puberty is a psychologic delay in which hormonal levels are normal and the hypothalamic pituitary gonadal axis is intact, but maturation is happening slowly. This psychological delay tends to be familial, less common in girls than boys, and is frequently diagnosed retrospectively once pubertal progression is complete. Although the exact incidence of this constitutional delay in growth and puberty is unknown, the Sentinel and leading study on the issue reported that approximately 30% of girls with delayed puberty ultimately progress through normal and spontaneous puberty. In addition, 19% of girls had functional hypogonadotropic hypogonadism, essentially an underlying condition or illness, responsible for the delayed development. Treatment of FHH, or functional hypogonadotropic hypogonadism, includes a correction of the underlying condition, with a possible initiation of hormone therapy if a prolonged recovery is projected. Treatment for CDGP includes expected management or initiation of hormone therapy in small doses to promote pubertal development and diminish the risk of poor skeletal growth or mineralization. So, here you're taking a look at the frequency and common causes of delayed puberty, other than constitutional delay of growth and puberty. So, here's a good spot to hit pause if you would like to take a closer look at all of that. In other cases, a disruption of the HPG axis is the primary cause of delayed puberty. Human gonadal function is partially controlled by a luteinizing hormone and the follicle-stimulating hormone, the release of which is regulated by the pulsatile secretion of hypothalamic gonadotropin-releasing hormone. The G protein, coupled receptor 54, has been identified as the gatekeeper gene for activation of the GnRH axis. The GPR54 is required for the function of this axis, and data suggest that the ligand kisspeptin-1 may act as a neurohormonal regulator of the GnRH axis. The mechanism of childhood inhibition of GnRH release and activation are poorly understood, but appear to involve feedback inhibition by sex steroids, and presumably other central nervous system pathways. Given the numerous etiologies contributing to the occurrence of delayed puberty, a thorough evaluation should be conducted that includes physical examination and medical and history that specifically targets known contributors to delayed puberty. Laboratory workup may consist of X-ray studies for bone age, measurement of thyroid function, determination of serum levels of prolactin and adrenal and gonadal steroids, radioimmunoassay of plasma gonadotropins, and screening for systemic disorders. Adolescents with high gonadotropin levels require a karyotype to rule out genetic causes, and those with low levels need school imaging to rule out pituitary or other CNS infiltrate or tumors. Treatment of delayed puberty depends on the cause. The goal of treatment is the development of secondary sex characteristics and fertility, and the promotion of bone growth and mineralization. Insufficient sex hormone secretion can be corrected by hormone replacement therapy, such as estrogen. Idiopathic hypogonadotropic hypogonadism is treated with a synthetic GnRH or sex hormone administration, or a combination of both, and may be required lifelong. Bringing us to a precocious puberty. Precocious puberty is a rare event affecting about 29 in 100,000 girls. Precocious puberty is defined as the onset of clinical signs of puberty before the age of 8. However, some endocrinologists have recommended that the criteria be changed to reflect a trend toward an earlier onset of puberty, suggesting that pubertal changes before age 6 in black girls or age 7 in white girls are more reflective of abnormal development. Others are concerned that lowering the age of precocious puberty will miss those individuals who present after the age cutoff with a pathologic underlying condition causing early puberty. There have been many postulated cases and causes of precocious puberty, including alterations in the genetic factors, an increase in obesity, an increase in protein consumption, and the growing prevalence of molecular compounds known as endocrine disruptors in common household products. Besides the premature development of secondary sex characteristics, precocity causes premature closure of the epiphysis of long bones, which results in a lifelong short stature and often carries profound psychosocial consequences. Because precocious puberty can be a sign of pathologic conditions, all cases of precocious puberty require a thorough evaluation. So here in this box, there's a couple different causes of precocious puberty, whether it's the central gonadotropin releasing hormone dependent, the peripheral puberty. So good spot to hit pause and review both. And then here is a recent study of what's new on precocious puberty. If you would like to read that, another good spot to hit pause. Precocious puberty may be partial, complete, or mixed, and can be further categorized into central and peripheral. Central precocious puberty is GnRH dependent and occurs when the HPG axis is working normally but prematurely. Central precocious puberty results from failure of central inhibition of the GnRH pulse generator, often because of CNS abnormalities. Although most cases are idiopathic, mutation in the imprinted gene MKRN3 were recently reported as a cause of central precocious puberty. So here in this box, we're looking at the primary form of precocious puberty, whether it's complete or partial. Again, a good spot to hit pause to see the comparison. And then here at the very bottom portion is the mixed. The diagnosis of central precocious puberty is one of exclusion. Because a CNS lesion may be missed, children with presumed central precocious puberty require long-term surveillance. Peripheral puberty is a GnRH independent and develops when sex hormones are produced by some mechanism other than stimulation by the gonadotropins and is either genetic or exogenous. Sex steroid producing tumors, testotoxicosis, and exposure to exogenous sex steroids are some of those causes. A partial precocious puberty is the partial early development of appropriate secondary sex characteristics alone or in combination. A girl with incomplete precocious puberty might undergo thelarche or pubarche and rarely premature menarche. Premature thelarche can be seen as early as 2 to 24 months of age, and in very small children, breast development often reverses. Thelarche is considered premature if it occurs before the age of 8, but is usually a variation of normal and represents the higher end of prepubertal hormone release. Skeletal growth and menarche in these girls occur during the normal time frame. Premature pubarche tends to occur between ages 5 and 8 years. Premature pubarche is usually the consequence of an early increase in the adrenal androgens that leads to early growth of pubic hair and possibly a transient acceleration in growth and bone maturation that has no significant effect on timing of puberty or final height. Sparse hair growth on the genitalia in the absence of thelarche or menarche does not represent precocious puberty. Growths with premature pubarche and thelarche should be followed through puberty to ensure normal progression. Occasionally, pathologic conditions may contribute to the premature development. Complete precocious puberty refers to the onset and progression of all pubertal features, so thelarche, pubarche, and menarche. Mixed precocious puberty is the virilization of a girl or feminization of a boy, causes the child to develop some secondary sex characteristics of the opposite sex. This condition is usually evident at birth and is rare in older children. So here you're taking a look at different causes of mixed precocious puberty, both female and male. A good spot to hit pause if you need to see the comparison. The diagnosis and cause of premature development are often straightforward. A thorough history and physical exam are done to determine the velocity of the process and to rule out life-threatening CNS, ovarian, or adrenal neoplasms. A history of family occurrence helps exclude tumors. Children with precocious puberty also have a tendency towards obesity. Treatment for all forms of precocious puberty includes identifying and removing the underlying cause or administering appropriate hormones. If needed, precocious puberty can be reversed. Management goals include diagnosing and treatment of intracranial disease, arresting maturation until developmentally appropriate, maximizing eventual adult height, and reducing emotional problems. The most common form, central precocious puberty, is usually treated with potent GnRH agonist analogs, which induce reversible selective suppression of the HPG axis. Because many of these children are obese and childhood obesity is predictive of morbidity in adolescence and adulthood, it is important for clinicians to include assessment and management of obesity as a component of the treatment for central precocious puberty, leading us to disorders of the female reproductive system, hormonal and menstrual alteration. So, primary dysmenorrhea. Primary dysmenorrhea is a painful menstruation associated with the release of prostaglandins in ovulatory cycles, but not with pelvic disease. Roughly 90% of all women experience a dysmenorrhea, 15% of whom are incapacitated for 1 to 3 days because of pain severity. Primary dysmenorrhea usually begins with the onset of ovulatory cycles, with prevalence highest during adolescence. In contrast, secondary dysmenorrhea is related to pelvic pathologic disorders that manifest in later reproductive years and may occur any time in the menstrual cycle. So, what is its pathophysiology? The primary dysmenorrhea is attributed to excessive endometrial prostaglandin production, primarily released during the first 48 hours of the menstruation, when symptoms are the most intense. Women with painful periods produce 10 times as much prostaglandin F, a potent myometrial stimulant and vasoconstrictor, as asymptomatic women. Elevated levels of prostaglandins cause uterine hypercontractility, decreased blood flow to the uterus, and increased nerve hypersensitivity, resulting in pain. Women with dysmenorrhea may have upregulated cyclooxygenase enzyme activity, which contributes to increased synthesis of prostaglandins. Furthermore, leukotriene production is elevated, further contributing to increased levels of pain. Women are more likely to report primary dysmenorrhea if they are younger than 30, have not given birth, have a history of pelvic inflammatory disease, sexual assault, premenstrual syndrome, or sterilization, are heavy tobacco or alcohol users, have a family history of dysmenorrhea, or have a body mass index less than 20. Women who experience severe primary dysmenorrhea appear to have a heightened pain sensitivity. Emerging research suggests an alteration in their pain modulating system, putting them at higher risk for functional pain disorders in later life. Women who are anovulatory because of use of oral contraceptives rarely have primary dysmenorrhea. Secondary dysmenorrhea results from disorders such as endometriosis, endometriitis, adenomyosis, pelvic inflammatory disease, obstructive uterine or vaginal anomalies, uterine fibroids, polyps, tumors, ovarian cysts, pelvic congestion syndrome, or non-hormonal intrauterine devices. So what are the clinical manifestations we would see? The chief symptom of dysmenorrhea is pelvic pain associated with the onset of menses. The pain often radiates into the groin and may be accompanied by backache, anorexia, vomiting, diarrhea, syncope, insomnia, and headaches. The latter symptoms are caused by entry of prostaglandins and prostaglandin metabolites into the systemic circulation. Usually the discomfort associated with primary dysmenorrhea begins shortly before the onset of menstruation and persists for the first 1 to 3 days of menstrual flow. So what is the evaluation and treatment? Primary dysmenorrhea can be differentiated from secondary dysmenorrhea by a thorough history and pelvic exam. Administration of nonsteroidal anti-inflammatory drugs is the treatment of choice because these medications reduce COX enzyme activity and thus prostaglandin production, and NSAIDs work in the majority of women with primary dysmenorrhea and are most effective if started at the first sign of bleeding or cramping. In women who desire contraception or do not respond well to NSAIDs, dysmenorrhea may be relieved with hormonal contraceptives, such as a combined estrogen-progestin pills or the progestin-only intrauterine devices. Hormonal contraception stops ovulation and creates an atrophic endometrium, thereby decreasing prostaglandin synthesis and myometrial contractility. Other treatment approaches with some evidence of effectiveness in pain relief include a transdermal nitroglycerin patches to diminish uterine contractility, local application of heat, acupuncture, transcutaneous electric nerve stimulation, increased physical activity, stress reduction through meditation, additional sleep, and supplements such as thiamine, vitamin E, and herbal treatments. Amenorrhea. Amenorrhea means lack of menstruation, and the most common causes, aside from pregnancy, are chromosomal abnormalities, hypothalamic dysfunction, polycystic ovarian syndrome, hyperprolactinemia, hypothyroidism, malnutrition, and ovarian failure. Primary amenorrhea is the failure of menarche and the absence of menstruation by 13 years, without the development of secondary sex characteristics or by age 15, regardless of the presence of secondary sex characteristics. Primary amenorrhea differs from delayed puberty in that most cases of delayed puberty require only reassurance, but when the diagnosis of primary amenorrhea is reached, a thorough evaluation is needed. Secondary amenorrhea is the absence of regular menses for 3 months, or irregular menses for 6 months in women who have previously menstruated. Pregnancy is the most common condition to exclude before further evaluation. So it's pathophysiology. There are numerous classifications of the etiologies of primary amenorrhea. One approach to understanding the pathophysiology is through the compartmentalization. Compartment 4 disorders include a CNS disorder, in particular the hypothalamic disorders. In some of the congenital syndromes that cause primary amenorrhea, the hypothalamic pituitary ovarian axis is dysfunctional. The hypothalamus is unable to synthesize GnRH, so the pituitary fails to secrete luteinizing and follicle-stimulating hormones. Therefore, the ovary does not receive the hormone signals required to stimulate estrogen production, and ovulation and menstruation do not occur. Because the ovarian hormones are absent, estrogen-dependent sex characteristics do not develop. CNS tumors can cause these disruptions in the hypothalamic pituitary ovarian axis. Other etiologies of amenorrhea caused by the dysfunction in the hypothalamus can include malnutrition, stress, infection, or traumatic brain injury. Compartment 3 disorders are disorders of the pituitary gland, including tumors, some anatomic defects of the CNS, whether congenital or acquired. Impingement on the hypothalamic pituitary unit so as to interfere with or interrupt the secretion of GnRH or FSH and LH. Examples of such defects include hydrocephalus, craniopharyngiomas, and other space-occupying lesions of the CNS. Again, the target organ, the ovaries, do not receive the necessary signals and ovulation and menstruation do not occur. In some cases, these lesions develop between the onset and conclusion of puberty. Therefore, skeletal growth factor may occur and secondary sex characteristics may develop. But sexual maturation is interrupted before menarche. Autoimmune disease, hyperprolactinemia, and some medications also can affect the pituitary and disrupt normal menstruation. Compartment 2 disorders involve the ovary and are often linked with genetic abnormalities. These include gonadal dysgenesis or androgen insensitivity syndromes. Turner syndrome involves the lack of two functional and complete X chromosomes in at least some body tissues, which results in the ovaries lacking gametes and ovarian failure. Without primitive gametes and follicles, follicular development and estrogen secretion cannot occur. Lack of estrogen accounts for failure of secondary sex characteristic development and amenorrhea, although there are high levels of circulating FSH and LH. As mentioned previously, an individual with AIS is male genetically and their body produces testosterone. However, their cells do not have the receptors for testosterone, which is needed to activate the development of male genitalia. Because target tissue have estrogen receptors, most individuals with AIS have female external genitalia and female secondary sex characteristics. With the exception of a small vagina. Internal female genitalia are absent, accounting for amenorrhea and infertility. Compartment 1 disorders are anatomic defects of the outflow tract associated with the primary amenorrhea. They include congenital absence of the vagina and uterus and congenital uterine hypoplasia. Genetically, normal females without a uterus or a vagina usually have normal ovarian function. Therefore, skeletal growth occurs and secondary sex characteristics develop in the proper sequence. But menstruation does not occur because the uterus is too small or malformed to produce substantial endometrium. So, clinical manifestations. The major clinical manifestation of primary amenorrhea is the absence of the first menstrual period. The cause of amenorrhea determines whether secondary sex characteristics and height are affected. So, what is our evaluation and treatment? Diagnosis of primary amenorrhea is based on the history and physical exam and determination of whether secondary sexual characteristics are present or absent. Absence of these sexual characteristics indicates that a female has never been exposed to estrogen. If ovarian steroid hormones levels are low, the individual has the appearance of an immature female. Physical exam may show structural or physiologic alterations of the reproductive tract as outlined at the beginning of the chapter. Lab studies may be required to document karyotype, abnormal levels of gonadotropins, thyroid and prolactin levels, and ovarian hormones. Diagnostic imaging is used to document structural abnormalities. Treatment involves correction of any underlying disorders and use of hormonal replacement therapy to induce the development of secondary sex characteristics as necessary. Although surgical alteration of the genitalia may be undertaken to correct structural abnormalities, surgery should be delayed until the individual can make a truly informed decision. Hormonal manipulation or embryo transplantation may make pregnancy possible for women with primary amenorrhea who have a normal uterus. Secondary amenorrhea. A wide variety of disorders and physiologic conditions are associated with secondary amenorrhea. Besides disease, secondary amenorrhea can be triggered by dramatic weight loss, whether the loss results from malnutrition or excessive exercise. Secondary amenorrhea is common during early adolescence and the perimenopausal period, pregnancy, and lactation. The most common causes are the thyroid disorder, hyperprolactinemia, HPO interruption secondary to excessive exercise, stress, weight loss, and polycystic ovarian syndromes. The factors leading to secondary amenorrhea also may cause primary amenorrhea in a young woman who has not begun to menstruate. So, pathophysiology. The cause of secondary amenorrhea is summarized in the following figure. In women with normal ovarian steroid hormone levels, secondary amenorrhea may be caused by structural abnormalities, Asherman syndrome, or removal of the uterus. In women with elevated ovarian steroid hormone levels, inhibited ovulation leads to amenorrhea. An excess of ovarian hormone disrupts feedback relationships within the HPO axis, preventing ovulation. Depressed ovarian hormone levels, which are associated with a variety of clinical disorders, also cause amenorrhea by preventing ovulation. Lack of ovulation, termed anovulation, may result from increased levels of prolactin, decreased levels of gonadotropins, irregular secretion of gonadotropins, or abnormally low levels of CNS neurotransmitters. Any of these variables alters the feedback effect that the ovarian hormones have on the hypothalamus and the pituitary. So here's a good spot if you need to hit pause so that you can see the diagnosis of amenorrhea. High levels of prolactin are physiologic during lactation because it increases milk production and suppresses ovulation, preventing closely spaced pregnancies. However, high levels of prolactin not related to lactation are abnormal and will disrupt the menstrual cycle. Hyperprolactinemia may be indirect effects that lead to decreased secretion of GnRH by the hypothalamus. The result is a reduction in FSH and LH secretion, followed by anovulation and secondary amenorrhea. Hyperprolactinemia should be diagnosed through blood testing for both normal size and large molecular prolactin. Hyperprolactinemia can have many causes, including medication side effects, hypothyroidism, excessive nipple stimulation, and pituitary tumors. So, our clinical manifestations, therefore. The major manifestation of secondary amenorrhea is the absence of menses after previous menstrual periods. Infertility, vasomotor flushes, vaginal atrophy, acne, osteopenia, and hirsutism, or abnormal hairiness, also may present, depending on the underlying cause of amenorrhea. The evaluation and treatment, therefore. Pregnancy is the most common cause of amenorrhea and must be ruled out before other evaluations. The menstrual cycle also may stop or become irregular in response to stress, extreme exercise, large dietary changes, eating disorders, or sleep abnormalities. A thorough history of the woman's life and stressors is important in assessing amenorrhea. Diagnosis of the organic cause of secondary amenorrhea involves the identification of underlying hormonal or anatomic alterations. A woman with secondary amenorrhea and normal secondary sex characteristics should have a complete history and physical exam. After ruling out pregnancy and performing an in-depth history, initial laboratory evaluation includes measuring the thyroid stimulating hormone and prolactin levels. Elevated prolactin levels warrant further investigation, including a complete medical history, TSH level measurements, and brain CAT scan or MRI if warranted. If these initial tests are normal, further testing would include measurement of gonadotropins, your FSH, estrogen, and testosterone, ultrasonography, and the outflow tracts, and the ovaries or adrenal MRI, or a combination of both. So here is another good spot to hit pause so that you can see the different causes of secondary amenorrhea. Treatment of amenorrhea depends on the cause and the woman's psychologic need for cycle stability. Treatments may include replacing deficient hormones or correcting underlying pathologic conditions. A diagnosis of PCOS might be treated with an insulin sensitizing agent, such as metformin, as well as an ovulation inducing drugs if fertility is desired. Some treatments for amenorrhea prevent pregnancy, whereas others may restore fertility. The choice of treatment may be influenced by the woman's childbearing plans. After pathologic conditions have been corrected and the menstrual cycle stabilizes, fertility may return. Occasionally, women with secondary amenorrhea may need additional ovulation-inducing drugs to assist conception, whereas others are able to conceive naturally. Which brings us now to the opposite end, the abnormal uterine bleeding. Menstrual irregularity or abnormal bleeding patterns, which account for roughly 33% of all gynecologic visits. For many years, these abnormal patterns were poorly and inconsistently defined. And in 2010, the International Federation of Gynecology and Obstetrics developed a new system of definition and classification that has been adopted in the United States. The outdated definition remains commonly used and are included in this table. Abnormal uterine bleeding is bleeding that is abnormal in duration, volume, frequency, or regularity, and has been present for the majority of previous 6 months. AUB may be acute or chronic and is classified by the cause of bleeding using an internationally recognized Palm-Cohen system. Palm-Cohen stands for polyp, adenomyosis, myoma, and malignancy and hyperplasia, and coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. The first group, PALM, consists of disorders of tissue or structure that are diagnosed through imaging or biopsy. The second group, COAN, consists of non-structural causes of AUB. More than one etiology may contribute to a woman's AUB. So, here is a table regarding abnormal uterine bleeding. Again, it's a good spot to pause so you can see the outdated terminology and its definitions with its current terminology. And then here is a good spot to hit pause so that you can see the differences between your palm and your coin. In premenstrual or menopausal women, any bleeding is considered abnormal. For reproductive aged women, normal uterine bleeding is every 28 days, with variation up to 7 days. Therefore, bleeding more frequently than every 21 days or less frequently than every 35 days is considered abnormal. Menstrual bleeding for longer than 7 days also is considered abnormal. Studies show that 10 to 30% of women will experience AUB in their lifetime. Roughly one-third of all gynecologic visits for premenopausal women and three-quarters of all visits for perimenopausal and menopausal women are because of AUB. AUB, under all etiologies, is the leading reason for a hysterectomy in the United States. Perimenopausal women are most commonly affected by AUB. So what is its pathophysiology? The majority of abnormal uterine bleeding is due to lack of ovulation. Normal, regular periods are the result of a complex interplay between the hypothalamus, pituitary, ovary, and uterine endometrium. Disruptions in the system can affect the amount and structure of the uterine endometrium, causing it to shed irregularly or heavily. Although an ovulatory AUB may occur at any time during the reproductive years, it tends to occur in adolescents and perimenopausal women more frequently because women at the edges of the reproductive years are more likely to ovulate irregularly. The formation of a follicle and its rupture to release an ovum are important components of the menstrual cycle. As the follicle forms, it produces estrogen, which causes proliferation of the endometrium. Following ovulation, the remaining portion of the follicle, known as the corpus luteum, releases progesterone. The progesterone acts on the proliferating endometrium to limit growth and cause changes in the vasculature of the endometrium, which limits bleeding during endometrial shedding. If a follicle forms but never releases the ovum, the follicle may continue to produce estrogen, encouraging endometrial proliferation because the normal 14-day time window. In addition, the lack of progesterone causes the thickened endometrium to be unable to shed in a predictable fashion without excess blood loss. Women who fail to ovulate experience irregularities in their menstrual bleeding related to the lack of progesterone and, in some cases, an excess of estrogen. Many conditions are associated with irregular ovulation, including physiologic changes of aging, PCOS, in which follicles begin to form but never reach the maturation and rupture, obesity, because adipose tissue excretes estrogen, which can suppress the HPG axis, hyperthyroidism and hypothyroidism, and estrogen secreting ovarian neoplasms. Without ovulation, menstrual flow may become irregular, excessive, or both, resulting from a large quantity of tissue available for bleeding and the random breakdown of tissue that results in exposure of vascular channels. In the absence of adequate progesterone levels, usual endometrial control mechanisms are missing, such as vasoconstrictive rhythmicity, tight coiling of spiral vessels, and orderly prolapse, and stasis does not occur. Unopposed estrogen induces a progression of endometrial responses beginning with proliferation, hyperplasia, and adenomatous hyperplasia. Over a course of many years, unopposed estrogen may end up with atypia and carcinoma. Abnormal menstruation, bleeding, also can result from defects of the corpus luteum, resulting in progesterone deficiencies, or from abnormalities of the uterus or cervix, such as endometrial polyps, uterine fibroids, or even uterine or cervical cancers. Coagulation defects also can cause heavy and abnormal uterine bleeding and should be suspected in younger women with a history of extensive bruising or bleeding during dental procedures. Iatrogenic AUB can be caused by intrauterine devices or long-acting contraceptive implants or medications such as anticoagulants, steroids, digitalis, phenytoin, or hypothalamic depressants. Clinical manifestations. Abnormal uterine bleeding is characterized by unpredictable and variable bleeding, especially during perimenopause. Abnormal bleeding also may cause and involve increased menstrual flow and the passage of large clots, leading to excessive blood loss. Excessive bleeding can lead to an iron deficiency anemia and associated symptoms of fatigue, shortness of breath. AUB may cause pain, decreased productivity, and sexual dysfunction. So, what is its evaluation and treatment, therefore? The first step in assessing abnormal bleeding is to determine the cause of the bleeding. If an organic cause can be found, the focus is on eliminating the pathologic disorder or mitigating its effects. To determine the cause of bleeding, a complete and thorough history and physical exam, including a transvaginal ultrasound, is needed. The woman's age and risk factors. for other abnormal conditions are important in assessing the likely cause of the bleed. Initial lab evaluation includes a complete blood count, measurements of the thyroid-stimulating hormone levels, and coagulation studies, if indicated. If no cause can be found, it is usually assumed that the bleeding is caused by a lack of regulatory ovulation. Treatment goals include preventing and controlling abnormal bleeding, identifying underlying disease, and inducing regular menstrual cycles. Treatment varies greatly by the age of the woman and her desire for current and future fertility plans. NSAIDs, such as ibuprofen and naproxen, are often first-line treatment for excessive menstrual bleeding because they reduce prostaglandin synthesis within the endometrial tissue, which causes vasoconstriction and decreased menstrual blood loss. NSAIDs can reduce menstrual bleeding significantly with minimal side effects. For best effect, they should be taken in the few days preceding the beginning of the menstrual period and be continued through the days of heaviest bleeding. NSAIDs are not as effective in controlling menstrual blood loss as hormonal therapies, but they are readily available without a prescription. Young women and those of childbearing age with abnormal bleeding are often treated with hormonal therapies to override the HPG axis and mimic normal menstrual bleeding or suppress it entirely. Common treatments include oral contraceptive pills that contain both estrogen and progesterone, long-term treatment with medroxyprogesterone, and the levonorgestrel intrauterine devices. The LNG IUD has a dual indicated from the FDA for both birth control and suppression of abnormal menstrual bleeding. The device releases a steady amount of progesterone into the uterus to stabilize and suppress the uterine lining. In addition, the progesterone suppresses the HPG axis, preventing ovulation. There is no strong evidence to differentiate whether estrogen and progesterone or progesterone alone is superior in the treatment of abnormal uterine bleeding. The woman should be allowed to select a treatment regimen that is compatible with lifestyle and needs. Women who are greater than 35 years of age, old, and smoke cigarettes may not be candidates for oral contraceptive pills because the estrogen increases their risk of cardiovascular incidents, such as myocardial infarction. However, the LNG IUD can still be used because it contains only progesterone. The LNG IUD is widely used as a first step in controlling a perimenopausal bleeding because it can be inserted in a clinic office and is easily removed. The LNG IUD decreases blood loss by 86 to 97% by decreasing endometrial proliferation and has similar success rates as more invasive procedures, such as an ablation or hysterectomy. Women who do not wish to have future pregnancies also can opt for treatments that permanently suppress their uterine lining. These treatments include ablation, where the lining is burned to prevent future proliferation of the endometrial cells, and complete removal of the uterus in hysterectomy. If a woman is menopausal and has had a menstrual period for more than 1 year, all vaginal bleeding should be investigated to rule out uterine and other cancers. Appropriate initial evaluation includes ultrasound and endometrial biopsy to exclude uterine cancers. Women with coagulation disorders may have excessive menstrual bleeding because they have a predisposition to bleeding or because they are taking anticoagulant medications to overcome a genetic predisposition to excessive clotting. To control their menstrual bleeding, these women can opt for cycle suppression. Provision of birth control for these women is important because pregnancy may be a risk to their health. Which brings us to the polycystic ovary syndrome. Polycystic ovary syndrome, or PCOS, is the most common cause of anovulation and ovulatory dysfunction in women. Although PCOS presents in a variety of different ways, it is defined as having at least two of the following three features: irregular ovulation, elevated levels of androgens, and the appearance of polycystic ovaries on ultrasound. Polycystic ovaries do not have to be present to diagnose PCOS, and conversely, their presence alone does not establish the diagnosis. Diagnosis is one of exclusion, and all other disorders potentially responsible for the clinical findings also must be ruled out, including thyroid dysfunction, hyperprolactinemia, and congenital adrenal hyperplasia. PCOS is associated with metabolic dysfunction, including dyslipidemia, insulin resistance, and obesity. PCOS remains one of the most common endocrine disturbances affecting women, especially young women, and is a leading cause of infertility in the United States, where prevalence rates are estimated at between 5 and 15% of women. There is a strong genetic component to PCOS, and various features of the syndrome may be differentially inherited. Confusing the issue is the frequency, expression, and timing of PCOS symptoms and diagnosis. From 22 to 30% of women who have polycystic ovaries on the ultrasound, with 80% having one or more symptoms of the syndrome. 80% of women with normal ovaries also experience one or more PCOS symptom. Signs and symptoms of women with PCOS may change over time, with metabolic syndrome becoming more prominent with age. In addition, polycystic ovaries may be associated with Cushing's syndrome, acromegaly, premature ovarian failure, simple obesity, congenital adrenal hyperplasia, thyroid disease, androgen-producing adrenal tumors, or ovarian tumors, and syndromes with hyperprolactinemia. So here you're taking a look at a couple different pictures of polycystic ovaries. So what is its pathophysiology? Polycystic ovaries, although the underlying cause of PCOS is unknown, a genetic basis is suspected. Initial identification of genes involved in steroid biosynthesis, androgen biosynthesis, and insulin receptors within the ovary indicates genetic involvement. No single factor fully accounts for the abnormalities of PCOS. A hyperandrogenetic state is a cardinal feature in the pathogenesis of PCOS. However, glucose intolerance, insulin resistance, and hyperinsulinemia often run parallel to and markedly aggravate the hyperandrogenic state, thus contributing to the severity of the signs and symptoms of PCOS. Women with PCOS are 3 times as likely to have insulin resistance. This number is even higher among obese women, who account for roughly 60% of women with PCOS. Insulin stimulates androgen secretion by the ovarian stroma and reduces serum sex hormone binding globulin directly and independently. The net effect is an increase in free testosterone levels. Excessive androgens affect follicular growth, and insulin affects follicular decline by suppressing apoptosis and enabling follicles to persist. Further, there appears to be a genetic ovarian defect in PCOS, which makes the ovary either more susceptible to or sensitive to insulin stimulation of androgen production. Recent research suggests that decreased intra-ovarian receptors for estrogen receptor alpha or insulin-like growth factor 1, increased leptin levels, or direct infrared radiation within the selective ovarian cells may contribute to this phenomenon. Intrauterine and early childhood environments may also contribute to the development of PCOS. So here you're taking a look at insulin resistance and the hyperinsulinemia in polycystic ovarian syndrome. A good spot to hit pause, as well as if you would like to read what's new in regards to PCOS. Weight gain tends to aggravate symptoms, whereas weight loss may ameliorate some of the endocrine and metabolic events, and thus decrease symptoms. Women with PCOS tend to have an increased leptin level. Leptin influences the hypothalamic pulsatility of GnRH and may consequently interaction along with the entire HPO axis. Feedback from the polycystic ovary is distributed because of changes in ovarian steroid and nonsteroidal hormones. In PCOS, there is a dysfunction in ovarian follicle development. Inappropriate gonadotropin secretion triggers the beginning of a vicious cycle that perpetuates anovulation. Typically, levels of FSH are low or below normal, and LH levels and LH bioactivity are elevated. An increased frequency of GnRH pulses appears to cause increased frequency of LH pulses. Persistent LH elevation causes an increase in the levels of androgens. Androgens are converted to estrogen in peripheral tissue, and increased testosterone levels cause a significant reduction in SHBG, which in turn causes increased levels of free estradiol. Elevated estrogen levels trigger a positive feedback response in LH and a negative feedback response in FSH. Because FSH levels are not totally depressed, new follicular growth is continuously stimulated, but not to full maturation and ovulation. The accumulation of follicular tissue in various stages of development allows an increased and relatively constant production of steroid in response to gonadotropin stimulation. Thus, PCOS is characterized by excessive production of both androgens and estrogens. Increased androgen secretion by the ovaries contributes to premature follicular failure and persistent anovulation. In turn, persistent anovulation causes enlarged polycystic ovaries, characterized by a smooth, pearly white capsule that we saw in the picture. This characteristic appearance is caused by an increase in surface area and increased volume of up to 2.8 times, doubling of growing and atretic follicles, thickening of the tunica by 50%, increasing cortical stromal thickening by 1/3, and a fivefold increase in the subcortical stroma, and escalating hyperplasia. With advancing age, menstrual irregularities may improve, while the incidence of metabolic syndrome and type 2 diabetes mellitus increases. Women with PCOS have a 3 times greater incidence of uterine cancer in later life than normal cycling women related to the anovulatory lack of progesterone in PCOS. Without treatment for anovulation, women with PCOS have a 9% lifetime risk for endometrial cancers related to the effects of unopposed estrogen. So, its clinical manifestations, therefore. Clinical manifestations of PCOS usually appears within 2 years of puberty, but may present after a variable period of normal menstrual function and possibly pregnancy. The symptoms are related to anovulation, hyperandrogenism, and insulin resistance, and include dysfunctional bleeding or amenorrhea, hirsutism, acne, acanthosis, nigricans, and infertility. Roughly 60% of women with PCOS are obese. The following box contains a list of signs and symptoms, a summary of hormonal disturbances, and complications of PCOS. In addition, women with PCOS are more likely to experience sleep apnea than unaffected women, which results in impaired sleep and may reduce their overall quality of life. So here's a good spot to pause to review the clinical manifestations of polycystic ovary syndrome, the presenting signs and symptoms, as well as the hormonal disturbances, and then the possible late sequelae. And then there's also some other factors. So, The evaluation and treatment, therefore. Diagnosis of PCOS is based on evidence of androgen excess, chronic anovulation, and sonographic evidence of polycystic ovaries with at least two of the three criteria present. Tests for impaired glucose tolerance are recommended. As stated, polycystic ovaries do not have to be present, and conversely, their presence alone does not establish the diagnosis. Because of the normalcy of anovulatory cycles in the adolescence, evidence of hyperandrogenism must be present before PCOS is diagnosed in an adolescent female. Goals of treatment include reversing signs and symptoms of androgen excess, instituting cyclic menstruation, restoring fertility, and ameliorating any associated metabolic or endocrine, or both, disturbances. First-line treatment of PCOS includes a combined oral contraceptive for management of symptoms and to establish regular menses. For those women with PCOS who are overweight or obese, lifestyle modifications including regular exercise and weight loss also are considered first-line treatments. Women with insulin resistance or those women who do not respond to contraceptive therapy may benefit from an insulin sensitizer metformin. If COCs are not used and pregnancy is not desired, progesterone therapy is recommended to oppose estrogen's effects on the endometrium and as a means to initiate monthly withdrawal bleeding. For overweight or obese infertile women desiring pregnancy, lifestyle modifications are the first line therapy. Even a small reduction of weight loss restores ovulation and increases insulin sensitivity by up to 71% in obese women with PCOS. Reduction of insulin by loss of abdominal fat appears crucial in restoring ovulation. Clomiphene citrate, an anti-estrogen, can be used to facilitate ovulation and can be combined with metformin for improved outcomes. Management of PCOS is a nearly lifelong process because the effects of syndrome persists past childbearing years. Appropriately, primary care is needed to control the systemic features of PCOS so that it has minimal impact on a woman's life and health outcomes. Bringing us to premenstrual disorders. Premenstrual syndrome, or PMS, and premenstrual dysphoric disorders, PMDD, are the cyclic recurrence of distressing physical, psychologic, or behavioral changes that impair interpersonal relationships or interfere with usual activities and resolve with menstruation. The prevalence of PMS and PMDD is difficult to determine, in part because of the wide-ranging nature of accepted symptoms, but it is estimated that 12% of menstruating women are significantly affected by these disorders, with 3 to 8% meeting criteria for PMDD. Symptoms of PMS and PMDD begin after ovulation during the luteal phase and persist up to 4 days into the menstrual cycle. So the pathophysiology. The psychologic and physiologic changes of PMS and PMDD occur in the luteal phase of the ovulatory cycle and are linked with the complex hormonal changes of the menstrual cycle. There are many theories on the cause of the disorder, including the drop in estrogen level following ovulation and the immediate rise in progesterone level interact with hormones and neurotransmitters to cause symptoms. However, the mechanisms involved are not known and may include an individual's sensitivity to hormonal levels. Furthermore, the neurotransmitter serotonin, gamma-aminobutyric acid, and noradrenaline may have mediating or moderating roles on symptom manifestation. These neurotransmitters have demonstrated interactions with estrogen and progesterone, and all of these are neuroactive, with known mood and behavioral effects, including negative mood, irritability, aggression, and impulse control. Sex steroids also interact with the renin-angiotensin-aldosterone system, which explains some PMS/PMDD signs and symptoms. There is a predisposition of PMS to occur in families, perhaps because of genetic or shared environment. However, no genes have been identified. Bringing us to clinical manifestations. The pattern of symptom frequency and severity is more important than specific complaints. Nearly 300 physical, emotional, and behavioral symptoms have been attributed to PMS/PMDD. Emotional symptoms, particularly depression, anger, irritability, and fatigue, have been reported as the most prominent and most distressing, whereas physical symptoms seem to be the least prevalent and problematic. Physical symptoms include breast tenderness, abdominal bloating, headache, and swelling of extremities. In addition, underlying physical or psychologic disease may be aggravated premenstrually and must be diagnosed and treated independently from PMS or PMDD. Its evaluation and treatment, therefore. Diagnosis of PMS/PMDD is based on prospective health history and symptoms, with completion of a 2-month prospective symptom questionnaire, which is considered the gold standard. Diagnostic criteria for PMDD are presented in the following box. Because the cause of PMS is not known and cannot be reduced to a single biologic explanation, and because the occurrence and severity of PMS are mediated by the lifestyle and social and psychologic factors, treatment for PMS is symptomatic. Initial treatment focusing on validating the premenstrual experience, relieving the physical and psychologic symptoms, and eliminating contributing factors, as well as treatment of coexisting or underlying disorders. So here's a good spot to hit pause if you want to look at all the diagnostic criteria for PMS and PMDD disorders. I'll see if I can put it all into one area. Almost. Non-pharmacologic methods are first-line treatments for women who have mild symptoms or do not desire medication. These include acupuncture, herbal or mineral supplements, and lifestyle modification. Lifestyle changes include regular exercise, appropriate sleep, and stress reduction during the premenstrual period. Calcium supplementation has been shown to decrease symptoms, although it is not as effective as pharmacologic treatment. Vitamin B6, vitamin D, and vitamin E also have been studied, but sample sizes are small and no clear evidence exists regarding their efficacy. Several studies of the herbal preparation Vitex agnus castus and Ginkgo biloba have shown a reduction in symptoms as compared with a placebo. Finally, cognitive behavior therapy, which assists individuals in identifying and restructuring thought or behavior patterns, have been effective in improving coping in the context of other chronic conditions. Several small trials have shown positive effects in the individuals with PMS and PMDD. If non-pharmacologic methods fail or symptoms are severe, medical therapy is indicated. Two major forms of pharmacologic treatment include the use of hormonal cycle regulation and the use of selective serotonin reuptake inhibitors as antidepressants. If a woman does not desire immediate fertility, COCs may regulate her menstrual cycle and decrease levels of circulating steroidal hormones. The oral contraceptive pill containing estrogen and progesterone has shown benefits in decreasing PMS and PMDD, in particular, bloating, breast tenderness, and headaches. Oral contraceptive pills also can be used continuously for up to 3 months to decrease the frequency of menstrual periods and PMS/PMDD. The SSRIs have been well studied for the use of prevention and treatment of PMS and PMDD, and are the first-line therapy for severe symptomatology. They are used to treat psychologic symptoms and also have a beneficial effect on physical symptoms. These medications are effective when taken either continuously or limited to the luteal phase of the menstrual cycle. They may have undesired side effects, such as nausea, fatigue, and a decreased libido, but they are largely dose dependent. Your serotonin norepinephrine reuptake inhibitors, or SNRIs, and the antipsychotic medication Seroquel also have been shown to improve symptomatology. However, more research is still needed, leading us to the infection and inflammation. Infections of the genital tract may result from exogenous or endogenous microorganisms. Exogenous pathogens are most often sexually transmitted. Endogenous causes of infection include a microorganism that are normally present in the vagina, bowel, or vulva. Infection occurs if these microorganisms overproliferate or migrate to a new location, or if the immune system and other defense mechanisms become impaired. A number of skin disorders also can affect the vulva. They include reactive dermatitis, contact dermatitis, psoriasis, and impetigo. Many infectious disorders that affect the vulva and vagina are sexually transmitted. These disorders are described in Chapter 27. That brings us to the pelvic inflammatory disease, or PID. Pelvic inflammatory disease is an acute inflammatory process caused by infection and affects an estimated 800,000 to 1 million women per year. PID may involve any or all organs in the upper genital tract, the uterus, fallopian tubes, or ovaries, and in its most severe form, the entire peritoneal cavity. Inflammation of the fallopian tubes is termed salpingitis. Inflammation of the ovaries is called oophoridis. Most cases of PID are caused by sexually transmitted microorganisms, such as chlamydia and gonorrhea, that migrate from the vagina to the uterus, fallopian tubes, and ovaries. The ascension of these microorganisms into the upper genital tract may be facilitated by disruptions in the normal vaginal flora. So here you're taking a look at a couple pictures that show salpingitis. Pelvic inflammatory disease is very common in the United States and around the world, and has both immediate and long-term health implications for women. Infections of the upper reproductive tract causes changes in the delicate cells of the fallopian and uterine tubes, which can affect fertility and increase the risk of ectopic pregnancies. So what is its pathophysiology? The development of upper genital tract infections is mediated by the failure of a number of defense mechanisms that usually are effective in preventing PID. The virulence of the organism, size of the inoculum, and defense status of the individual determine whether an infectious process results. Both gonorrhea and chlamydia are the main infectious causes of PID. These microorganisms can affect the vagina and cervix, but do not usually ascend into the upper genital tract and cause PID. However, when the normal vaginal microbial flora is disrupted, the pathogens can more easily ascend through the cervix. So here you're taking a look at the ascension of the pelvic inflammatory disease. Many anaerobic bacteria have been implicated in increasing the risk of PID because they can alter the pH of the vaginal environment and may decrease the integrity of the mucus blocking the cervical canal. Bacterial vaginosis is present in up to 66% of women with PID, and other anaerobes such as bacteroides, Gardnerella vaginalis, and Haemophilus influenza, and genital tract mycoplasmas are frequently isolated from women with PID. E. coli may contribute to pelvic inflammation and infection in older women. Therefore, although gonorrhea and chlamydia are the main pathogens in PID, the disease is really polymicrobial and is treated with a broad spectrum of antibiotics to ensure that all the causative agents are eliminated. Once the infection is established within the uterus and the fallopian or uterine tubes, the infection may induce changes in the columnar epithelial lining, the upper reproductive tract, causing permanent damage. The resultant inflammatory responses causes localized edema and occasionally obstruction or necrosis of the area. Gonorrhea, gonococci attach to the fallopian tubes and excrete a substance toxic to the tubal mucosa, causing further inflammation and damage. Chlamydia enters the tubal cells and replicates, bursting the cell membranes as it reproduces, causing permanent scarring. Gonorrhea and chlamydia can spread to the abdominal cavity through the opening of the fallopian and uterine tubes. Other mechanisms that may contribute to PID include the lymphatic drainage with parametrial spread of the infection, sexual intercourse, and retrograde menstruation. The rate of mortality from PID in the United States is fairly low. However, PID infection results in permanent changes to the ciliated epithelium of the fallopian or uterine tubes. Studies suggest that approximately 20 to 50% of women with PID subsequently struggle with infertility. A recent study found that one episode of mild subclinical PID resulted in a 40% decrease in later pregnancy rates, and multiple episodes of PID further increased the risk of infertility. Scarring caused by PID greatly increases the risk of later ectopic pregnancy by up to 10-fold because the mobility of an egg through the fallopian tubes is slowed by damaged cilia. Scarring and adhesion also can result in chronic pelvic pain and, potentially, an increased risk of later uterine cancer. So, its clinical manifestations, therefore. The clinical manifestations of PID vary from sudden, severe abdominal pain with fever to no symptoms at all. An asymptomatic cervicitis with or without discharge may be present for some time before PID develops. The first sign of the ascending infection may be the onset of low bilateral abdominal pain, most often characterized as dull and steady with a gradual onset. Symptoms are most likely to develop during or immediate after menstruation. The pain of PID may worsen with walking, intercourse, or other activities involving movement. Other manifestations of PID include dysuria, dyspareunia, and irregular bleeding. So, what is its evaluation and treatment, therefore? PID often has limited or vague clinical symptoms, leading to undertreatment and subsequent long-term health effects. Because PID is a substantial health risk to women, the Center of Disease Control and Prevention encourages clinicians to consider PID as a likely diagnosis when a sexually active woman has abdominal or pelvic tenderness and one of the following: cervical motion tenderness, uterine tenderness, or adnexal tenderness. The following box lists the diagnosis criteria for PID. No lab tests or studies are needed to begin treatment. However, additional information can improve the specificity of diagnosis. Abdominal pain in women can have many causes, and it is important to rule out other diagnoses. However, further studies to rule out other diagnoses can be done while treating for PID. So here again is a good spot to hit pause so you can see the diagnostic criteria for PID. So there is a minimum criteria and additional criteria that increases specificity to the diagnosis, and then a definitive criteria. And then you have a diagnostic algorithm for PID. Because of the significance of complications of PID, Rapid treatment is recommended even before the causative pathogen can be identified. Because treatment is empiric, it is needed to be effective against a broad range of pathogens, especially chlamydia, gonorrhea, and anaerobic bacteria. Treatment is usually conducted in an outpatient setting, unless the woman has symptoms of advanced infection, or cannot take oral medications, or is pregnant, or if the pathogen or pathologic condition cannot be excluded. The CDC recommends outpatient regimen as shown in the following box. Although alternative treatment regimens are available, the growing antibiotic resistance of gonorrhea limits antibiotic choices. The CDC is closely monitoring gonorrhea's antibiotic sensitivity and updates treatment guidelines periodically to reflect new information. The most up-to-date treatment guidelines are found on the CDC's website. So, the CDC current recommendation is ceftriaxone 250 milligrams IM in a single dose, doxycycline 100 milligrams orally twice a day for 2 weeks, and that's either with or without Flagyl 500 milligrams orally twice a day for 2 weeks. I know I normally don't read these little boxes, but this is one of the bigger ones that's not too easily overread. So, sexual partners of women with PID also should receive treatment, even if they are asymptomatic. Women receiving treatment should be re-evaluated by their care provider in 3 days to ensure that the antibiotic treatment is effective. Because women with a history of PID are at increased risk for ectopic pregnancies, they should seek care as soon as they know they are pregnant, because ectopic pregnancy is a major cause of maternal mortality. Additionally, all sexually active women younger than the age of 25 should receive minimal annual screening for chlamydia and gonorrhea, as well as women older than the age of 25 with a new sexual partner. More than one sexual partner, a partner who has been diagnosed with a STI, or a partner with more than one sexual partner. That brings us to vaginitis. Vaginitis is the irritation of the vagina that can be caused by a variety of microorganisms, irritants, or pathologies, or by a disruption of the normal flora of the vagina. Vaginitis is characterized by complaints of vaginal irritation, itching, burning, odor, or abnormal discharge. Clinically, an increase in the number of white blood cells or abnormal or foreign cells, or both, is observed on a saline vet prep examination. The major causes of vaginitis are overgrowth of normal flora, STDs, and vaginal irritation related to low estrogen levels during menopause. The primary form of vaginitis are vulvovaginal candidiasis, or yeast vaginitis, bacterial vaginosis, or trichomoniasis. The irritation of vaginitis is related to an alterations in the vaginal environment, including changes in the skin integrity, immune reaction, and particularly vaginal pH. The pH of the vagina needs and depends on cervical secretions and the presence of normal flora that help maintain an acidic environment. A neutral or alkaline pH normally occurs before puberty, after menopause, and during pregnancy. The acidic nature of the vaginal secretions during the reproductive years provides protection against a variety of sexually transmitted pathogens and establishes a healthy microflora in the vagina. Changes in the vaginal pH may predispose a woman to infection. Many substances and conditions can alter vaginal pH, including exposure to soaps, spermicides, douches, feminine hygiene sprays, semen, or deodorant menstrual pads or tampons, and conditions associated with increased glycogen content of vaginal secretion, such as pregnancy or diabetes. Antibiotics can destroy normal vaginal flora, facilitating overgrowth of Candida albicans, causing a yeast vaginitis. Normally, Vaginal discharge is clear, milky, or cloudy secretion with a slippery or clumpy texture. It is non-irritating, has a mild smell, and may yellow after drying. Throughout the menstrual cycle, the amount of and texture of a woman's discharge changes in response to hormonal fluctuation. Vaginal secretions increase at the time of ovulation, during pregnancy, and with sexual arousal just before menstruation. Vaginal discharge becomes thick and sticky. Unusual changes in the amount, color, or texture of the vaginal discharge may signal an infection, especially if the discharge is copious, malodorous, or irritating. Irritation of the vaginal area may be the result of many factors. Diagnosis of the cause of vaginitis is based on history, physical exam, and examination of the discharge by VetMat. Treatment by physical symptoms alone is inadequate. Treatment involves developing and maintaining an acidic environment, relieving symptoms, and administering antimicrobial or antifungal medications to eradicate the infectious organism. If the infection can be sexually transmitted, a woman's partner also will need treatment. Research suggests that probiotics, especially Lactobacillus rhamnosus, can encourage normal vaginal flora and decrease the incidence of vaginitis in women at risk for vaginitis. Cervicitis. Cervicitis is a nonspecific term used to describe inflammation of the cervix. The CDC defines cervicitis as having two diagnostic signs: a purulent or mucopurulent discharge from the cervical os, or endocervical bleeding, or a combination of both, induced by gently introducing a cotton swab into the cervix. Cervicitis can have infectious or non-infectious causes, with roughly half of all cases caused by sexually transmitted pathogens. Chemicals and substances introduced into the vagina can cause cervicitis, in addition to disrupting the normal vaginal flora. Age and risk factors are important in assessing a woman with cervicitis. Younger women are at risk for sexually transmitted infections and should be tested for chlamydia, gonorrhea, and trichomonas. Older women with cervicitis may have STIs but are more likely to have irritation from abnormal vaginal flora related to low vaginal estrogen levels. In addition, where no infectious agent is found, pharmacologic therapy may still be effective. Surgery may be an option or necessary for unresponsive and chronic cases. Mucopurulent cervicitis usually is caused by one or more sexually transmitted pathogen, such as trichomonas, gonorrhea, chlamydia, mycoplasma, or uroplasma. Infection causes the cervix to become red and edematous. A mucopurulent exudate drains from the external cervical os, and the individual may report pelvic pain, bleeding, or dysuria. The cervix often becomes friable, bleeding easily during sexual intercourse or with pelvic examination, and papinocallo smears or pap smears. Because mucopurulent cervicitis is a symptom of PID, women at risk for STIs, especially those less than 25 years of age, should receive treatment for PID while awaiting results of microbial testing. If the woman is not at risk of STIs, a thorough evaluation often reveals another cause for the inflammation. Bringing us to vulvodynia. Vulvodynia is a chronic pain and inflammation of the vulva or vestibule, or both. In many cases, it may represent several disorders without an indefinable cause. Vulvodynia is fairly common, affecting up to 16% of women at some point in life, whereas the inflammation of the vulvodynia may be caused by contact dermatitis. The condition may be more complex and will represent abnormalities in multiple systems, including vestibular mucosa, pelvic floor musculature, and CNS pain regulatory pathways. The condition may also represent an autoimmune reaction, similar to fibromyalgia. Genetic and psychological links have also been proposed and studied. The mechanisms are poorly understood, thus, vulvodynia is difficult to evaluate and treat. Vulvodynia can be classified as generalized or localized, and as provoked and unprovoked. Vulvodynia may increase susceptibility to vaginal infection. Likewise, it may be caused by vaginal infections that spread to the labia, where they cause inflammation and edema. Other skin diseases, such as tinea, pruritus, psoriasis, lichen sclerosis, and inflammation of the apocrine gland, can involve the vulva. Assessment includes excluding and treating conditions that may contribute to or cause vulvar inflammation, and gently probing the vagina with a cotton-tipped swab to assess whether the pain is generalized or local to one region, and how the pain is perceived in terms of quality and severity. Treatment is focusing on identifying and treating any infectious cause or comorbid contributor and using a multidisciplinary approach to address both the physical and emotional aspects of the disorder. Women are advised to avoid potential irritants and to wear loose cotton clothing, using mild soaps and apply a vaginal emollient after bathing. Studies on treatments are limited but suggest that women may benefit from topical lidocaine or estrogen cream, topical or systemic antidepressants, or anxiolytics, Botox injections into the affected nerve, dietary modifications, physical therapy, behavior and sexual counseling, or both, acupuncture, nerve blocks, and a vestibulectomy. That brings us to Bartholinitis or Bartholinitis. Bartholinitis or Bartholin cyst is an inflammation of one or both of the ducts that lead from the introitus to the Bartholin greater vestibular gland. The usual causes of Bartholinitis are microorganisms that infect the lower female reproductive tract, such as streptococci, staphylococci, and STI pathogens. So here you're taking a look at the inflammation of the Bartholin gland. Infection or trauma causes inflammatory changes that narrow the distal portion of the duct, leading to obstruction and stasis of glandular secretions. The obstruction or cyst varies from 1 to 8 centimeters in diameter and is located in the posterior lateral portion of the vulva. The cyst may be reddened and painful, and pus may be visible at the opening of the duct. Any exudate should be tested for gonorrhea and chlamydia. The individual may have symptoms of the initiating infection, fever, and malaise. Diagnosis of a Bartholin cyst is based on the clinical manifestations and the identification of infectious microorganism. Most Bartholin cysts are asymptomatic and require no treatment in women younger than the age of 40. However, if they are uncomfortable or show signs of infection, treatment is advised to prevent abscess formation. Treatment is controversial but involves broad-spectrum antibiotics for a suspected infection. Some clinicians also attempt to drain the cyst using hot soaks, needle aspiration, insertion of a catheter, or a marsupialization of the infected gland. No one treatment has proved to be superior in symptom relief and prevention of recurrence. In women older than 40, drainage and biopsy are advised to rule out carcinoma. Pelvic organ prolapse. The bladder, urethra, and rectum are supported by the endopelvic fascia and the perineal muscles, particularly the levator ani group. This muscular and facial group tissue loses tone and strength with aging and may not maintain the pelvic organs in their proper position. The pelvic area contains many organs and has the force of gravity and the abdominal contents pushing down on it. If the pelvic fascia and the musculature are not firm, the pelvic organs may fail to or move to fill any space, voids. With weak support, the bladder and rectum tend to push into the vagina and vaginal wall. The vagina is an opening in the pelvic musculature for intercourse and childbirth. However, as gravity acts on the pelvis, this opening becomes a weakness in the musculature support of the entire pelvic cavity. Without proper support from the vaginal muscles and the fascia, the uterus and bulging vaginal walls can begin to herniate through the vaginal opening. A pelvic organ prolapse is the descent of one or more of the following into the vaginal space: the vaginal wall, the uterus, or the apex of the vagina after a hysterectomy. Up to 50% of women have some version of POP on a physical examination. However, most women have no symptoms, and there's no need for intervention. As the degree of prolapse increases, women feel more vaginal pressure. Bulging of the organs beyond the hymenal ring or vaginal entrance is commonly used as the clinical indicator for significant prolapse. When prolapse becomes severe, the functioning of the surrounding organs can be altered. For instance, as the bladder is pulled posteriorly, incontinence and incomplete voiding become more common. As the bowel bulges into the vaginal space, defecation becomes more difficult. The severity of POP and its symptoms increase with age, and half of women older than 50 have symptoms of POP. POP is multifactorial, but several factors contribute to the weakening of the pelvic fascia that support the female reproductive tract. Trauma is the most common risk factor, including vaginal birth and hysterectomy. Both of these events can cause disruption or tearing of the pelvic fascia. Chronic stress on the pelvic fascia also contributes to risk. Pregnancy, obesity, prolonged standing, and chronic constipation are associated with stretching of the fascia and prolapse over time. Women with connective tissue disorders are also at risk, so there is a strong genetic familial component. In addition, risk of prolapse increases with age because of the cumulative effects of stress on the pelvic floor. Because estrogen improves vascularity of the pelvic area, postmenopausal women are at risk since the fascia and pelvis musculature lose resilience and diminish estrogen levels. The following shows a list of all the factors in this box. So here's a good spot to hit pause if you need to give it a quick review. The trend is to use terminology that describes physical examination findings, thus avoiding assumptions about structural involvement. The term cytocele or rectocele may be used when the structure involves the bladder and rectum respectively, have been definitively identified. Examining the woman in multiple positions and while straining maximally provides the best information about the degree of pelvic organ relaxation. Physical examination may be augmented with imaging by ultrasound or MRI. Several systems are used to describe a prolapse. One is widespread clinical use is based on physical examination findings and uses a grading system to describe the extent of the prolapse. Subjective reports regarding the symptoms and effects of POP can be assessed through direct questioning or by using a questionnaire such as the Pelvic Floor Impact Questionnaire or the Pelvic Floor Distress Inventory. So here in this box you see the physical examination terms for the description of the supported abnormalities. And then the box following that, the evaluation of pelvic organ prolapse. The Baden-Walker halfway scoring system. Uterine prolapse is the descent of the cervix or the entire uterus into the vaginal canal. In severe cases, the uterus falls completely through the vagina and protrudes from the intra-otus. Symptoms of other pelvic floor disorders also may be present. So here you're taking a look at a picture of degrees of uterine prolapse. The following figure shows vaginal prolapse caused by a cytocele and rectocele. Cystocele is the descent of a portion of the posterior bladder wall and tridron into the vaginal canal. In severe cases, the bladder and anterior vaginal wall bulge outside of the introitus. Occasionally, a cytocele causes significant residual urine and an increased rate of bladder infections. So here you're taking a look at that. A rectocele is the bulging of the rectum and posterior vaginal wall into the vaginal canal. Although most rectoceles are asymptomatic, larger ones cause vaginal pressure, rectal fullness, and incomplete bowel evacuation. If rectoceles are severe, defecation is difficult and can be facilitated by applying manual pressure to the posterior vaginal wall. An anterocele is the herniation of the recto-uterine pouch into the rectovaginal septum. It can be congenital or acquired. Congenital anteroceles rarely cause symptoms or progress in life. Anteroceles also can result from a muscular weakness caused by previous surgery, especially surgeries through the vagina or the pelvic relaxation disorders, such as uterine prolapse, cystocele, and rectocele. Most large anteroceles are found in grossly obese and older adults and can be complicated by rupture or complete eversion of the vagina with trophic ulceration, edema, and fibrosis. Treatment is surgical. The following box here summarizes the symptoms and treatments for POP. So, a good spot to hit pause. Treatment of POP depends on the severity of symptoms and the physical condition of the woman. Treatment is often progressive, with less aggressive treatments tried first. The pelvic fascia may be strengthened through Kegel exercises or by estrogen therapy in menopausal women. Maintaining a healthy body mass index, preventing constipation, and treating chronic cough or constipation may help as well. A common treatment is a pessary, which is a removable device that, when placed in the vagina, holds the uterus in position. Surgical repair, with or without hysterectomy, is the treatment of last resort. Women should be active participants in decision making surrounding treatments because they need to balance expectations for improvement with potential side effects. So, here is a small box regarding vaginal mesh. Good spot to hit pause if you would like to read through that. Benign growths and proliferative conditions. Benign ovary cysts. Benign ovarian cysts. Benign cysts of the ovary may occur at any time in life, but the most common during the reproductive years and in particular at the extremes of those years. An increase in benign ovarian cysts occurs when hormonal imbalances are more likely. However, ovarian masses can occur during fetal development and throughout childhood as well. Benign ovary cysts are quite common and are the fourth leading diagnosis of gynecologic hospital admissions. The two most common of benign ovarian enlargement in ovulating women are follicular cysts and corpus luteum cysts. These cysts are called functional cysts because they are caused by a variation of normal physiologic events. Follicular and corpus luteum cysts are usually unilateral. They are typically 5 to 6 centimeters in diameter, but can grow as large as 8 to 10 centimeters. Most women are asymptomatic. Any ovarian mass greater than 6 centimeters or noted for a period longer than 12 weeks should be referred to a gynecologic visit. Benign cysts of the ovary are produced when a follicle or a number of follicles are stimulated but not dominant follicle develops and completes The maturity process. Every month, about 120 follicles are stimulated, but in most cycles, only one follicle succeeds in ovulating a mature ovum. Normally, during the early follicular phase of the menstrual cycle, follicles of the ovary respond to hormonal signals from the pituitary gland. The pituitary produces FSH to mature follicles in the ovary. As the follicles enlarge, granulosa cells in the follicle multiply and secrete estradiol. As a dominant follicle develops, it secretes higher levels of estradiol, which stimulates the LH surge that comes from the pituitary. A small cyst on the ovary during the follicular phase is normal. The LH surge stimulates the follicle to rupture, releasing the ovum and transforming the granulosa cells of the dominant follicles into the corpus luteum. If the dominant follicle develops properly before ovulation, the corpus luteum becomes vascularized and secretes progesterone. Progesterone arrests development of the follicles in both ovaries in that cycle. LH proteolytic enzymes and prostaglandins trigger follicular rupture and release of the ovum. Follicular cysts can be caused by a transient condition in which the dominant follicle fails to rupture or one or more of the non-dominant follicles fail to regress. The disturbance is not well understood. It may be that the hypothalamus does not receive or send a message strong enough to increase FSH levels needed to develop or mature a dominant follicle. The hypothalamus monitors blood levels of estradiol and progesterone. When FSH levels is low, estradiol does not increase enough to stimulate LH. Evidence indicates that when the progesterone is not being produced, the hypothalamus releases GnRH to increase the FSH level. FSH continues to stimulate follicles to mature, and the granulosa cells grow, and presumably estradiol increases. This abnormal cycle continues to stimulate follicular size and causes follicular cysts to develop. Clinical symptoms of follicular cysts, or even a single cyst, are bloating, swollen and tender breasts, and heavy or irregular menses. After several subsequent cycles in which hormone levels once again follow a regular cycle and progesterone levels are restored, cysts usually are absorbed or regress. Follicular cysts can vary in size and symptoms from one episode to the next and often can recur. Most are fluid-filled and more solid in ovarian cysts. The greater the chance of malignancy. Follicular cysts can be treated with combined estrogen-progestin oral contraceptives because they block the HPG axis, effectively quieting the ovary. Progestin-only contraceptives, however, increase the likelihood of developing follicular cysts because the ovarian function is diminished, but not suppressed, leading to an increased number of immature follicles. The corpus luteum cyst is normally formed by the granulosa cells left behind after ovulation. This cyst is highly vascularized but limited in size and spontaneous regresses as part of the normal menstrual cycle. However, an abnormal or hemorrhagic cyst may develop because of hormonal imbalances in low LH and progesterone levels, causing an inadequate development of the corpus luteum. In some cases, large cysts can rupture, causing hemorrhage. Corpus luteum cysts are less common than follicular cysts, but luteal cysts typically cause more symptoms, particularly if they rupture. Manifestations including dull, unilateral pelvic pain and amenorrhea or delayed menstruation, followed by irregular or heavier than usual bleeding. Rupture occasionally occurs and can cause massive bleeding with excruciating pain. Immediate surgery may be required. Corpus luteum cysts usually regress spontaneously in non-pregnant women. A persistent corpus luteum cyst is a normal finding within the first trimester of pregnancy, since the corpus luteum produces progesterone to support pregnancy until the placenta is established. following the development of a large, painful, or hemorrhagic cyst. Oral contraceptives can be used to suppress ovarian function and prevent future cysts. Dermoid cysts are ovarian teratomas that contain elements of all three germ layers. They are common ovarian neoplasms. These growths may contain mature tissue including skin, hair, sebaceous and sweat glands, muscle fibers, cartilage, teeth, and bone. Dermoid cysts are usually asymptomatic and are found incidentally on pelvic exam. However, these cysts should be carefully evaluated for the removal because they are malignant potential. Torsion of the ovary is a rare complication of ovarian cysts or tumors, or enlargement of the ovary and can occur in girls or women. If a cyst is large enough, it can cause the ovary to twist on its ligaments, pinching off blood supply to the ovary and causing extreme pain. Ovarian torsion is rare, but is a gynecologic emergency. Individuals present with acute, severe unilateral abdominal or pelvic pain. Ovarian torsion is treated surgically. Endometrial polyps. An endometrial polyp is a benign mass of endometrial tissue covered by a surface epithelium and contains a variable amounts of glands, stroma, and blood vessels. Endometrial polyps can occur anywhere within the uterus. Polyps are morphologically diverse and usually classified as hyperplastic, atrophic, or functional. In the last case, the surface epithelium may be out of phase with other endometrial tissue. Hyperplastic polyps are often pedunculated and may be mistaken for endometrial hyperplasia or, if large, adenosarcoma. Although polyps most often develop in women between the ages of 40 and 50, they can occur at all ages. These are often related to estrogen stimulation. An estimated 20% to 25% of women have uterine polyps, including as many as 35% of women with abnormal uterine bleeding. So here you're taking a look at a uterine polyp. Endometrial polyps are a common cause of intermenstrual or excessive menstrual bleeding. Diagnosis is made by transvaginal sonography or hysteroscopy. Risk factors include advanced age, obesity, nulliparity, early menarche or late menopause, or both, diabetes, tamoxifen use, hypertension, and estrogen states. Malignancy is rare. However, polyps that cause abnormal bleeding have twice the rate of malignancy of asymptomatic polyps. Coexistence of separate endometrial atypical hyperplasia or adenocarcinoma is common. Uterine polyps have a high rate of spontaneous resolution, but have been associated with suboptimal fertility. Polypectomy can be performed through a hysteroscopy for systematic women, or symptomatic women rather, for those at risk for malignancy, or for women who are struggling to conceive. Leiomyomas. Leiomyomas, commonly called myomas or uterine fibroids, are benign smooth muscle tumors in the myometrium. Leiomyomas are the most common benign tumors in the uterus, affecting as many as 70 to 80% of all women, and most remain small, asymptomatic, and clinically insignificant. Prevalence increases in women ages 30 to 50, but decreases with menopause. The incidence of leiomyomas in Black and Asian women is 2 to 5 times higher than in white women, and the age of onset for Black women is, on average, 10 years earlier than that of white women. Complications related to leiomyomas are the primary reason for gynecologic hospitalizations and accounts for 30% of all hysterectomies in women less than 40 years of age. So here is a leiomyoma classification system. The cause of uterine leiomyomas is unknown, although their size appears to be related to estrogen, progesterone, growth factor, angiogenesis, and apoptosis. There's a genetic component to fibroids, and the leiomyomas exhibit chromosomal changes within their tissue. Leiomyomas are estrogen and progesterone sensitive and are found to have increased number of estrogen receptors. Uterine leiomyomas are not seen before menarche, and those that develop during the reproductive years generally decrease in size after menopause. Occurrence is multifactorial but often linked with the estrogen exposure. Tumor in pregnant women may enlarge rapidly, but often decrease in size after the end of pregnancy. Risk factors for fibroids include nulliparity, obesity, PCOS, black race, postmenopausal hormone use, and hypertension. So it's pathophysiology. Most leiomyomas occur in multiples in the fundus of the uterus, although they may occur singly and throughout the uterus. Leiomyomas are classified as subserous, submucosous, or intramural, according to their location within the various layers of the uterine wall. Uterine leiomyomas are usually firm and surrounded by a connective tissue layer. Unlike cancer, leiomyomas are unable to cause blood vessel proliferation to support their growth. Degeneration and necrosis may occur when a large leiomyoma outgrows its blood supply. The ensuing tissue necrosis causes pain. So here you're taking a look at the myoma. So its clinical manifestations. The major clinical manifestations of leiomyomas are abnormal uterine bleeding, pain, and symptoms related to pressure on nearby structures. Leiomyoma may distort the uterine cavity and increase the endometrial surface area. This increase may account for the increased menstrual bleeding that is associated with leiomyomas. Pain is not an early symptom, but tends to occur with the devascularization of larger leiomyomas. It is also associated with blood vessel compression that limits blood supply to adjacent structures. Symptoms of abdominal pressure are slow to develop, apparently because the tumor is relatively slow growing, enabling adjacent structures to adapt to pressure. Pressure on the bladder may contribute to urinary frequency, urgency, and dysuria. Pressure on the ureter may cause it to become distended upstream from the pressure point. Rectosigmoid pressure may lead to constipation. A sensation of abdominal or genital heaviness may be felt with larger tumors. Fibroids also may contribute to infertility and subfertility. So, its evaluation and treatment, therefore. Uterine leiomas are suspected when the bimanual examination discloses uterine enlargement and irregular, non-tender nodularity of the uterus. Pelvic sonography, or MRI, confirms diagnosis. Treatment depends on the symptoms, tumor size, age, reproductive status, overall health of the individual, and the woman's preference. Most myomas are asymptomatic and can be managed by observation only. Medical treatment for symptomatic women not desiring pregnancy is aimed at shrinking the myoma or reducing symptoms, or both. Some lyomas shrink in response to oral contraceptives. However, oral contraceptive pills may enhance growth, so they should be monitored carefully. An LNG IUD may be helpful for women who wish to reduce their bleeding and decrease the size of tumors. If the uterine cavity is not completely blocked by large fibroids, GnRH agonists are usually a temporary management for those close to menopause or as a pre-surgical treatment. GnRH side effects related to the decreased levels of estrogen, including hot flashes and osteoporosis, limit its usefulness. Various selective estrogen receptor modulators have been studied alone and in conjunction with GnRH agonists and appear effective, although more research is needed, especially because these agents may decrease bone density. GnRH antagonists also have been shown to reduce fibroid volume. Progesterone receptors agonists, such as mifepristone and ulipristal acetate, also has shown some effectiveness in shrinking leiomyomas. These have been approved for the use in Europe for the purpose of shrinking fibroids before surgery. Promising non-pharmacologic therapies include green tea extract, curcumin, vitamin D, and herbal preparations used in Chinese medicine specifically to treat fibroids. Surgical treatments are commonly used but may be decreasing in frequency. Hysterectomy is commonly performed for bleeding and pain related to fibroids. Myomectomy, or removal of the fibroids from the muscle of the uterus, may be less invasive than a full hysterectomy and remains the standard of treatment for women wishing to preserve their fertility. Newer, less invasive treatments that show promise include uterine artery embolization and MRI-guided ultrasonography to coagulate areas of the fibroid, causing tissue destruction and involution. The benefits and risk of each therapy should be carefully explored with women who experience severe symptoms. Adenomyosis. Adenomyosis is the presence of the endometrial tissue within the uterine myometrium. Endometrial cells migrate into the myometrial layer through an unknown mechanism. Estrogen and progesterone likely play a role and, perhaps, metaplasia of Mullerian tissue. Unlike endometriosis, this tissue does not respond to cyclic hormone changes. It is more commonly found during the late and reproductive years. However, because of adenomyosis is generally diagnosed after a hysterectomy, time of diagnosis may not correspond with incidence. Adenomyosis has been found in up to 30 to 60% of hysterectomy specimens from otherwise normal women. Rates are higher for women taking tamoxifen. Parity also increases the risk for adenomyosis, as does any history of uterine surgery. While women diagnosed with adenomyosis are often out of their childbearing years, those with adenomyosis who become pregnant are at risk for poor outcomes, including preterm labor, preterm premature rupture of membranes, and a low birth weight. Adenomyosis may be asymptomatic or may be associated with abnormal menstrual bleeding, dysmenorrhea, dyspareunia, uterine enlargement, uterine tenderness during menstruation, chronic pelvic pain, and infertility. Secondary dysmenorrhea becomes increasingly severe as disease progresses. On bimanual examination, the uterus is diffusely enlarged, globular, and most tender just before or after menstruation. Diagnosis is confirmed with an ultrasound or MRI. Treatment is asymptomatic, and first-line therapies include NSAIDs, combined oral contraceptives, and the LNG IUD. Other promising medical treatments include selective estrogen receptor modulators, high-dose progestins, selective progesterone receptor modulators, aromatase inhibitors, and GnRH agonists. Surgical treatments includes resection of localized areas of adenomyosis, or, if severe, hysterectomy. Uterine artery embolization and uterine ablation have shown good initial results, but needs further testing. In addition, there is an emerging body of research looking at the use of high-intensity ultrasound and other interventional radiologic treatments. Decisions are based on managing symptoms and whether future fertility is desired. Endometriosis. Endometriosis is the presence of functioning endometrial tissue or implants outside the uterus. Like normal endometrial tissue, the ectopic endometrium responds to hormonal fluctuations of the menstrual cycle. Common sites of implantation include the pelvic peritoneum, ovaries, and uterosacral ligaments. Endometriosis primarily affects younger women, with peak incidence in the third decade. However, the overall incidence of endometriosis is difficult to determine, particularly in asymptomatic adolescent and fertile women. It is estimated that 11% of asymptomatic women have endometriosis. However, as many as 50% of women evaluated for pelvic pain, infertility, or a pelvic mass are diagnosed as having endometriosis. It is the third most common reason for a hysterectomy. In addition, women with endometriosis are at greater risk for cancers, especially ovarian cancer. The cause of endometriosis is not known, but multiple theories have been proposed. One commonly accepted theory was proposed in 1927 and suggested that endometriosis is caused by the implantation of endometrial cells during retrograde menstruation, in which menstrual fluids move through the fallopian tubes and into the pelvic cavity. Indeed, there is a higher incidence of endometriosis in women who have an obstructed menstrual flow. However, it is now known that although retrograde menstruation occurs in almost all women, not all women develop endometriosis. Another theory is that women with endometriosis have impaired cellular and humoral immunity. Alterations in cytokine and growth factor signaling have been identified. Cytotoxic T cells and natural killer cell activity has been found to be depressed. At the same time, increased number of macrophages appear to be stimulating endometrial cell proliferation outside the uterus. An autoimmune response is also suspected. Such alterations may cause the body to tolerate ectopic implantation of endometrial cells. Researchers also have proposed that endometrial cells spread through the lymphatic or vascular system, or that multipotential cells in the epithelial coverings to reproductive organs are somehow stimulated to develop into endometrial and metaplastic cells. Another theory, supported by recent findings of endometriosis found in female fetuses, is that endometrial cells may spread outside the uterus during fetal organogenesis. A genetic predisposition to endometriosis has been documented, and genetic polymorphism has been identified. Emerging research also suggests that there may be a disruption in the gene expression during embryogenesis that is responsible for the generation of endometriosis. So it's pathophysiology. Endometrial implant can occur throughout the body, but generally occur in the pelvic and abdominal cavity. The most common site of implantation are the ovaries, uterine ligaments, rectovaginal septum, and pelvic peritoneum. Other sites of implantation are the sigmoid colon, small intestine, rectum, appendix, bladder, uterus, vulva, vagina, cervix, lymph nodes, extremities, pleural cavity, lung, laparotomy scars, and hernial sacs. Indeed, the pathologic studies have found endometriosis on all organs of the body except the spleen. So that's a little fun fact. Pelvic sites of the endometrial implantation. A good spot to take a look at that. The growth of endometrial lesions depends on the estrogen exposure. Endometriosis lesions are affected by ovarian hormones in the same manner as endometrial tissue within the uterus, with the exception of the marked progesterone resistance of the endometriosis cells. Cyclic changes depend on the vascularity and blood supply of the lesion and the presence of glandular and stromal cells. Given that blood supply is sufficient, the ectopic endometrium proliferates, breaks down, and bleeds with the normal menstrual cycle. The bleeding causes inflammation, triggering a cascade of cellular inflammatory mediators, including cytokines, chemokines, growth factors, and protective factors, such as the secretory leukocyte protease inhibitor and superoxide dismutase. The inflammation may lead to fibrosis, scarring, adhesion, and pain. So, its clinical manifestations, therefore. The clinical manifestations of endometriosis can mimic other diseases and disease processes. Symptoms are variably in frequency and severity and most commonly include pain and infertility. Women with endometriosis report progressive dysmenorrhea, dysuria, cachexia, and dyspareunia. They may also report constipation and abnormal vaginal bleeding. If implants are located within the pelvis, they can cause an asymptomatic pelvic mass, having irregular, movable nodules, and are fixed retroverted uterus. Most symptoms of endometriosis can be explained by the proliferation, breakdown, and bleeding of an ectopic endometrial tissue, with then subsequent formation of adhesions. In most instances, however, the degree of endometriosis is not related to the frequency or severity of symptoms. Dysmenorrhea, for example, does not appear to be related to the degree of endometriosis, with involvement of the rectovaginal septum or the uterosacral ligaments. Dyspareunia develops. Cachexia occurs with bleeding of ectopic endometrium in the rectosigmoid musculature and subsequent fibrosis. Roughly 25 to 40% of women with infertility have endometriosis. The link between endometriosis and infertility is strong, yet the degree of disease and infertility is not as closely associated. That is, women with untreated minimal to mild disease may have high pregnancy rates or may experience infertility. The exact mechanism for infertility in women with endometriosis is unknown. Infertility may result from mechanical interference with ovulation or ovum transport through the fallopian tube because of adhesion and the effects of inflammation and cytokine activity. However, the infertility also could be the result of the underlying autoimmune disorder that caused the endometriosis. There are conflicting reports regarding the effects of endometriosis on sperm activity. An increased phagocytosis of spermatozoa by macrophages has been observed. The uterine endometrium in women with endometriosis appears to have an overactive response to estrogen and an underactive response to progesterone, impairing the endometrial receptivity to blastocysts implantation, decreasing the chance of successful pregnancy. Women with endometriosis who achieve pregnancy naturally or through in vitro fertilization also seem to be at higher risk for poor obstetric outcomes, including preterm birth, small for gestational age babies, and placental complications. So it's evaluation and treatment, therefore. A presumptive diagnosis can be made based on clinical manifestations, but a laparoscopy is required for definitive diagnosis of endometriosis. A uniform classification system that includes both extent and severity has been developed, but still does not correlate well with women's symptoms. Treatment is aimed at preventing or decreasing progression and spread, alleviating pain, and restoring fertility. Current therapies include suppression of ovulation with continuous estrogen progestin COCs, danazol, GnRH agonists, analogs in oral or depot formulations, and the antiprogestin, gestrinone, mifepristone, and dianogest, and atrophy of the endometrium with progestins include medroxyprogesterone acetate, oral progestins, and the etonogestrel rod, or an LNG IUD. Conservative surgical treatment include laparoscopic removal of ectopic endometrium with conventional or laser techniques. Effectiveness may be increased when medical regimens are combined with surgical techniques. All treatments have risks or side effects, and recurrent symptoms develop in the majority of women within a few years. Even with surgical treatment, women should be fully informed about all options and carefully weigh the risk to benefit ratio of non-reversible treatments. That brings us to a series of cancers. Malignant tumor of the female reproductive systems are common. Cancers of the female reproductive tract can often grow large before causing pain, because the pelvis and abdomen are poorly innervated and designed to accommodate a growing fetus. Reproductive tract cancers are more likely to be diagnosed early if there are symptoms. Uterine cancer is the third leading cancer diagnosed in women, but is only the seventh leading cause of death, in part because symptoms of vaginal bleeding prompt women to seek treatment. Ovarian cancer, on the other hand, occurs less frequently at 2.6% of new cancer diagnoses in women, but is the sixth leading cause of death from cancer related to its lack of symptoms and lack of clear screening or diagnostic testing. Cervical cancer is also generally asymptomatic until the cancer has progressed, but early detection is possible with routine screening. 2% of cancers in women begin in the cervix, but the death rate from the cervical cancer has declined by half since the advent of screening techniques. That brings us to cervical cancer. Cancer of the cervix is the leading cancer-related death in most of Africa, Central America, and South Central Asia. However, it has a lower prevalence in the United States. In the US, rates of cervical cancer incidence and mortality have declined by half since 1975, largely because of the increased prevalence and frequency of cervical screening of cancer with the Pap test. In 2016, the American Cancer Society estimated about just shy of 13,000 new cases of invasive cervical cancer and 4,120 cervical cancer deaths. So, what is its pathophysiology? It is established that cervical cancer is almost exclusively caused by cervical human papillomavirus, or HPV infection. Infection with high-risk types of HPV is a necessary precursor to the development of cervical dysplasia, otherwise known as the precancerous cell changes that lead to invasive cancer. Precancerous dysplasia, also called cervical intraepithelial carcinoma and cervical carcinoma in situ, is a more advanced form of these cell changes. Importantly, cervical dysplasia can be detected non-invasively through examination of the cervical cells. If dysplasia is detected early, treatment is available to prevent invasive cancer. Most sexually active women will contract HPV at some point in their life. Most of these infections are asymptomatic and resolve spontaneously. However, high-risk HPV may persist and cause abnormal cellular changes that can become cancerous. HPV strains 16 and 18 are most often implicated as causing 70% of all cervical cancers, and also contribute to many vaginal, vulvar, penile, anal, and oropharyngeal cancers. Most HPV infections are cleared by the immune system. The vast majority of infections do not cause cervical cancer. For this reason, screening for cervical cancers before age 21 is not recommended. Previous efforts at early screening resulted in many young women receiving treatments on their cervix that may have been unnecessary. These treatments destroyed or removed cervical cells and in many cases altered the structural integrity of the cervix, resulting in an increase in preterm births in women treated without substantially decreasing later rates of cervical cancer. It is unknown why some women are able to clear HPV infections and others cannot. Women with multiple sexual partners are more likely to be exposed to high-risk HPV, but women with only one lifetime sexual partner also can become infected. Smoking has been shown to increase the risk of persistent infection and later development of cervical cancer. In addition, women who have had many children, have a long history of oral contraceptive use, and are immunocompromised also are at higher risk of cervical cancer. Women who use vaginal douches also seem to be at increased risk of HPV infection, likely caused by the alteration in the cervicovaginal microbiome. On the contrary, women with healthy vaginal microbiomes, marked by adequate quantities of lactobacilli, seem to have a decreased prevalence and increased clearance of HPV. Anything that affects the integrity of the immune system may affect the latter risk of cervical cancer, including tobacco use, poor nutrition, chronic stress, and immunosuppressant medication. HIV infection greatly increases the risk of women infected with HPV will develop cervical cancer, and women with HIV should be screened for cervical cancer more frequently than women without HIV. In addition, high-risk HPV is found more frequently in women who are co-infected with chlamydia or gonorrhea, suggesting that those infectious processes may support the persistence of HPV in those women. It is hoped that the widespread use of HPV vaccine in boys and girls will decrease rates of invasive cervical, genital, and anal cancers over the next several decades. There are two main cell types of the cervix: squamous epithelium cells and columnar epithelial cells. The line where the two cell types meet, known as the transformation zone, is very vulnerable to the oncogenic effects of HPV, and this is where carcinoma in situ is most likely to develop. In this zone, columnar epithelium is constantly being replaced by squamous epithelium in a process known as metaplasia. Metaplasia is thought to be affected by hormonal levels. Changes in cervical epithelium is not understood, as well as endometrial tissue change in response to the fluctuating hormone. Because metaplastic cells are at increased risk of incorporating foreign or abnormal genetic material, neoplastic changes are most common in the transformation zone. So here you're taking a look at cervical cancer in situ. Young women are especially vulnerable to HPV because of their cervical anatomy. Squamous epithelial cells in older women cover the portion of the cervix that protrude into the vagina, and columnar epithelial cells line the inner portion of the cervical canal. The location of the transformation zone changes as girls and women age in response to estrogen and vaginal pH changes. In girls and young women, a large portion of the cervix is covered with columnar epithelium, a condition known as squamous metaplasia. As women age, the transformation zone moves as the squamous epithelium covers the surface of the cervix. Therefore, the younger a woman is when she contacts HPV, the more sensitive cervical cells are exposed. This is one reason vaccination against HPV is aimed at women before the initiation of sexual activity. Many chromosomes may contain genes that relate to HPV-linked cervical cancer. Like other cancers, cervical cancer requires the accumulation of genetic alteration for carcinogenesis to occur. Several genetic mutations have been identified, including some that have not been seen in other cancers. Several chromosome regions with recurrent loss of heterozygosity have been identified. In addition, other genes may influence a woman's receptivity to HPV. For instance, HPV may upregulate the E6 oncoprotein in certain gene sequences, causing a greater production of vascular epidermal growth factor, which allows the tumor to promote blood vessel growth toward the proliferating cells, fueling growth. Moreover, mutation in genes regulating the immune response have also been identified as playing a role in the development of cervical cancers. So, the clinical manifestations. Cervical neoplasm are predominantly asymptomatic. Therefore, regular Pap test or HPV screening is necessary for early detection. About 90% of cervical cancer cases can be detected through early use of regular screening tests. If symptoms exist, they may include vaginal bleeding or abnormal discharge. Bleeding is variable and may occur after intercourse or between menstrual periods. Vaginal discharge is a less common presenting symptom and may be serosanguinous or yellowish with a foul odor. Bleeding and discharge are subtle and are likely to be disregarded by premenopausal women. Postmenopausal women are more likely to seek medical attention if these signs appear. Advanced disease may cause urinary or rectal symptoms and pelvic or back pain, along with anemia. So here is what's new on cervical cancer screening. Good spot to hit pause if you wish to read through this. Its evaluation and treatment. Women should be screened for cervical cancer and risk for future cervical cancer through PAP and HPV testing. For women aged 30 to 65, HPV testing is now recommended at the same time as the PAP test because it is non-invasive and identifies women at later risk for cellular abnormalities leading to cancer. Indeed, HPV is often detectable for more than a decade before any noticed cellular changes. For women ages 21 through 29, HPV testing is only indicated if the PAP test is abnormal, which is known as reflex HPV testing. Recent studies suggest that HPV testing alone may be as effective but less expensive than co-testing or reflex testing. The World Health Organization recommends HPV testing in settings where HPV tests are available, but PAP tests are not. A PAP test involves the non-invasive collection of cellular samples from the surface of the cervix during a pelvic examination, using a speculum to allow for the visualization of the cervix. Cervical cytologic examination is most accurate if cells are obtained from both the endocervix and the ectocervix, which involves placing the collection device into the cervical os. These cells are then sent to a laboratory for analysis. When dysplasia is detected, further testing is indicated for diagnosis. Colposcopy involves examining the cervix visually and taking needed biopsies. An acetic acid solution is applied to the cervix, making areas of HPV infection stand out in a white color, known as the aceto-white. The cervix is then viewed under the magnification of aceto-white areas, changes in the epithelium, and the presence of abnormal vascular patterns. Abnormal areas of the cervix are biopsied because the vulnerable transformation zones move into the cervical canal. As a woman ages, the endocervix is sampled using a curettage for diagnosis. So here is a good spot to hit pause so you can see the table regarding the cervical epithelial cell abnormalities, the cytological report, and the intraepithelial lesions. The progressive neoplastic changes of cervical cells are classified on a continuum from the cervical intraepithelial neoplasia to cervical carcinoma in situ to invasive carcinoma. Various terms are used to describe the cellular changes in the cervix based on how the cells were obtained. Screening for cervical cancer is done with a PAP test, and a cytology report describes test findings. These terms are outlined on the left side of Table 25.3. If a PAP test has abnormal findings, a biopsy of the affected tissue is taken during the colposcopy. The biopsy reveals the actual extent of the lesion within the cervix. Terminology used in the pathology report is listed on the right side of the table. Pathology reports that involve cancerous changes begin with the abbreviation CIN or CIS. Cervical intraepithelial neoplasia and carcinoma in situ, respectively. So, a good spot to hit pause so you can see the different stage characteristics. Cervical dysplasia is replacement of some epithelial cells by atypical neoplastic cells and is staged depending on the depth of the epithelial involvement. Risk of progression to invasive carcinoma rises steadily with the severity of dysplasia. However, women with intact immune systems are likely to resolve dysplasia on their own. At least one-third or more of all cervical intraepithelial lesions persist without progression or regression. Women with CIN1 have an 11% chance of progression to CIS and a 1% chance of progression to cervical invasion. Women with CIN2 have a 22% chance of progression to CIS and a 5% chance of invasive lesions. In cervical CIN3 or HSIL, all or most of the cervical epithelium shows cellular features of carcinoma. However, underlying tissue is not affected. At least 12% of women with CAN3 progress to a cervical invasion. So here you're taking a look at dysplasia, and then you see the physical picture of the lesion that is reflected in distant capillaries. CIS is generally a precursor of invasive carcinoma of the cervix. A number of factors, including tumor type, contribute to the rate at which CIS becomes invasive. Because of the ease of Pap test screening, invasive cervical cancer is rare within the US, but much more common in the developing world where screening is not available. Invasive carcinoma of the cervix consists of cancer invasion into the adjacent tissue and metastasis. Adjacent tissues most often involved are the ureters and structures of the lateral pelvic wall, the vaginal stroma and epithelium, and the lower uterine segment and myometrium, the internal, external, and common iliac lymph nodes, and the obturator nodes are common sites of lymphatic involvement. Invasive cervical cancer is most often discovered through Pap test, tentatively diagnosed with a biopsy during a colposcopy, and then further diagnosed using surgery and a lymphanode angiography, CT scan, MRI, ultrasonography, and radioimmunodetection methods. The staging system for carcinoma of the cervix is shown on Table 25.4. Treatment depends on the degree of neoplastic changes, the size and location of the lesion, and the extent of the metastatic spread. For premalignant cellular changes and CIS, the goal is to kill or remove abnormal cells. These procedures can be done in a clinic with the administration of a local anesthetic. Invasive carcinoma requires surgery, including removal of the cervix and other affected tissues. Common treatments can be classified as ablative, when the cells are killed without being removed, or excisional, in which the abnormal cells are physically removed from the cervix. Ablative therapies are appropriate for lower levels of the cervical dysplasia because they leave the cervix intact, which may be beneficial for later childbearing. However, they do not provide a tissue sample for testing. Ablative surgeries include cryotherapy and cold coagulation, in which extreme cold is applied to the surface of the cervix. Carbon dioxide laser and electrocoagulation also are used to kill abnormal cells and coagulate vessels supporting their growth. Excisional therapies are appropriate if a more advanced lesion is suspected, because they produce tissue for analysis. Excisional therapies include conization, in which a cone-shaped portion of the cervix is removed, and the loop electrosurgical excision procedure, in which a small looped wire with electric current generates heat and destroys cancer cells. Heat, cold, or laser are used in excisional procedures to simultaneously excise the tissue and obliterate abnormal blood vessels. For invasive cervical carcinoma, treatment depends on the stage of the tumor. Surgical intervention may include a hysterectomy, pelvic lymphadenectomy, or pelvic excenturation. Multi-drug chemotherapy regimens also have been used, alone or in combination with radiation, and emerging treatments targeting specific cancer genes show promise. Smokers tend to have a higher stage of disease at diagnosis, and their cancer is more resistant to radiation treatment. With early detection and treatment, prognosis is excellent. Overall, the 5-year survival rate is 92% for a stage IA or lower. For women diagnosed with cervical carcinoma, the 5-year survival rate is 68%. The prevention of HPV infection may be key to substantially reducing the risk of cervical cancer. There are currently 3 licensed HPV vaccines available in the US. One that protects against 2 strains of HPV, 16 and 18, 4 strains of HPV, 6, 11, 16, and 18, and 9 strains of HPV, 6, 11, 16, 18, 31, 33, 45, 52, and 58. It is recommended that all young men and women be vaccinated. More recent studies indicate that 63% of girls have received at least one dose of this vaccine, and 42% are fully vaccinated, and that rates of HPV infection in young women have been cut in half. As vaccine uptake increases and longitudinal studies persist, further reduction are likely to be seen in cervical cancer related mortality and morbidity over the next 20 years. So here you see a table of the HPV vaccine recommendation. Again, if I'm ever going too quick, please hit pause so you can review the information. Cancer of the vagina, vaginal cancers, are the rarest of female genital cancers and account for less than 2% of gynecologic cancers. In 2016, there were an estimated 4,620 diagnoses of vaginal cancer and 950 deaths. Vaginal and cervical cancers are thought to have similar epidemiologies. Both start at the intraepithelial lesion, occur in women who have been sexually active, and are associated with HPV infection. Prior carcinoma of the cervix or uterus places a woman at higher risk for developing vaginal cancer. In utero exposure to nonsteroidal estrogens is a risk factor. It has been estimated that 100,000 to 160,000 women were exposed in utero to such nonsteroidal estrogens as DES, dianestrol, or hexestrol from 1960 to 1971. Exposure to such hormones during the first 3 months of gestation inhibits the normal replacement of columnar epithelium by squamous epithelium in the vagina of the fetus. The columnar epithelium, which is not normally found in the vagina, may then undergo malignant transformation. Not all women exposed to DES in utero develop neoplastic changes in the vagina, however. Vaginal cancers is usually diagnosed in women in their 60s and 70s, but the cellular changes begin many years before the appearance of clinical apparent disease. The most common type of vaginal cancer is squamous cell carcinoma. About 90% of tumors are squamous cell type cancers. The remaining 10% are adenocarcinomas, sarcomas, and melanomas. Non-squamous types of cancer are more common in younger women. Vaginal sarcomas can develop in children younger than 5 years, and adenocarcinomas are the most common in women less than 30 years old. Vaginal cancer is generally asymptomatic until fairly late in the disease process. The major symptom of invasive cancer is vaginal bleeding or bloody discharge. Other symptoms can include vaginal discharge, vulvar pruritus, rectal or bladder symptoms, pain, or leg edema. Several mechanisms can be used to diagnose vaginal cancer, including a Pap testing of abnormal vaginal skin, colposcopy, and biopsy. Once a diagnosis of cancer is established, the size and extent of the lesion are determined using an MRI before surgery. Like cervical neoplasms, vaginal cancer are classified as intraepithelial neoplasia, CIS, or invasive carcinoma, and are staged based on the extension into the local tissue and metastasis to distant organs. Treatment depends on the type and extent of the cancer and the overall health and expectation of the woman. Potential treatment modalities include laser therapy or removal, or both, of the affected tissues, excision of lymph nodes, radiation, and chemotherapy. Many women with invasive vaginal cancer develop recurrent pelvic cancer and need intensive monitoring for recurrence. Recurrence and survival rates vary greatly by the type and extent of cancer and the aggressiveness of the treatment regimen. HPV vaccination is the primary form of prevention. Vulvar cancer. Cancer of the vulva is responsible for about 3 to 5% of all gynecologic cancers. However, there has been a steady increase in the incidence of vulvar cancer over the last 30 years. there were an estimated 5,950 new diagnoses and 1,110 deaths in 2016. The majority are squamous cell carcinomas, although melanomas, Bartholin gland carcinomas, sarcomas, and adenosquamous carcinomas may occur. A history of HPV infection related to the 20% to 80% of vulvar cancers, depending on the type. Interestingly, HPV-related lesions have a better prognosis than those that are not positive for HPV. Previous squamous dysplasia of the vagina or cervix also is a major risk factor, as are smoking and HIV infection. Although it usually affects postmenopausal women, vulvar cancer has been diagnosed in women between the ages of 30 and 90. Usually, women have a history of vulvar irritation and pruritus. Urinary symptoms and discharge are less common. In addition, there may be a hard ulcerated area of the vulva, large cauliflower lesions, or lesions similar to those of chronic dermatitis. Biopsy confirms the diagnosis. Treatment options include primary ablative or excisional surgery, and sometimes radiation with or without chemotherapy. Less extensive removal of vulvar tissue is being studied to decrease post-surgical morbidity and maintain function. Prognosis depends on the lesion size and location, histology, and lymph involvement. Risk of metastasis increases with tumor size. The 5-year survival rate depends on the extent of the lesion, the treatment, and the overall health of the woman. Cancer caught in the early stages has a greater than 90% 5-year survival rate, with progressively poorer prognosis with advancing stages. Endometrial cancer and uterine sarcoma. Endometrial carcinomas arise within the glandular epithelium of the uterine lining. Estimates include 60,000 new cases in 2016, with approximately 10,500 deaths. Most cases occur in postmenopausal women, with peak incidence occurring in the late 50s to early 60s. Women have a 3% lifetime risk of developing uterine cancer, although incidence rates are higher in white than in black women. Mortality rates in black women are nearly twice as high, primarily because cancers are more likely to be diagnosed in advanced stages. The primary risk factor is prolonged exposure to estrogen without the presence of progesterone. Estrogen causes endometrial proliferation, whereas progesterone changes the uterine lining to limit proliferation and encourage normal shedding. Estrogen without the presence of progesterone is known as unopposed estrogen because its proliferating effects are not restrained. Exposure to unopposed estrogen includes estrogen-only hormone replacement therapy, tamoxifen use, early menarche, late menopause, never having children, and a failure to ovulate. Obesity also is a known source of endogenous estrogen and is a risk factor for endometrial cancer. Other risk factors not directly related to estrogen include diabetes, gallbladder disease, and hypertension, though obesity may be a mediating factor for these risks. A family history of colon, endometrial, or ovarian cancer could signal hereditary non-polyposis colorectal cancer. Women with this family history may wish to explore genetic testing and more aggressive screening. So here you see how the endometrial cancer has an increased risk with obesity. Although estrogen and obesity increase the risk of endometrial cancer, several interventions have been shown to decrease the risk of cancer. A review of modifiable risk factors and prevention for endometrial hyperplasia and cancer indicates that controlling obesity, hypertension, and diabetes may reduce an individual's risk of endometrial cancer. Exposure to progesterone also decreases the risk of endometrial cancer, both immediately and long-term. Large amounts of progesterone are released during pregnancy. Smaller but still effective amounts of progesterone are in OCPs and the progestin-containing IUDs. The use of birth control pills can decrease the risk of endometrial cancer by 80%, even more than a decade after use. The progestin-containing IUD is used to prevent endometrial abnormalities in women who need to take tamoxifen as part of breast cancer prevention, and has shown promise in protecting the endometria of obese women. With an estimated 50% reduction in endometrial cancer incidence among obese women using a LNG IUD. About 75% of endometrial cancers are adenocarcinomas. Abnormal vaginal bleeding caused by disruption of the endometrial surface by neoplastic processes is the most common clinical manifestation of endometrial cancer. Pain and weight loss are symptoms of late disease. Screenings methods for early detection of endometrial cancer are as effective as those for cervical cancer. Pap tests, highly effective in detecting cervical dysplasia, are ineffective in detecting early endometrial cancer. Transvaginal ultrasounds may be used to measure endometrial thickness and screen postmenopausal and high-risk premenopausal women. If the endometrium is abnormally thick, then further testing, such as the endometrial biopsy, is warranted to rule out cancer, especially in high-risk women. Endometrial biopsies can be performed in a normal clinic with minimal additional equipment. The biopsy involves placement of a thin, small tube through the cervix to collect a specimen of the endometrium for analysis. Once cancer is confirmed by biopsy, a laparoscopy and MRI may be performed to determine stage of disease. Uterine cancers can be divided into two types by histology. Type 1 tumor are by far the most common and result from estrogen exposure, leading to endometrial hyperplasia. Type 2 cancers, however, make up about 10% of endometrial cancers, but are more likely to be invasive into the uterine muscle and metastasize beyond the original location, resulting in a much greater risk for death. Treatment is based on the cancer type and the extent of the disease. For women with simple hyperplasia, progestin therapy may often suffice. However, treatment for atypical hyperplasia or invasive disease usually includes surgical interventions such as curettage for carcinoma in situ, total abdominal hysterectomy with bilateral salpingo or oophorectomy, and a lymphadenectomy. Chemotherapy and radiation also may be used. The 5-year relative survival rate is 82%. There are health disparities in survival rates. The 5-year survival rates for white women is 84% compared to the 62% in black women, partly because white women are likely to be diagnosed at earlier stages of the disease. Uterine sarcomas are rare neoplasms that arise from the mesenchymal tissue of and near the uterus, including myometrial smooth muscle, endometrial stroma, or adjacent connective tissues. Uterine sarcomas are rare, constituting up to 3% of all genital tract cancers and 3 to 5% of all uterine malignancies. The average age at diagnosis is the early 50s, though some sarcomas can form in childhood. Uterine sarcomas can be divided into endometrial stromal sarcoma, leiomyosarcoma, and adenosarcoma based on the involved tissue type. The very low occurrence and diversity of cellular composition of these tumors explain the lack of epidemiologic and treatment data. Thus, relatively few risk factors have been identified. However, prior pelvic radiation therapy, chronic excess estrogen exposure, use of tamoxifen, and black race have been cited as risk factors. Symptoms include abnormal uterine bleeding, awareness of a mass, and pelvic pressure or pain. Vaginal discharge may be profuse and foul. Gastrointestinal and genitourinary complaints are common. Treatment consists of a total hysterectomy, which may include bilateral, salpingo or oophorectomy, and selective lymphadenectomy, followed by radiation therapy or chemotherapy or a combination of both. Molecularly targeted therapies also are under investigation. 5-year survival rates range from 50% in early disease to 5% in advanced disease. Like most cancers, stage and histopathology analysis are the most important determinants of prognosis. The survival rate at 5 years for a stage 1 disease is 50%. Few women survive advanced stage diseases. Bringing us to ovarian cancer. The incidence of ovarian cancer is estimated at 22,250 women in the US in 2016. In 2013, ovarian cancer accounted for 3% of all cancers among women and 21% of gynecologic cancers. It's caused more deaths than any other female reproductive cancer from 2003 to 2012. The incidence declined at a rate of 0.9% per year. Ovarian cancer in women older than 40 years is associated with conditions associated with increased ovulation over the lifetime, such as early menarche, late menopause, and nulliparity. A history of endometriosis also increases the risk. There's a genetic component to ovarian cancer, and women with a BRCA1 or 2 mutation have a 40 to 60% lifetime risk of ovarian cancer. Women who have this gene tend to be diagnosed roughly 10 years before women without a genetic predisposition. Factors that suppress ovulation decrease the risk of ovarian cancer and include pregnancies, prolonged lactation, and the use of hormonal contraceptives that limit ovulation, including the birth control pill, tubal ligation and hysterectomy, and specifically the prevention of a retrograde menses around the ovary also have been shown to decrease the risk. Pathophysiology, therefore. There is a controversy about the pathogenesis of ovarian cancer. The great majority of ovarian cancer are sporadic and not associated with a known pattern of inheritance. Of the approximate 20% of cancers that are familial, the majority are associated with the breast cancer susceptibility gene, 1 or BRCA1, and the smaller number with the mutation of BRCA2, or mismatched repair genes. Various pathways have been proposed. Women and families who are more susceptible to cancer may have errors in their ability to repair cellular DNA, related to abnormalities in several genes responsible for repair of the damaged DNA. In sporadic ovarian cancer, BRCA1 and 2 are rarely mutated. A newer theory proposes that many spontaneous non-hereditary ovarian tumors arise from the migration of cells from tissues of mesoderm origin to the surface of the ovary. Cells from the variety of the intra-abdominal location, including endometrial tissue and epithelium of the fallopian uterine tubes, can attach to the ovary. The local ovarian environment, including the ovarian stroma, may then interact with the transplanted cell to enhance cellular growth and encourage metastasis. So here you're taking a look at a picture of the migration of the epithelial cells from the fallopian and uterine tubes to the ovary. And then here you see the ovarian stroma. The two major types of ovarian cancer are epithelial ovarian neoplasms and germ cell neoplasms. Most ovarian malignancies are epithelial ovarian neoplasms that usually develop from the surface of the epithelium of the ovary or the epithelium that lines cysts immediately beneath the ovarian surface, or may be cells that have migrated from precursor lesions in the fallopian uterine tubes. Most epithelial cancers seem to arise from a single cell, because of the loss of the tumor suppressor gene and the activation of oncogenes. Epithelial ovarian tumors may have cellular similarities to other tissues within the abdomen, including the lining of the fallopian and uterine tubes, or the endometrium, or be undifferentiated. Tumors are often classified by type 1, 2, and based on their cellular type. Type 1 tumors grow more slowly and are genetically stable. Type 2 tumors often grow rapidly and aggressively and often have genetic mutations. Type 2 tumors have a poorer prognosis. The 5-year survival rate is 92% if treated in stage 1. However, only 15% of ovarian cancers are diagnosed as early. The 5-year survival rate varies by the age at diagnosis, with younger women than 65 having a 58% rate compared to the 28% survival rate in women older than 65 years of age. So here you're taking a look at the ovarian tumors. Your germ cells tumors are derived from a primitive germ cell of the embryonic gonad and may be malignant or benign. The benign cystic teratoma accounts for about 10% of all ovarian tumors. These tumors represent an era in meiosis that result in the formation of ectoderm, endoderm, and mesoderm cell lines. Hair, teeth, and skin can be visualized within cystic teratomas. If the germ cell tumor is malignant, it tends to be highly aggressive and rapidly growing with a poor prognosis. Cystic hygromas and other germ cell tumors can occur on the ovaries of girls and women. Germ cell tumors in children can be particularly aggressive. That brings us to our clinical manifestations. Ovarian cancer is commonly asymptomatic until the tumors have grown very large. Given the location of the ovaries, assessing abnormalities on routine gynecologic exam poses difficulty, especially in obese women. There's no sensitive and specific test for ovarian cancer for screening. Low-risk women and routine screening of women without risk factors have not been shown to be beneficial and may cause harm because more women have unnecessary surgical procedures. Common first symptoms of ovarian cancer are vague and include persistent abdominal distension, loss of appetite due to early satiety, and pelvic pain. Screening is warranted if women have a new onset of these symptoms that persist for more than 12 days each month. However, many women fail to notice the very first signs of ovarian cancer because they are vague and fairly common in older women. The disease is most commonly diagnosed after metastasis has occurred. Consequently, ovarian cancer is often termed the silent killer. Symptoms of advanced disease include pain and abdominal swelling from the primary ovarian mass, or ascites, and abdominal distension. Gastrointestinal manifestations may include dyspepsia, vomiting, and alterations in bowel habits caused by mechanical obstruction. Abnormal vaginal bleeding may occur if the postmenopausal endometrium is stimulated by a hormone-secreting tumor. The tumor also may cause ulcerations through the vaginal wall that result in bleeding. There also can be a feeling of pressure in the pelvis and leg pain. So here you're taking a look at a large malignant ovarian tumor. Tumor obstruction of vascular channels can cause venous and occasionally arterial thrombosis. Alteration in coagulability also occur, contributing to clot formation. Metastasis often causes pleural effusions. So what is the evaluation and treatment therefore? Because ovarian cancer has no early symptoms and there is no cost-effective screening technique for early detection, disease usually is advanced by the time treatment is sought. Screening procedures include a gynecologic assessment. Vaginal ultrasound and a CA-125 assay have low predictive value in women without special risk factors. Women with symptoms of disease, as outlined earlier, should be assessed with minimally invasive tests first. Screening commonly begins with a CA-125 blood test, looking for specific cancer markers, and a transvaginal ultrasound. Increased CA-125 levels are found in about 70 to 80% of non-mucosal or mucinous ovarian cancers. However, elevated levels are produced in 29% of a non-gynecologic tumor and in a variety of non-cancerous conditions, such as endometriosis, PID, benign ovarian cysts, myomas, and pregnancy. Women less than the age of 40 are more likely to have non-epithelial cell tumors and should be assessed with blood tests to look for the CA-125 marker. your alpha fetoprotein, and for beta human chorionic growth hormone to screen for tumors of non-epithelial cell origin. Some types of germ cells, and rarely adenocarcinomas, may be associated with increased levels of AFP, HCG, or CA125. If initial tests are suspicious for a cancerous mass, diagnosis is confirmed by biopsy, and the extent of the disease is determined by ultrasound, CAT scan, MRI, and other imaging techniques. Women undergoing surgery for ovarian cancer staging receive a thorough assessment for metastasis. The International Federation of Gynecologic and Obstetricians staging system is described in the following table. Other studies may be used to determine the extent of metastasis. These include an upper gastrointestinal series, barium enema, IV pyelogram, and mammography and lymphography. So, here's a good spot to hit pause so you can see the FIGO staging of carcinoma of the ovary. And I'll see if I can put it all into one section here for you. The initial approach to treatment is surgery, which is performed to determine the stage of the disease and to remove as much of the tumor as possible. Future treatment is then customized based on the clinical stage of the cancer, the woman's desire, and the cell type and sensitivity of the cancer cells. Ideally, treatment plans are developed and implemented by a multidisciplinary team from a variety of disciplines, including surgeons, pathologists, and oncologists. Radiation therapy and chemotherapy with an agent containing platinum are common treatments. Even after initially effective treatment, 55 to 75% of women relapse, and less than 20% survive long term with stage 3 or 4 disease. New therapies under investigation include small molecular weight inhibitors, monoclonal antibodies, epidermal growth factor receptors, and gene therapy. Survivors of ovarian cancer should be monitored for serial CA125 testing. Prophylactic removal of the ovaries and fallopian tubes is associated with increased survival rates among those carrying the BRCA mutations and is considered for those women who do not desire fertility. That brings us to sexual dysfunction. Sexual dysfunction. Sexual dysfunction is a lack of satisfaction with sexual function resulting from pain or a deficiency in sexual desire, arousal, or orgasm/climax. Moreover, in order to meet diagnostic criteria, these symptoms should distress and persist for at least 3 months. Sexual dysfunction and dysfunction results from a complex interplay of the individual, culture, and physiology. Sexual problems are manifested and often difficult to diagnose. Adequate research is still needed. Sexual dysfunction can have organic or psychogenic causes, or, more commonly, be a combination of both. Studies show that at any given time, up to 40 to 50% of adult women has some form of sexual dysfunction. The sexual response cycle is complex, involving the brain, mind, sympathetic and parasympathetic nervous system, the systemic and local vasculature, and local innervation. Any disruption in these systems can affect sexual response. Chronic medical conditions can greatly affect both sexual desire and sexual function. Acute illness and infections also can affect the woman's desire and ability to engage in fulfilling sexual activity. Vaginal infections are especially problematic because they can lead to vaginal irritation and pain with friction. Medications also can disrupt the sexual response cycle. Antihypertensives and antidepressants are commonly associated with sexual problems. Surgeries on the genital area can disrupt nerve pathways, and hysterectomy may affect sexual function because the uterus, cervix, and vagina are involved in sexual response and orgasm. The mind is a large component of sexual response and any stressor that affects the woman can affect her sexual response, including her feelings about her sexuality and relationship, as well as past sexual abuse. A thorough history is needed to assess for sexual dysfunction, and testing is appropriate to assess for organic dysfunction. The American College of Obstetricians and Gynecologists divides sexual dysfunction into four categories: disorders of desire, arousal, orgasm, and sexual pain. The following table shows the possible effects of chronic disease on sexual function in women. So here you see the disease process on one side and the sexual dysfunction, or function rather, on the other. So it's a good spot to hit pause if you want to review that. And then here's a figure regarding the diagnostic and treatment algorithm for sexual dysfunction. Disorders of desire, a hypoactive sexual desire or decreased libido, are the most common sexual dysfunction in women. The prevalence of a hypoactive sexual desire increases with age and may be biologic manifestation of depression, alcohol or other substance abuse, prolactin secreting pituitary tumors, or testosterone deficiency. Beta-adrenergic blockers, used for heart disease, also may inhibit sexual desire. A promising medication, flibanserin, has emerged that activates dopamine and norepinephrine in the brain and has been shown to increase sexual desire. In addition, treatment with exogenous testosterone and the antidepressant bupropion and sexual and psychologic therapy have also shown to increase sexual desire in women. And orgasmia, or orgasmic dysfunction, is the inability of the woman to reach or achieve an orgasm. Dysfunction follows a continuum from a difficulty in arousal to lack of orgasm. Any chronic illness may affect arousal. Diabetes, alcoholism, neurologic disturbances, hormonal deficiencies, and pelvic disorders may block orgasms. Narcotics, tranquilizers, antidepressants, and antihypertensive medications also can inhibit an orgasm. Dyspareunia is also common, or also known as painful intercourse. Women may experience pain during arousal, at the initiation of intercourse, midway during intercourse, at the time of orgasm, or after intercourse. The pain may have a burning, sharp, searing, or cramping quality and may be described as external, vaginal, deep abdominal, or pelvic. A variety of psychosocial and organic causes have been identified. Inadequate lubrication may make penetration or intercourse difficult or painful. Low estrogen levels are common with menopause and lactation, which also will decrease vaginal lubrication. Drugs with a drying effect, such as antihistamines, certain tranquilizers, and marijuana, can decrease lubrication. Infections and skin problems of the vulva and vagina are a frequent cause of acute onset of dyspareunia. The use of products such as spermicides and fragrances on the sensitive vaginal mucosa may increase that risk of irritation. Disorders of the vaginal opening, such as scarring from the female genital, mutilation, episiotomy, or an intact hymen, also can be problematic. Deep pelvic disorders, such as infection, tumors, and cervical or uterine abnormalities, can cause pain with intercourse. Vaginismus is an involuntary muscle spasm in response to attempted penetration. Vaginismus is often a response to a previous painful penetration. Common causes include prior sexual trauma or fear of sex. Organic causes are less common and are similar to those that cause dyspareunia, including vulvovestibulitis. Even after the underlying organic problem is detected and successfully treated, vaginismus may persist. Sexual dysfunction may develop as a coping mechanism. Women with a history of sexual trauma, rape, incest, or molestation often have problems of desire, arousal, or orgasm, or experience pain with sexual activity. In extreme cases, total sexual aversion may develop. At other times, sexual dysfunction may be a symptom of marital or relationship problems. Because sexual dysfunction has many causes, assessment and treatment should be holistic and culturally sensitive. Impaired fertility. Infertility affects approximately 50% of all couples and is defined as the inability to conceive after 1 year of unprotected intercourse with the same partner. However, many sources believe that medical intervention is indicated for women who are older than the age of 35 if they fail to conceive after 6 months of unprotected intercourse. The rate of infertility may be increasing because of an increase in sexually transmitted disease and environmental exposure, and a delay in the start of childbearing. But the increase in incidence rates may also reflect the greater utilization of medical services for infertility. Fertility can be impaired by factors in the man or the woman, or both partners. Causes include ovulatory disorders, abnormal semen, blockage of the fallopian tubes, endometriosis, and unexplained infertility. The majority of cases of infertility involve the female, caused in part by the complexity of the female reproductive cycle and tract. Ovulatory factors account for 40% of female infertility. Regular ovulation occurs as a result of a functioning hypothalamic pituitary axis. Ovulation can be disrupted by a wide variety of factors, including imbalances in the diversity of hormones, chronic conditions, and stress. Age is a major factor in female fertility because the regularity of ovulation and the quality of the ova decrease with age. Abnormalities of the reproductive tract, including tubal pathologies, cause another 20% of cases of infertility. Endometriosis and adhesions and scarring from PID are a major contributor to blockages within the female reproductive tract. The remaining 20% of the female infertility is caused by a rare condition or unknown etiologies. So here you're taking a look at the maternal age and the rate of spontaneous abortions as well as the fertility rate per 1,000 married women. So you see the relationship of fertility and miscarriage with maternal age. Male infertility has a variety of causes, many of which can be corrected, and contributes to approximately 40% of cases of infertility. Hormonal disorders, such as thyroid disturbances or low testosterone levels, can be diagnosed and corrected. Throughout the 82 days of their creation at maturation, the sperm must be kept cooler than the body temperature. Elevations in temperature caused by illness, abnormal placement of the testes, varicoceles near the testes, or exposure to high temperatures in hot tubs or saunas may kill or disable sperm. Male infertility is also linked to abnormalities of the seminal tract and sexual dysfunction that disrupts ejaculation. A number of diagnostic procedures are required in the routine investigation of the infertile couple. In many instances, no cause may be identified, leading us to fertility tests. Both the performance of even basic fertility tests, a complete history, should be obtained that includes coital, sex timing, and frequency in a relationship to the menstrual cycle, and an in-depth assessment and charting of the menstrual cycle. A reproductive history, including all previous pregnancies from both partners and their outcomes, a medical history of systemic disease, current medications, past surgeries, a sexual history including any previous STIs, and exposure to toxins. The history allows the clinician to focus on the most useful tests. Testing starts with the least invasive test or procedure and increases with invasiveness and complexity as the duration of infertility increases. The types of tests and their normal values are summarized in the following table. The most common test for male infertility is the basic semen analysis. A sample of fresh semen is evaluated for volume and the concentration, morphology, and forward motility of sperm. More advanced semen analysis also examines the function of the sperm, including their ability to bind to and penetrate eggs. In-depth analysis also may analyze the sperm's DNA for number, fragmentation, and ability to merge with the egg's DNA. The test for women determines whether ovulation occurs normally. The endometrium is responding normally to hormones, the reproductive tissues are free of tumors or infections, the woman does not have any chronic conditions interfering with fertilization or implantation, and the reproductive tract is, is adequately patent to allow for passage of ovum and sperm. Hormonal assays can be useful to detecting underlying abnormalities. The position and size of organs or the presence of tumors can be assessed by pelvic exam, ultrasound, and hysterosalpingogram that injects contrast dye into the reproductive tract to look for normal anatomy and fallopian uterine tube patency. Chromosomal analysis of the couple may reveal mutations or translocations that result in very early embryo loss. Treatment of infertility aims at correcting underlying pathologies or overriding the deficient system. Male infertility can overcome through injection of the male DNA directly into the uterus or even the ovum. Anovulation in the female can be overcome with ovulation-inducing drugs. Blockages within the female reproductive tract can be bypassed with in vitro fertilization. There has been proliferation in assisted reproductive technologies that enable women and couples to conceive and bear children. ARTs result in more than 50,000 live births per year in the US alone, and the rate is rising. However, there are questions about the health and long-term safety of infants conceived with assisted reproduction. For instance, concerns about the high rate of twins and preterm births in pregnancies conceived via ARTs. In addition, children born through ARTs have a higher rate of birth defects, even when other variables are controlled. The many theories about this cause of this increase suggest that birth defects may be the result of epigenetic changes when the expression of the embryo's DNA is affected by the very early environment of blastocytes, though it is not clear if damage done through the fertilization and implantation procedures themselves is caused by an underlying medical condition contributing to the infertility. Research in this area and field of epigenetics is still ongoing. So that brings us to disorders of the female breast. Galactorrhea. Galactorrhea, or inappropriate lactation, is the persistent and somewhat excessive secretion of milky fluid from the breasts of women who is not pregnant or nursing an infant. It can occur in men, may involve one or both breasts, and is not associated with breast cancer. Incidence is difficult to estimate because of differences among definitions of the condition, examination techniques, and populations of women who have been studied. Prevalence has been documented too as 0.1 to 32% of all women. So, what is the pathophysiology? Galactorrhea is a manifestation of a pathophysiologic process in the body rather than a breast disorder. These processes are chiefly hormonal imbalances caused by hypothalamic pituitary disturbances, pituitary tumors, or neurologic damage. Exogenous causes include drugs, estrogen, and manipulation of the nipples. When caused by hyperprolactinemia, it is manifested by the spontaneous appearance of a milky secretion from multiple duct openings, usually from both breasts. Galactorrhea, caused by oral contraceptives, is more likely to occur with high-dose use. It is characterized by clear, serous, or milky discharge from multiple ducts, and is noticeable during the drug-free interval between OC packets. In premenopausal women, unilateral or bilateral spontaneous multiple duct discharge that increases before menstruation often is caused by fibrocytic changes. Unilateral, spontaneous, serous, or serosanguinous discharge from a single duct usually is caused by an intraductal papilloma. Bloody discharge suggests cancer. Bilateral, sticky, multicolored discharge from multiple ducts is often caused by a ductal ectasia, and purulent discharge indicates a subareolar abscess. The most common cause of galactorrhea is nonpuerperal hyperprolactinemia, or excess amounts of prolactin in the blood not related to pregnancy or childbirth. Non-puerperal hyperprolactinemia can be caused by any factor that either stimulates or overstimulates the prolactin-secreting units of the pituitary gland, interferes with the production of prolactin inhibition factor, a neurotransmitter that inhibits prolactin secretion, or interferes with the pituitary receptor for prolactin inhibition factor. A variety of exogenous agents and disorders can trigger one of these three mechanisms, thereby causing the hyperprolactinemia. So looking at the following box, you see the common causes that would trigger hyperprolactinemia. So there's not just only physiologic causes, but also drug causes. So it's a good spot to hit pause to review. And then here we have the pathophysiologic causes. Hypothyroidism causes increased secretion of the hypothalamic TSH that stimulates prolactin release from the pituitary. Hypothyroidism also is associated with reduced metabolic clearance of prolactin, which prolongs its effects. Many types of pituitary tumors cause hyperprolactinemia. Prolactinomas cause hyperprolactinemia by secreting prolactin, decreasing production of PIF, or putting pressure on the pituitary stalk, such that delivery of PIF to the anterior pituitary is prevented. Growth hormone secreting pituitary tumors may cause galactorrhea through the intrinsic galactogenic effect that growth hormone appears to have on mammary tissues. Prolactin secreting drugs or prolactin secreting lung and kidney tumors also can cause hyperprolactinemia. Chronic stress may cause hyperprolactinemia by inhibiting PIF release. Cervical spinal injuries, head trauma, encephalitis, meningitis, herpes zoster, and thoracotomy scars may stimulate the afferent portion of the suckling reflex arc, which is carried in the second to sixth thoracic nerves. The suckling reflex increases prolactin secretion. So, the clinical manifestations, therefore. A small amount of breast milk is expressed from the nipples of Paris women, usually is not a concern, and normal breast milk color can be other than white. Inappropriate lactation is manifested by the appearance of a milky breast secretion in non-pregnant, non-lactating women from one or both breasts. Most women with galactorrhea also experience menstrual abnormalities. If a pituitary process is involved, the women usually experience hirsutism and infertility. If a hypothalamic lesion is present, she may report such CNS symptoms as intractable headaches, visual field disturbances, sleep disturbances, and abnormal temperature, thirst, or appetite. So, its evaluation and treatment, therefore. Galactorrhea requires an evaluation when it occurs in nulliparous women or in parous women who have not been pregnant or have not breastfed for 12 months, or is associated with amenorrhea, headache, visual field abnormalities, or other symptoms implying systemic illness. Evaluation includes a variety of diagnostic tests. When amenorrhea accompanies galactorrhea, The assessment is the same as that for amenorrhea. Breast secretions are examined for fat globules and neoplastic cells to verify their source. Serum prolactin levels are measured. Because such variables as eating, sleeping, stress, and breast examination increase prolactin levels, at least two positive results are needed for diagnosis of hyperprolactinemia. Prolactin levels greater than 25 to 30 ng per ml are elevated. Those in the range of 75 to 100 are considered to be caused by a pituitary tumor until proved otherwise. Serum thyroxine and TSH levels are measured to rule out hypothyroidism, and luteinizing hormone and follicle-stimulating hormone levels are obtained if the individual is amenorrheic. MRI may assist in locating adenomas. Treatment is specific to the underlying cause and occurs after the identification of the cause. Medical therapy is usual, and surgery or radiation therapy is rarely required. That brings us to the benign breast disease. Benign breast disease, also known as BBD, is a range of non-cancerous changes in the breast for different components of the breast, whether it's epithelial, stromal, adipocytes, or vascular. Numerous benign alterations in ducts and lobules occur in the breast, including irregular lumps, cysts, sensitive nipples, and itching. The most common symptoms reported by women are pain, palpable masses, or nipple discharge. The majority of these prove to have a benign cause. After a diagnosis of BBD, however, major determinants of breast cancer risk include degree of family history, histologic or biologic features, and results of previous biopsy. The College of American Pathologists has classified biopsy tissue according to breast cancer risk. Benign epithelial lesions can be broadly classified according to their risk of developing breast cancer as non-proliferative breast lesions, proliferative breast disease, and atypical hyperplasia. The majority of non-proliferative benign lesions are not precursors of cancer and generally not associated with an increased risk of breast cancer. Examples of other benign conditions are summarized in the following table. So here is a good spot to hit pause so you can take a look at all the other benign breast conditions. And I'll make sure to kind of leave a spot where most of it is in one section. Non-proliferative breast lesions. Non-proliferative epithelial breast lesions are usually not associated with an increased risk of breast cancer. The non-proliferative lesions include simple breast cysts, a papillary apocrine change, and a mild hyperplasia of the usual type. Terms such as fibrocytic changes, fibrocytic disease, chronic cystic mastitis, and mammary dysplasia refer to non-proliferative lesions that are not clinically definitive because they encompass a heterogeneous group of diagnoses. Simple cysts are the most common non-proliferative breast lesions and are a specific type of lump that commonly occur in women in their 30s, 40s, and early 50s. Cysts feel squishy when they occur close to the surface of the breast, but when deeply embedded, they can feel hard. An estimated 50 to 80% of women normally experience some of these changes. The prevalence of fibrocytic lesions is probably related to the systemic factors, particularly hormones, through their receptors to produce signal pathways that result in cell regulation and stimulation. These events are affected by genetic background, age, parity, history of lactation, caffeine consumption, and the use of exogenous hormones. Calcifications found in cysts and adenosis, or an increase in the number of acini per lobule, can form mammographically suspicious alterations. Cysts also can be associated with unilateral nipple discharge. A variety of substances are secreted into cyst fluid, including polypeptide hormones and male and female sex steroid hormones. Cysts often rupture with release of secretory material into the adjacent tissue. The resulting chronic inflammation and scarring fibrosis contribute to the palpable firmness of the breast. Fibrous tissue increases progressively until menopause and regresses thereafter. So here you're taking a look at the benign breast disease. Papillary apocrine changes are an increase in ductal epithelial cells that has apocrine changes, or an eosinophilic cytoplasm. A mild hyperplasia of the usual type is an increase in the number of epithelial cells within a duct that is more than 2, but not more than 4 cells in depth. Which brings us to the proliferative breast lesions without atypica or atypia. These disorders are characterized by proliferation of ductal epithelium or stroma, or a combination of both, without cellular signs of abnormality. The following structurally diverse lesions include the usual ductal hyperplasia and intraductal papillomas, sclerosing adenosis, a radial scar, and a simple fibroadenoma. The criteria for the diagnosis of an intraductal proliferative lesion have been the subject of much research and controversy, and include the following structurally diverse lesions. Usual ductal hyperplasia is additional or proliferating epithelial cells that fill and distend the ducts and lobules. They retain features of benign cells, but the cells can vary in size and shape. They are usually found as an incidental result from mammography. No additional treatment is needed, and chemoprevention is not recommended. Then there are the intraductal papillomas, which can occur as a solitary or multiple lesions. Solitary papillomas are a monotonous array of papillary cells that grow from the wall of a cyst into the lumen of the duct. Growth occurs within a dilated duct, often near or beside the nipple, causing benign nipple discharge. Epithelial hyperplasia and apocrine metaplasia are frequently present. Diffuse papillomatosis may present as breast masses, nodules on the ultrasound, or the cause of nipple discharge. Diffuse papillomatosis is defined as a minimum of 5 papillomas within a localized segment of breast tissue. It is controversial whether papillary lesions require surgical excision after core needle biopsies. So here we're taking a look of the intraductal papilloma. Then we have the sclerosing adenosis, which is a lobular lesion with increased fibrous tissue and scattered glandular cells. Calcification is commonly present within the lumens. However, the normal lobular arrangement is maintained. It can present as a mass or suspicious findings from mammogram, but require no treatment. Occasionally, stromal fibrosis may mimic the appearance of invasive carcinomas, leading us to the radial scar, which refers to an irregular radial proliferation of duct-like small tubules entrapped in a dense fibrotic stroma. The term scar refers to the structural appearance, only because these lesions are not associated with scarring and fibrosis from a prior injury, biopsy, or surgery. Radial scars, or RS, also has been called radial sclerosing lesions and sclerosing papillary proliferation. RSs are usually discovered when a breast lesion or radiologic abnormality is biopsied or removed. Controversy exists about the need for surgical excision when RAs or RSs are found. So here we're taking a look at a radial scar. And then this last one is the simple fibroadenomas, which are benign solid lumps or masses composed of both stromal and glandular tissue. Fibroadenomas usually present as a well-defined mobile mass, smooth and hard like a marble on physical examination or as a well-defined solid mass on ultrasound. Fibroadenomas are common, and regression or resolution is frequent. There is no increased risk of breast cancer in the majority of women with a simple fibroadenoma. If the fibroadenoma is complex with adjacent proliferative disease, or if there is a family history of breast cancer, the risk of breast cancer is slightly elevated. Multiple fibroadenomas occur in the same breast, or bilaterally, in about 20% of cases. Fibroadenomas are found most commonly in women between the ages of 15 and 35 years of age, but they can occur at any age, especially in older women receiving hormone therapy. The etiology is unknown, but a hormonal role is likely because they persist during the reproductive years, increase in size during pregnancy or with estrogen therapy, and usually regress after menopause. Not all biopsies proven lesions require surgical excision. Disadvantages of the excisional surgery, including scarring at the incisional site, dimpling of the breast from the removal of the tumor, damage of the breast duct system, and mammographic changes. If biopsy-proven fibroadenoma is asymptomatic, then it can be left in place, although some women may wish to have the mass excised so that they will not worry further. So that brings us to the proliferative breast lesion with atypia. Proliferative breast lesions of some abnormal structures, or atypia, include atypical ductal hyperplasia, or abnormal proliferating cells in breast ducts, and atypical lobular hyperplasia, or abnormal proliferating cells in the lumen of lobular units. ALH may lie between the ductal basement membrane and overlying normal luminal cells. Atypical hyperplasia, or AH, is an increase in the number of cells with some variation in cellular structure. Unlike ductal carcinoma in situ, ADH only partially fills involved ducts. Studies continue to indicate that women with atypical hyperplasia have an increased risk of breast cancer compared with women who have non-proliferative lesions. About 60% of the subsequent breast cancers in women with AH occur in the ipsilateral breast, as the biopsy. As mentioned earlier from long-term follow-up studies, atypical hyperplasia has been shown to confer a relative risk of 4 for future breast cancer, and recently the absolute risk has been better defined with a cumulative incidence of breast cancer about 30% at 25 years of follow-up. It appears that menopausal status at the time of benign breast biopsy influences the magnitude of subsequent breast cancer risk. For women who were premenopausal at the time of their breast biopsy, the risk of breast cancer was greater in those with ALH than among women with ADH. Overall, the younger a woman is when she receives a diagnosis of atypical hyperplasia, the higher the risk that breast cancer will develop. Among women who are postmenopausal at the time of benign breast biopsy, the risk was similar with ALH and women with ADH. Two independent cohorts of women found the extent of atypica stratified the long-term risk of breast cancer for ADH and ALH. However, from the Nurses' Health Study, the extent of ADH or ALH did not significantly contribute to breast cancer risk. The discrepant findings are important to clarify for breast cancer risk and because of concern about overdiagnosis and overtreatment of high-risk breast lesions. Overall, ADH and ALH are viewed best as markers of a generalized bilateral increase in breast cancer risk. So here we're taking a look at different types of anatomic and histologic features of atypical hyperplasias. So, what is our evaluation and treatment? Breast problems are diagnosed from a multimodal approach that combines physical examination, mammography, ultrasonography, thermography, a possible MRI, and biopsy. The dense breast tissue, often seen in young women, can make mammographic interpretation extremely difficult. Ultrasonography is used to determine and differentiate a solid mass from a cystic mass, which is generally benign. So here is a small box regarding breast cancer screening mammography. It's a good spot to hit pause if you would like to read it and review. See if I can put as much of it into one location for you as possible. Again, if I'm ever going too quickly, it's always good to hit pause. Treatment consists largely of relieving symptoms, reduction in consumption of caffeinated beverages, and chocolate, which can cause overstimulation for some women, may reduce pain and nodularity. Research for primary prevention of AH is weak. The rules of regular exercise, dietary factors, and sleep and the avoidance of psychological stress is unknown. Given time, the cysts may disappear without treatment. Certain selective estrogen modulators, such as tamoxifen and raloxifene, or, or an aromatase inhibitor, may be considered for chemoprevention after a thorough discussion of risk and benefit. Although still controversial, isoflavone exposure was associated with a decreased risk of proliferative benign fibrocytic changes, non-proliferative changes, and breast cancer. Genistein, a soy isoflavone, has been reported to downregulate an enzyme important in cancer progression and contributes to the inhibition in both breast benign and cancer cells. Toxicologists conclude soy supplements intake will not induce proliferation of normal breast tissue and may even inhibit proliferation. The North American Menopause Society found that soy food generally appears to be breast protective and recommended moderate lifelong soy consumption. Another preventative factor may be iodine. Investigators reported that povidone iodine, Lugol solution, and a combination of iodide and molecular iodine may be potent agents for use in the development of anti-tumor strategies. Drugs used to treat severe breast pain are listed in the following table. So if you're unfamiliar with your pharmacology, another good spot is to pause here. That brings us to cancer. Except for skin cancer, breast cancer is the most common cancer in American women. It is estimated that 250,000 women and 2,600 men will be diagnosed with breast cancer, and that 40,000 women and 440 men will die from breast cancer in 2016. Age and the chance of being diagnosed with breast cancer are presented in the following table. The age-adjusted death rate based on years from 2009 to 2013 cases and death in the United States is 21.5 per 100,000 women. Using the CDC's data from 2013, in the US, white women had the highest rate of getting breast cancer, followed by Black, Hispanic, Asian or Pacific Islander, and American Indian or Alaska Native women. Dying from breast cancer varies by race and ethnicity. In 2013, Black women were more likely to die of breast cancer than any other group, followed by white, Hispanic, Asian Pacific Islander, and American Indian Alaska Native women. Globally, breast cancer is the second most common cancer in the world. It is most frequent cancer of women with an estimated 1.67 million new cases diagnosed in 2012. Incidence rates vary nearly fourfold across the world regions, with rates ranging from 27 per 100,000 in Middle Africa and Eastern Asia to 92 in North America. So here you see the chance of being diagnosed with breast cancer in this following table. More than two-thirds of breast cancer cases occur in women older than 55. From 2005 to 2009, the median age for breast cancer diagnosis was 61 years of age. The median age of death for breast cancer was 68 years of age. Because ductal carcinoma in situ is almost exclusively detected by mammography, the large increase in incidence of DCIS over the past 20 years can be attributed to screening. Some women younger than the age of 45 may have a higher risk of getting breast cancer compared with other women their age if they have the following risk factors. Close relatives who were diagnosed with breast or ovarian cancer when they were younger than 45, especially if more than one relative was diagnosed or a male relative had breast cancer. Alterations in the breast genes, the BRCA1 and 2, or having close relatives with these alterations. Ashkenazi Jewish heritage, treatment with radiation therapy to the breast or chest during childhood and or early adulthood, have been diagnosed with breast cancer or other breast health problems, such as lobular carcinoma in situ. DCIS, atypical ductal hyperplasia or typical lobular hyperplasia, and high breast density. A high-risk breast cancer condition is postpartum breast cancer with immune suppression and delayed involution. Although breast cancer is a multifactorial disease involving a complex web of interacting factors, risk is related to timing, duration, and pattern of exposure. Risk factors and possible causes of breast cancer can be classified as reproductive, hormonal, environmental, and lifestyle and familial. Two factors emerging as important are postpartum involution of the mammary gland, a reproductive factor, and breast density, which is not as easily classified. So here at this table, we see the factors associated with an increased risk of breast cancer. A good spot to hit pause. That brings us to the reproductive factors, including pregnancy, a clearer understanding of the mammary gland structure and function from fetal development to puberty, pregnancy, and aging will help elucidate fundamental changes to breast development and disease. A key element is branching morphogenesis, in which the mammary gland produces and delivers copious amounts of milk by forming a root-like network of branched ducts from a rudimentary epithelial bud. Branching morphogenesis begins in fetal development, pauses after birth, starts again in response to estrogens at puberty, and is modified by the cyclic ovarian hormonal action. This systemic hormonal action elicits local paracrine interactions between the developing epithelial ducts and their adjacent mesenchyme, or postnatal stroma. The local cellular crosstalk then directs the tissue remodeling, ultimately producing a mature ductal tree. The gland is unique because it undergoes most of its branching during adolescence and not fetal development. This allows experimental manipulation of the gland not possible with any other organ. A woman's age when her first child is born affects her risk for developing breast cancer. The younger she is, the lower the risk. Overall, lifetime risk of breast cancer is reduced in Paris women compared to nulliparous women, but pregnancy must occur at a young age. The protective factor is especially observed in the years of peak incidence of postmenopausal years. The risk reduces or reduction is limited to hormone receptor positive breast cancer. The influence of pregnancy on the risk of breast cancer also depends on the family history, lactation postpartum, and overall parity. Paradoxically, women of all ages have a transient increase in breast cancer risk with a recent pregnancy and after each subsequent pregnancy. Pregnancy-associated breast cancer is defined as breast cancer diagnosed up to 5 years after a completed pregnancy. However, risk may persist for a decade. Delayed childbearing, observed in the US and all developing countries, is expected to show a rise in diagnosed breast cancers. The transient increase in breast cancer risk for all Paris women includes events associated with pregnancy, including pregnancy-related hormones such as estrogen, progesterone, and growth hormone that promote or initiate cancer cells. Immune suppressive effects of pregnancy and breast tissue involution. Breast gland involution after pregnancy and lactation uses some of the same tissue remodeling pathways activated during wound healing. The pro-inflammatory environment, although physiologically normal, promotes tumor progression. One mechanism identified links fibrillar collagen deposition, noted during normal involution, to high levels of COX2 expression in tumor cells and subsequent tumor cell metastasis. This alteration provides support to the tissue change in stroma for driving carcinogenesis. The presence of macrophages in the involuting mammary gland contributes to carcinogenesis. Immature macrophages are capable of suppressing cytotoxic T cell function, causing an immunosuppressive stroma conducive to tumor cell promotion. So here in this box you see the potential mechanisms underlying protective effects of pregnancy and the implications for prevention of breast cancer. Again, if you wish to read this, now's the time to hit pause. And I'll try and make sure you get the most of it in one spot. The main mechanisms for a protective effect of pregnancy are controversial, including the induction of breast differentiation with lasting protective phenotypic changes, altered cell fate with removal or modification of vulnerable cells, possible stem cells, enhancement of the ability for DNA to repair, or apoptosis, or both, altered systemic hormonal regulation, and the possible persistent changes in intracellular pathways regulating proliferation, decreased proliferation in the Paris-involuted gland, and early life hormonal and dietary exposure. Which brings us to the lobular involution and the age of post-lactational involution. Part of the uniqueness of the mammary gland is its profound physiologic changes throughout the phases of the woman's life: puberty, pregnancy, lactation, post-lactational involution, and aging. The human breast is organized into 15 to 20 major lobes, each with terminal lobules containing milk-forming acini. Terminal duct lobular units, also called lobules, are epithelial structures within the breast that produce milk during lactation and are the major source of most breast cancer. With aging, breast lobules regress or involute with a decrease in the number and size for acini per lobule and replacement of the intralobular stroma with the denser collagen of connective tissue. With time, the glandular elements and collagen are replaced with fatty tissue. This process is called lobular involution, and over many years, the parenchymal elements progressively decrease in size and function and begin to disappear. The first study of this kind found lobular involution was associated with reduced risk of breast cancer. Breast cancer risk decreased with increasing extent of involution in both high and low risk subgroups, defined by family history of breast cancer, epithelial atypia, reproductive history, and age. Recent data suggests breast cancer susceptibility from single nucleotide polymorphism may not strongly influence TDLU involution. Based on the histologic and epidemiologic factors, investigators propose that delayed involution is a major risk factor for breast cancer. Tissue involution involves massive epithelial cell death, recruitment and activation of fibroblasts, stromal remodeling, and immune cell infiltration, including macrophages, with similarities to microenvironments present during wound healing and tumor progression. Post-lactational involution is involution of the mammary gland that occurs at the end of every period of lactation and is essential to return the gland to the pre-pregnant state in readiness for the next pregnancy. For the first time, investigators using murine postpartum mammary gland showed involution is characterized by an influx of immune cells that reflect classic wound healing, and mammary tumor exposed to the involution microenvironment are infiltrated by immature macrophages. These macrophages inhibit T cell activation ex vivo, and involution tumors have a growth edge that is interleukin 10 dependent. The immune cell composition across postpartum mammary gland involution resembles inflammation, proliferation, and remodeling resolution phases associated with classic wound healing. Importantly, when apoptotic cells are phagocytized by macrophages, macrophages are stimulated to an immune suppressive phenotype with transforming growth factor beta and interleukin 10 expression. Phagocytosis is crucial for the remodeling process, removal of cell debris, and residual milk in the second phase of involution. Additionally, other investigators in the first study in the rodent models demonstrated nuclein, a novel apoptosis-associated protein that plays an important role in the involution by regulating NF-κ beta cells, as well as your STAT3 signaling pathways, an important transcriptional regulator of genes. Signal transducer and activator of transcription 3 is associated with inflammation, wound healing, mammary macrophages, and mast cells. STAT3 appears to have an important role in modulating cell death and involution. Regulatory T cells provide a checkpoint against inflammation during wound healing by suppressing multiple cell types, including the CD4 and CD8 T cells, B cells, natural killer cells, and antigen-presenting cells. All of these data are suggestive of classic wound resolution. The association between wound healing and tumor promotion has been recognized as a therapeutic target for decades. This relevance with breast cancer has been recently obtained because mammary gland biopsies in rodents promote lung metastasis through the recruitment of immune cells, and a skin wound adjacent to a mammary tumor stimulates tumor progression. Therefore, studies support potential for tumor promotional effects of wound healing programs associated with normal gland involution. Investigators developed an immune-competent murine model of postpartum breast cancer. They demonstrated that tumor size is increased sixfold in the involution microenvironment compared to the nulliparous host. In the postpartum group, mammary tumors have high levels of immature macrophages and reduced cytotoxic T cell levels, a pattern predictive of poor prognosis in individuals with human breast cancer. Importantly, because involution macrophages have been proposed to be associated with poor prognosis of postpartum breast cancer, macrophages may be the therapeutic target for blocking the tumor promotional characteristics of the involuting gland. Additionally, in rodents, circulating estrogens are responsible for recruiting estrogen receptor alpha, bone marrow cells that promote mammary tumor growth. So here we're taking a look at a picture of the nipple, which contains connective tissue and smooth muscle cells, forming a circular sphincter. And here is a normal breast and breast cancer. Again, if I'm ever going too quickly through the slides or pictures, always hit pause. And here you see the macrophages as instigators of tumor promotional environment. Widely appreciated is that a woman's age, their risk of breast cancer increases, but the rate of increase of breast cancer slows at about 50 years of age. The slowing has been attributed to a reduction in ovarian hormone production. Myelinase and colleagues observed a definitive increase in the process of involution at about 50 years of age, with complete involution present in 5.8% of women ages 40 to 49, and in 21.6% of women between ages 50 to 59. Investigators propose that the involution may contribute to the slowing in the rate of increase of breast cancer among women older than 50 years. Importantly, investigators found an inverse association between lobular involution and parity. Other investigators have reported that the more children a woman has, the more likely she is to have persistent lobular tissue, which Myelinase and colleagues found was associated with increased risk of breast cancer. However, multiparity also has been found to reduce the risk of breast cancer. This apparent contradiction may be explained by studies documenting that full-term pregnancies after 35 years of age are correlated with an increased risk of breast cancer. In the Myelinase study, the age of the mother at each child's birth was unknown. Henson and colleagues proposed a late pregnancy with its concomitant increase in the proliferation of the ductal alveolar epithelium is likely to interrupt the process of involution, which typically begins between the ages of 30 and 40 years of age. Failure to undergo TDLU involution among women with benign breast disease has been associated with progression to breast cancer, independent of other breast cancer risk factors. The activated stromal environment in the process of involution is the ideal niche for carcinogenesis. Major signaling pathways involved in mammary gland involution also are involved in breast cancer. Certain proteases activated during the involution modify the extracellular matrix and are implicated in the loss of cell anchoring, providing a microenvironment for tumor growth. Further, the normal involuting gland may be in an immunosuppressed state with the transient presence of immune-regulating cells that promote T cell suppression. So, in summary, an increase in breast cancer risk following pregnancy may be caused by the process of mammary gland involution, which returned the tissue back to its pre-pregnant state and is co-opted by process of wound healing, resulting in a pro-inflammatory environment that, although physiologically normal, can promote carcinogenesis. The extracellular matrix is very different between nulliparous lactating and involuting glands, and is shown in the following figure. Understanding the factors from the microenvironment that control cell function, differentiation, and stem cell renewal is the crux of developmental and cancer biology. So here you see the nulliparous, the lactation, and the regressed cellular matrix. And in this box, you see the what's new in regards to memory. ECM directs differentiation of testicular and embryonic system cells to form functional mammary glands in vivo. So a good spot to hit pause, and you can read all of it all at once here. Interestingly, orophorectomy, which is associated with a decrease in risk of breast cancer, leads to atrophy of breast parenchyma in young women, as is noted in older women. Thus, the risk reduction of orophorectomy may be caused by an accelerated involution, leading us to the hormonal factors. The link between breast cancer and hormones is based on 6 factors that affect risk: the protective effects of an early first pregnancy, the protective effect of removal of the ovaries and pituitary gland, the increased risk associated with early menarche, late menopause, and nulliparity, the relationship between types of fat, free estrogen levels, and oxidative changes in estrogen metabolism, and the hormone-dependent development and differentiation of mammary gland structures, and lastly, the efficacy of anti-hormone therapies for treatment and prevention of breast cancer. Throughout its existence, the mammary gland epithelium proceeds through critical exposure periods of rapid growth or cycles of proliferation, including neonatal growth, pubertal development, pregnancy, lactation, and involution. Importantly, lack of TDLU involution has been associated with increased breast cancer risk, but the role of sex hormone levels and TDLU assessments is only beginning. Investigators suggest that hormone levels may act in part to delay age-appropriate TDLU involution, resulting in a higher quantity of at-risk epithelium. These investigators found significant associations between the higher TDLU counts, representing less involution with higher levels of prolactin and lower levels of progesterone among premenopausal women, and higher levels of estradiol among postmenopausal women. Higher testosterone levels were suggestively associated with higher TDLU counts among postmenopausal women from a cross-sectional study. Investigators found higher levels of estrogen metabolites are generally associated with lower levels of a TDLU involution. The understanding of the role of systemic hormones as powerful regulators of mammary gland development is shifting. Evidence is pointing to the wide-ranging effects of systemic hormones as possibly not due to their direct hormone action, but rather their induced actions from multiple secondary paracrine effectors. Thus, the term hierarchical unraveling is a complex model of hormone paracrine, possibly autocrine, and adhesion molecule signaling pathways, affecting epithelial and stromal cell fate and breast development and cancers. Despite differences between the organized processes of development and the less even chaotic environment of invasive cancers, both processes share many identical mechanisms and signaling pathways. Key is tissue remodeling that applies to pubertal growth, immediately after pregnancy and during involution. The female reproductive hormones have a major role and effect on mammary gland development and breast cancer. Epidemiologic studies show that breast cancer risk increases with the number of menstrual cycles a woman has during her lifetime. Early menarche, late menopause, and short menstrual cycles all increase risk, and menopause and ovariorectomy decrease that risk. A vast majority of breast cancers are initially hormone dependent, with estrogens playing a crucial role in that development. Estrogens control processes critical for cellular function by regulating activities and expression of key signaling molecules. These processes include regulation of receptor activity and its interaction with other intracellular proteins and DNA. So here we're taking a look at the mammary gland development in a mouse. Endogenous estrogen. Substantial prospective data have accrued on endogenous circulating estrogens and breast cancer risk in postmenopausal women from the EPIC study. Increasing blood levels of estradiol also increase the risk for breast cancer. Updated analysis from two cohorts of the pooled analysis of 9 prospective studies provide strong evidence that circulating hormones are an important marker of increased risk in postmenopausal women and not a result of the production of hormones by a tumor. Emerging data reveal estrogen acting on cells of hematopoietic origin. Co-injection of tumor cells and bone marrow isolated from estrogen-treated mice into nulliparous hosts was sufficient to promote tumor growth. In this model, despite the lack of estrogen receptors expression, tumors arising following pregnancy required circulating estrogens for their formation. Importantly, increasing the level of circulating estrogens was sufficient to promote for formation and progression of ER-negative cancers. This was accompanied by a systemic increase in host angiogenesis and coincided with the recruitment of bone marrow-derived stromal cells. Moreover, bone marrow cells from estrogen-treated mice were sufficient to promote tumor growth. The progression of normal mammary epithelium towards a cancerous state depends on diverse function of the surrounding stromal cells. The many different mesenchymal cells appear to be recruited into the developing tumor masses. Circulating levels of estrogen are at their highest in women during pregnancy, and the majority of breast cancers that develop during this time lack appreciable expression of either ERs or progesterone receptors, the PRs. This significant observation suggests that estrogen is involved in promoting breast cancer following pregnancy and not through the direct binding of receptors expressed by breast epithelial cells. Recent work shows that estrogen may promote the progression of ER-negative breast cancers by stimulating cancer-associated fibroblasts to secrete stromal-derived factor 1, which can recruit bone marrow myeloid-derived suppressor cells to the tumor microenvironment, which exerts tumor-promoting effects. Evidence for estrogen in modulating the immune environment of the mammary gland comes from studies showing changes in macrophage numbers and phenotype in the mammary gland across the estrous cycle and with treatment with estradiol and progesterone. In wound healing model, estradiol and progesterone promoted an alternative phenotype in macrophages. Estradiol can promote a pro-inflammatory phenotype in macrophages. In response to estrogen and progesterone, mast cell upregulate chemokine receptors, maturation markers, and degranulate. T and B cells can be directly regulated by estrogen. Estrogen signaling drives the mobilization of MDSCs and enhances their immunosuppressive effects in vivo. More simply, estrogen promotes immunosuppression by promoting the mobilization and accumulation of the immunosuppressive action of MDSCs. Investigators found that removing the ovaries and thus estrogen production from mice boosted the anti-tumor immune response and blocked malignant progression. Estrogen signaling is a critical mechanism underlying the pathologic myelopoiesis in cancer. So that brings us to the endogenous progesterone. The role of progesterone receptors, or PR, signaling in breast cancer is complex and controversial. See the section on menopausal hormone therapy and breast cancer risk, estrogen plus progesterone and estrogen only, on treatment effects with progesterone. Several types of evidence show that repeated exposure to the luteal phase, and therefore endogenous increased serum progesterone levels, increases breast cancer risk. Confusion exists about the term proliferative phase in the first part of the menstrual cycle. The follicular phase. The breast is quiet during the follicular phase. The term proliferative phase is based on changes that occur in the uterus. The endometrium proliferates before ovulation. Post-ovulatory secretion of P has antiproliferative effects on the endometrium and induces differentiation in the uterine lining. In the breast, cell proliferation occurs during the luteal phase and is accompanied by changes in the stroma, or microenvironment. Moreover, proliferation happens in the TDLUs, where breast cancers originate. Data from cancer models show P is now recognized as a major proliferative hormone in both the mouse mammary gland and the normal human breast epithelium. The understanding of how P promotes proliferation in the human breast has grown over the years, mainly from animal studies. So here we're taking a look at the luminal cell layer, the working model of progesterone, which promotes the proliferation in human breast epithelium. After, so, P is required to promote the wave of proliferation, which occurs in early pregnancy. Ovarectomy causes endogenous levels of estrogen and progesterone to decrease significantly. As a result, cell proliferation in mammary epithelium cases or ceases, and the epithelium becomes atrophic. Emerging from mouse studies is the mechanism by which progesterone triggers cell proliferation, activates progenitor cells, induces branching morphogenesis, affects immune cells, and controls blood vessels to enable increased blood flow during the luteal phase and pregnancy. So here we're taking a look at the working model of breast carcinogenesis and the hormonal involvement. Endogenous prolactin. Prolactin, produced by the pituitary gland, travels through the blood and exerts multiple metabolic and reproductive effects, especially the breast, as the key regulator of lactation. Prolactin is also produced in other tissues, including the breast. Recently, investigators reported that autocrine prolactin is required for terminal mammary epithelial differentiation during pregnancy, and production is regulated by the signaling pathway PTEN PI3K AKT. Although this finding is critical for normal breast development, differentiation, and lactation, it may also be important in breast cancer carcinogenesis because the P13K AKT signaling pathway is commonly activated in human cancer. This suggests the important possibility that autocrine prolactin may play a role in breast cancer. A recent meta-analysis of 7 studies supports a positive association between plasma prolactin levels and the risk of breast cancer. Prolactin may inhibit a major tumor suppressive function in the BRCA1 by interfering with the P21. From the Nurses' Health Study, the association with prolactin was more modest than with estradiol. The association was stronger among postmenopausal women and for ER-positive tumors. Endogenous testosterone, androgen receptors. From the combination of prospective studies, case control studies, and laboratory data, the association between circulating testosterone in postmenopausal women and subsequent risk of breast cancer is now well established. Unclear is whether the association with testosterone is direct or indirect. So here we're taking a look at a picture of the local biosynthesis of estrogens. The androgen receptors has been implicated in prostate cancer and now in the development and progression of breast cancer. The question of whether ARs are harmful or beneficial for individuals with breast cancer is complex and may differ by breast cancer subtype and menopausal status. Researchers used breast cancer cell lines and found that treatment of breast cancer cells with 5-alpha dihydrotestosterone promotes cell proliferation and decreases apoptosis. The reduction of testosterone levels in women with oophorectomy or hysterectomy may also be a protective factor. So that leads us to the serum estrogen, progesterone, androgens, and prolactin. Substantial evidence supports a positive association of circulating estrogens, androgens, and prolactin with postmenopausal breast cancer risk. For the Nurses' Health Study, the inclusion of endogenous hormones to both the Gale score and the original Rosner-Kalditz model significantly improved risk prediction for breast cancer among postmenopausal women. Measurements of endogenous hormones improve risk prediction for invasive breast cancer. A recent reanalysis of the 13 prospective studies showed that circulating concentrations of sex hormones are associated with several of the established or suspected risk factors for breast cancer. Data identify mammary stem cells as critical targets for ovarian hormones, especially progesterone, surges during the normal reproductive cycle and pregnancy, increasing the proliferation of mammary stem cells. A key aspect of MASCs is the cytoskeletal function that facilitates cell shape and mobility. Local in situ estrogens, the paracrine, the formation of estrogens in breast tumor may be significant for the growth and survival of estrogen-dependent breast cancer in postmenopausal women. The rationale is based on the following evidence. Estradiol levels in breast tumors are equivalent to those in premenopausal women, despite plasma estradiol levels being lower after menopause. Estradiol concentration in breast tumors of postmenopausal women are at least 10 times higher than serum levels. And the biosynthesis of estrogens in breast tumors occurs through two different routes: the aromatase pathway and the steroid sulfide pathway. Investigators measured levels of breast sex steroids in both benign and cancerous tissue. Estrogen and androgen concentrations varied greatly in both tissue and blood levels in benign and cancerous tissue. The estradiol-estrone ratio was the lowest in premenopausal benign tissue and much higher in premenopausal cancerous tissue and postmenopausal benign and cancerous tissue. Estradiol and estrone levels were substantially higher in tissue than in plasma in both premenopausal and postmenopausal women. Hormone levels in breast adipose tissue revealed high levels of androstenedione and testosterone, and significant estrone and estradiol levels in breast adipocytes from postmenopausal breast cancer patients, consistent with an obesity inflammation aromatase axis occurring locally in breast tissue. Crown-like structures are proposed as sites of increased aromatization of androgens and to estrogen. CLSs were more frequently identified in the breast fat of obese women and were associated with increased ratios of select estrogens, androgens in the blood and tissues, but not with individual hormones. Evidence suggests that the site of conversion of androgens to estrogens in breast cancer is the stroma and not the malignant epithelial cells. Stromal fibroblasts adjacent to the tumor express aromatase and actively induce local estrogen production and signal crosstalk between estrogen and growth factors, affecting the progression of breast carcinomas. In the presence of estrogen in mice studies, fibroblasts provided cancer cells additional growth capacity. Breast tissue also contains high sulfatase activity and produces estrone through the hydrolysis of estrone sulfate. Thus, quantitatively, estrone sulfate may be the most important circulating estrogen in women. It increases the reservoir for the production of estrone and ultimately estradiol. It was found that estradiol itself has antisulfatase action. This paradoxical effect of estradiol could be related to some studies that have found estrogen replacement therapy either to have no effect or to decrease breast cancer mortality in postmenopausal women. So here we're taking a look at breast cancer cells and stromal fibroblasts, which produce estrogen. Estrogen metabolism from oxidation of the parent estrogens, estrone and estradiol, occurs at the 2, 4, and 16 position of the carbon skeleton to yield 2-hydroxylated, 4-hydroxylated, and 16-hydroxylated estrogens, respectively. The 4 and 16 alpha hydroxylated pathways are potentially tumor promoting. Conversely, the 2-hydroxylated pathway has been demonstrated to be less tumor promoting and possibly inhibiting. A recent prospective case control study found nearly all estrogens, estrogen metabolites, and metabolic pathway groups were associated with an increased risk of breast cancer, especially unconjugated estradiol. These investigators found more extensive 2-hydroxylation of estrogens is associated with a lower risk and less methylation of the potentially genotoxic 4-hydroxylation pathway, with a higher risk of breast cancer in postmenopausal women. From the Nurses' Health Study, a comprehensive nested case control study found that women who excreted more parent estrogens are at reduced breast cancer risk. Overall, the two mechanisms of carcinogenicity of estrogens involve a receptor-mediated hormonal activity shown to stimulate cellular proliferation, resulting in increased opportunities for accumulation of genetic damage, and oxidative catabolism of estrogen mediated by various cytochrome complexes that eventually activate and generate reactive oxygen species that can cause oxidative stress and genomic damage directly. Oxidative metabolites of estrogen can develop ultimately carcinogens that react with DNA to cause mutation, leading to carcinogenesis. Thus, imbalances in estrogen metabolites in breast tissue correlate with the development of tumors and suggest possible biomarkers related to the risk of developing breast cancer. So here in this box, we see the nutrition and disease, sustained proliferation in cancer and dietary substances to block cancer proliferation. Again, if I'm ever going through this too quickly, please hit pause. Menopausal hormone therapy and breast cancer risk. Estrogen plus progesterone and estrogen only. The Nurses' Health Study is one of the largest cohort studies with comprehensive knowledge on hormone therapy, used for more than 4 decades. The following table summarizes postmenopausal hormone use and risk of cancer and cardiovascular disease from the NHS and NHS2 from 1976 to 2016. Most epidemiologic studies have found an increase in breast cancer risk related to MHT with combined estrogen and progesterone. The table shown below shows evidence comes from observational studies and clinical trials showing an increase in breast cancer risk with MHT current use, stronger among those with longer duration of use, and breast cancer risk disappearing a few years after treatment discontinuation. So again, here is a good time to hit pause if you want to review different types of breast cancers and how it's been studied. And then the following table shows the hormonal treatments assessed by the IRAC, the monograph working group. Again, a good spot to hit pause. Similar to the findings of the intervention phase of the Women's Health Initiative. Current use of the unopposed estrogen therapy from 5.0 to 9.9 years was not associated with a higher risk of breast cancer in the NHS among postmenopausal women who had undergone a hysterectomy. However, longer duration of use, which could not be examined in the WHI, was associated with a trend toward a higher risk. Use for more than 20 years or more was associated with a 42% higher risk of breast cancer, especially for those positive for estrogen receptors and progesterone receptors. Longer use in animal studies has been linked with increasing cell proliferation, angiogenesis, and inhibition of apoptosis. Longer use of ET that may increase breast cancer risk was found in combination of data of 16 studies and another analysis of 52,700 women with breast cancer. In these studies and the Million Women study, leaner women had an even higher risk of breast cancer. From the NHS, as with the WHI, current use of MHT was associated with a higher risk of invasive breast cancer. The NHS was one of the first studies to quantify the relationship between other types of HT formulations and breast cancer risk. During 14 years of follow-up studies, the use of estrogen or progestins alone was associated with adjusted relative risk for breast cancer. These data from the women in the United States confirms the data from European studies as well. Moreover, with 10 additional years of follow-up, the risk of breast cancer was found to be nearly 2.5 times higher among current users of estrogen plus testosterone than among those who had never used those hormones. Additional support for MHT to increase breast cancer risk was the reduction in risk reported by several countries with discontinuation of MHT use. The risk associated with transdermal, intranasal, or natural estrogens have insufficient data and hypotheses remain unsubstantiated. The International Agency for Research on Cancer lists estrogen progesterone menopausal therapy and estrogen progesterone contraceptives as carcinogenic agents with sufficient evidence in humans for breast cancer. Evidence from the Agency for Healthcare Research and Quality published a systemic review from 283 trials comparing effectiveness of treatment for menopausal symptoms. From this report, they state, over the long term, estrogen combined with progesterone has both beneficial effects and harmful effects. Estrogen given alone do not appear to increase breast cancer risk, although endometrial cancer risk is increased. Which brings us to the insulin and insulin-like growth factor. IGFs regulate cellular function, involving cell proliferation, migration, differentiation, and apoptosis. IGF-1 is a protein hormone with a structure similar to that of insulin. IGF-1 is a potent mitogen. After binding to the IGF-1R triggers a signaling cascade, leading to proliferation and anti-apoptosis. The growth hormone IGF-1 axis can stimulate proliferation of both breast cancer and normal breast epithelial cells. A pooled analysis of 17 studies showed a significant association of IGF-1 with breast cancer risk. Interestingly, no significant difference was found according to menopausal studies and status. Joint association of IGF-1 and estradiol together showed that they were related to risk in those women in the top third of estradiol and IGF-1 levels had the highest risk. Estradiol increases IGF-1 activity in the breast. Agents to target IGF-1R in triple-negative breast cancer may induce cell-protective autophagy. Investigators suggest that elevated IGF levels may define a subgroup of women with high mammographic density and limited TDLU involution. Two markers related to increased breast cancer risk, insulin and IGF-1 receptor family, are now known to have a role in macronutrient intake and cancer, diabetes and cancer, and obesity and cancer. Diabetes is associated with a complex physiology of insulin resistance, increased insulin, estrogen, and growth hormone levels, increased inflammatory levels, and signaling pathways leading to an increased risk of breast cancer. Insulin therapy and sulfonylurea were found to be mildly associated with increased breast cancer risk. A United Kingdom study showed women treated with insulin, glargine, were not associated with breast cancer risk in the first 5 years. However, longer use may increase that risk. Metformin appears to have a protective role. Much more investigation is needed to understand the role of insulin-like growth factor, and diabetes mellitus, and their associated risk of breast cancer, and recurrence of breast cancers. A recent study found women with multiple gestational diabetes mellitus pregnancies had a higher incidence of breast cancer. Melatonin, as a regulator of a circadian rhythm, is the main focus of shift work and light at night and breast cancer risk. However, tumor growth can be accelerated by light at night, in part from continuous activation of IGF-1 receptor signaling. A recent case control study of 1679 women exposed to LAN during sleep was significantly associated with breast cancer risk. This study was the first to identify bedroom light intensity and breast cancer risk. Although inconclusive, shift work and its disruptive effects on circadian rhythms and sleep deprivation at night have been suggested as a risk factor for breast cancer. The human chorionic gonadotropin. The human chorionic gonadotropin level increases during the first trimester and then rapidly declines to a steady state throughout pregnancy. Data from rat studies indicate that measurement of HCG levels may be useful in developing new therapies because it has anti-proliferative and anti-invasive effects. However, insufficient data exist on the safety of HCG. Its role in carcinogenesis is complex, and much more research needs to be done. Oral contraceptives. The International Agency for Research on Cancer group confirmed that combined estrogen-progesterone oral contraceptives increase the risk for breast, cervix, and liver cancer. A recent meta-analysis of 66 studies showed current use of oral contraceptives, nulliparity, and maternal age of 30 years or older at first birth were associated with a 1 to 1.5-fold increased risk of breast cancer. Current oral contraceptive use appears to be associated with a higher risk of invasive breast cancer, but risk differs by hormone fluctuation and age. From the NHS, older women use of oral contraceptives for 10 or more years and past oral contraceptive use before the first full-term pregnancy were not associated significantly with breast cancer. Oral contraceptive formulations were prescribed in the 1990s in the younger NHSI2 cohort, but current oral contraceptive use is associated with a 33% higher risk of breast cancer. A higher risk was not observed in past users. Hormones are discussed further in the Pathophysiologic section. Mammographic breast density, or MBD, is a radiologic appearance of the breast, reflecting variations in breast tissue composition. Mammographic breast density appears white or dense on a mammogram, is expressed as a percentage of a mammogram, and is a strong and consistent risk factor for breast cancer. A recent prospective study revealed breast density was the most prevalent risk factor for both premenopausal and postmenopausal women and had the largest effect on the population attributable risk proportion. Percentage mammographic density estimates the proportion of stromal and epithelial tissue in relation to fat tissue in the breast. Internationally, studies done in the US, Canada, and Europe all found that a significant increase in risk is associated with more extensive PMD. Risk persisted for 8 to 10 years from the date of the mammogram and increased with increasing PMD. Extensive PMD is associated with a markedly increased risk of invasive breast cancer. PMD is inversely associated with age, weight, age of menopause, and use of tamoxifen, and directly associated with height, parity, family history of breast cancer, and combined hormone therapy. High breast density correlates with collagen level. Investigators suggest that COX-2 has a direct role in modulating tumor progression in tumors arising within collagen-dense microenvironments. CC chemokine ligand 2 is an inflammatory cytokine that recruits macrophages to sites of injury. CCL2 by mouse mammary epithelium induces a state of low-level chronic inflammation that increases stromal density. Investigators hypothesized that CCL2-driven inflammation contributes to the increased breast cancer in women with a high MBD. So here you're looking at the breast density varies among women. Environmental factors and lifestyle. The environmental causes of breast cancer possibly affect the breast the most during critical phases or windows of development, including early differential stages, that is, undifferentiated cells to alveolar buds and then lobulins, puberty, pregnancy and lactation, involution, and menopause. During early phases, mitotic activity and cell division are greater than later in life, leading to radiation. Ionizing radiation is a known mutagen and establishes carcinogens for breast cancer. To date, only accidentally or medically induced radiation has been demonstrated to exert a carcinogenic effect on the breast. The Institute of Medicine reports that the two most strongly associated environmental factors are exposure to ionizing radiation and combined postmenopausal HT. There are many sources of ionizing radiation, including X-ray, CT scans, fluoroscopy, and other medical radiologic procedures. Although only about 10% of the diagnostic radiologic procedures in large US hospitals are CTs, they contribute to an estimated 65% of effective radiation dose to the public from all medical X-ray exams. The IOM conclusion of a causal relationship between radiation exposure in the same range as CT and cancer is consistent from a large varied literature. The IOM makes it clear that avoidance of medical imaging is an important and concrete step that women can take to reduce their risk of breast cancer. Scientists and clinicians have been expressed concerns about the increased number of CT scans performed, including on children, radiologic exposure of the upper spine, heart, ribs, lungs, shoulders, and esophagus also exposes breast tissue to radiation. Breast tissue may be exposed from abdominal CAT scans. X-rays and fluoroscopy of infants may constitute whole body irradiation. Epidemiologic studies have shown that adolescents and young women are at increased risk of developing breast cancer following exposure to ionizing radiation compared with older women, and the risk is dose dependent. The duration of increased risk from radiation is unknown, but increased risk appears to have lasted at least 35 years in women treated for mastitis. Those treated with fluoroscopy and those who survived the atom bomb. Breast cancer rates in atomic bomb survivors in Japan were highest among women younger than 20 years of age at the time of exposure. Importantly, those who had early full-term pregnancies were at significantly lower risk than those who had not. Thus, interacting factors can modulate the risk from radiation. Similarly, young women exposed to high levels of diagnostic radiation have an elevated risk of breast cancer. In women treated with radiotherapy for Hodgkin's lymphoma, There is a linear relationship between radiation exposure and breast cancer risk, and women younger than age 20 at the time of exposure had the highest risk of developing subsequent breast cancer. Cancer induction and exposure to low doses and low energy X rays are controversial and a topic of much debate and research. Biologic understanding related to low doses of radiation is presented in Chapter 2 and 13. Delivering dose and specific low dose effects are main concerns in radiologic breast imaging. Conventional X ray mammography is one of the most valuable diagnostic tools for imaging of the breast. Today, much use is with full field digital mammography. Continuous technical development has led to several new imaging techniques, including digital breast tomosynthesis, phase contrast X-ray imaging, computed tomography of the breast, as well as ultrasound and MRIs. Despite technical involution, except for ultrasound and MRI, these modalities require exposure of breast tissue to ionizing radiation, and the breast is considered the most radiosensitive organ in the body. Therefore, it is critical to compare delivered radiation doses to the breast and measure X-ray and induced DNA damage, as well as other biologic effects. A technique for the detection and quantification of in vivo DNA damage has been developed. DNA double-strand breaks in our most relevant lesion induced by ionizing irradiation. After induction of DSBs, the phosphorylation of the histone variant H2AX, named gamma H2AX, is the second most source of DNA damage. Gamma H2AX is a visible focus and a reliable and sensitive tool for the determination of DNA damage. Researchers found mammography induces a slight but significant increase of gamma H2AX foci in systemic blood lymphocytes. A clear induction of DNA lesions was found both by FFDM and by DBT. Investigators assessed in vitro mammographic radiation induced DNA damage in mammary epithelial cells from 30 women with low LR or high HR, family risk of breast cancer. They found the existence of double-strand breaks induced by mammography and revealed by gamma H2AX assay with two radiobiologic effects, a low-dose effect and a low and repeated dose effect. These effects were greater in the high-risk patient. In agreement with these findings was a low and repeated dose effect and a lack of DNA repair of DNA damage. Investigators from international studies have concluded that diagnostic chest irradiation or radiation therapy for benign or malignant diseases increases the risk of breast cancer for cumulative doses as low as 130 mgy. The breast cancer risk did not decrease when increasing the number of radiologic treatment fractions for delivering the same total dose, but the risk decreased greatly with the increasing age of exposure to ionizing radiation. International agencies are assessing the utility of screening MRI and mammography in these high-risk populations. The risk of secondary lung malignancy is an important concern for women treated with whole breast radiation therapy after breast conserving surgery for early-stage breast cancer. According to the Cochrane Review, radiation therapy as a treatment for breast cancer increases deaths from heart disease by more than 25% and much more higher for deaths from lung cancer. Researchers studied SLM risk associated with several common methods of delivering whole breast radiation therapy, compared with supine whole breast irradiation. Prone breast irradiation is associated with a significantly lower predicted risk of secondary lung malignancies. These data will have more important to compare different breast imaging techniques. The United States Preventative Service Task Force has updated the recommendations for mammography because of overdiagnosis and overtreatment issues related to screening mammography. The next table here presents benefits and harm of screening mammography from randomized controlled trials. A good spot to hit pause so you can read more from the International and National Cancer Institute. Researchers are now looking for markers that are activated by DNA damage. One new marker may be the caveolin 1 protein. Caveolin proteins act as a sensor, an early mediator in response to DNA damage, and may be important as a biomarker for radiosensitivity. The pathogenesis of radiogenic breast cancer is unclear. Evidence shows that cancer that develops after radiation exposure have genotypic and phenotypic features that distinguish them from other breast cancers. Specific alterations have been implicated in radiogenic breast transformation. These cancers are more likely to be of the human epidermal growth factor receptor 2, or basal-like subtypes. Radiogenic breast cancers have a higher degree of genetic instability, such as a higher frequency of allelic loss of chromosome bands 6q13 and 9p21. Researchers identified numerous alterations of CMYC with high levels of CMYC application. CMYC protein expression is significantly higher in breast cancer after radiotherapy exposure. Radiogenic breast cancers reveal extensive intratumor heterogeneity with respect to CMYC copy number, which suggests continuous evolution of this locus during pathogenesis and progression. These data implicate CMYC as an oncogenic transcription factor in the etiology of radiogenic breast cancer. Elevated CMYC expression drives cell proliferation and replicative stress. So here we're taking a look at the working model of possible mechanisms of radiogenic carcinogenesis in the breast. The interplay between two factors that together may increase the breast cancer risk is ionizing radiation and the elevated estrogen levels. For the first time, a study was done in rat mammary gland tissue with ionizing radiation, combined with elevated levels of estrogen. Combined exposure caused a significant induction of the P24, 44, MAPK, and P38 signaling pathway that was paralleled by elevated levels of the H3S10 phosphorylation, a well-established biomarker of genome and chromosome instability. Diet. Prospective epidemiologic studies on diet and breast cancer risk fail to show an association that is consistent, strong, and statistically significant, except for alcohol intake, being overweight, and weight gain after menopause. Diet has been postulated as an important for breast cancer risk because of the international correlations of consumption of specific dietary factors and breast cancer incidence and mortality. And because migrant studies show greater incidence of breast cancer among descendants who relocated to another country compared with those in a country of origin. International variation also can occur because of differences in reproductive history, physical activity, obesity, and other factors. Animal models have identified the influence of diet on mammary carcinogenesis. Dietary fat. Dietary fat and breast cancer risk is the subject of much study, controversy, and debate. Potential biologic mechanisms between fat intake and breast cancer include that fat may stimulate endogenous steroid hormone production, that fat interferes with immune and inflammatory function, and that fat influences gene expression. Again, animal studies reveal obesity induced by fat diet increases the risk of several cancers, including breast cancer. Evidence from large prospective cohort studies has been mostly unsupportive, and clinical trials have not supported a strong association with total fat intake. Cohort studies, however, suggest a modest positive association between fat intake and the risk of breast cancer. But so far, more than 70 studies of the consumption of dietary fat during midlife on risk of breast cancer show the relationship is likely to be small. After 8.5 years of follow-up, the largest randomized controlled dietary trial conducted in the US showed no significant difference in the number of newly diagnosed breast cancer cases in the women in the treatment group compared with the control group. The World Health Cancer Research Fund, American Institute for Cancer Research, report indicated that although the evidence is limited, there was an increase in breast cancer risk among postmenopausal women consuming higher fat diets. The hypothesis that exposure that occur between menarche and first pregnancy are especially important in determining subsequent risk of breast cancer is supported by several lines of evidence. A first prospective study of almost 40,000 premenopausal women observed a modest direct association between adolescent intake of fat and breast cancer. This association persisted after adjusting for adult fat intake. Subtypes of fat were not significantly related to invasive breast cancer. Additionally, from the same time, study milk, dairy, and total carb intake in adolescent as well as the quality of carbohydrates as assessed by the glycemic load, glycemic index, and dietary fiber was not associated with breast cancer. A large prospective study of almost 100,000 subjects with an 8-year follow-up found that dietary fat does increase the risk of breast cancer recurrence or death in premenopausal women. Concern also has been that any association with fat intake may be because of total energy intake. A meta-analysis of 57 international and national studies indicates that saturated fat intake was associated with an increased risk for postmenopausal disease. Polyunsaturated fats were associated with increased risk regardless of menopausal status, and monounsaturated fats had no significant correlation with risk. Breast cancer risk may be determined early in life before the period of investigation. Which brings us to red meat. Another study is how consumption of red meat could increase breast cancer risk. The hypothesis ranged from available iron content, growth-promoting hormone used in the cattle industry, and carcinogenic heterocyclic amines released from cooking the fatty acid content. Case control and cohort studies have shown a modest association of red meat intake with breast cancer incidence, but no association in a pooled analysis of prospective studies. Researchers reported an increased risk with red meat consumption. However, a 2010 meta-analysis supported the WCRF AICR report that suggested there is no conclusive evidence that red meat or processed meat acts as an independent risk factor for breast cancer. Fiber. Fiber intake could affect breast cancer risk by several mechanisms, including stimulation of the intestinal microflora and reduction of the enterohepatic estrogen circulation that could reduce overall body estrogen concentration. Dietary fiber has been shown to modify estrogen concentration. A recent meta-analysis of prospective cohort studies showed that every 10 grams per day increment in dietary fiber was associated with a significant reduction in breast cancer risk. A meta-analysis of prospective case control studies also found an inverse association between dietary fiber intake and breast cancer risk. Data from the NHS support the hypothesis that higher fiber intake reduces breast cancer risk and suggests intake during adolescence and early adulthood may be especially important. Similar in structure by estrogens, lignans are biphenolic compounds in plant food, primarily found in fiber-rich foods. Lignans are the major source of phytoestrogens in Western populations. Plant lignans are converted in the human gut by intestinal bacteria to the enterolignans enterolactone and enterodiol, which are bioactive and are subsequently absorbed. Enteroligands may protect against cancer, and several mechanisms have been proposed and include they have weak estrogenic activity and therefore may bind to estrogen receptors. They inhibit tumor growth, they stimulate apoptosis, and they stimulate production of the carrier SHBG. Two meta-analyses found lignans to be associated with a small risk reduction in postmenopausal breast cancer, but not premenopausal. And from a follow-up study, those postmenopausal women with a higher enterolignan levels may have better survival. Soy. Soy products are a hot topic because of their consumption in Asian countries that have low rates of cancer. Soybeans are the main source of isoflavones. The isoflavone compounds, including diazine and genistein, can bind estrogen receptors, but are far less potent than estradiol. Soy may act like any other anti-estrogen, such as tamoxifen, by blocking the action of endogenous estrogens to reduce breast cancer risk. Thus, depending on the estradiol concentration and the timing of the administration, soy exhibit weak estrogenic and antiestrogenic activity. Isoflavones act through various mechanisms by which they may be cancer protective, including anti-proliferative effects, tyrosine kinase inhibition, induction of apoptosis, and inhibition of angiogenesis. They modulate enzyme activities, as well as signal transduction and have antioxidant properties. Researchers found that rats fed genistein before puberty had activated T-cell immune response before they started treatment with tamoxifen. Genistein improved response of memory tumors in rats by reduced activity of unfolded protein response, pro-survival autophagy signaling, and increased anti-tumor immunity. Soy is one of the few plant foods with all the amino acids to make necessary protein. In 2011, the North American Menopause Society held a symposium to review the latest evidence-based science on the role of soy and found that soy foods generally appear to be breast protective and recommended moderate lifelong soy consumption. Specific recommendations for breast cancer survivors and soy or isoflavone consumption could not be reached because animal studies indicate potential for risk and studies in humans imply a null or protective effect. A recent large study of both American and Chinese women, however, suggested that moderate intake of soy had a significant reduction in breast cancer recurrence, as well as a non-significant trend towards reduced all-cause mortality. In addition, soy may optimize extrarenal, the 1,2,5 cholecalciferol or vitamin D3, which could result in growth control and conceivably inhibition of tumor progression. Iodine deficiency is hypothesized as contributing to the development of breast pathology and cancer. Iodine plays a significant role in breast health. Evidence reveals that iodine is an antioxidant and antiproliferative agent, contributing to the integrity of normal mammary tissue. Seaweed, which is iodine rich, is an important dietary item in Asian communities and has been associated with a low evidence of benign and breast cancer disease in Japanese women. Molecular iodine supplementation exerts an inhibitory effect on the development and size of benign and cancerous tissue. A study in mice showed molecular iodine with solidodronate as a potent adjuvant therapeutic target for triple-negative breast cancer. Combined therapy reduced metalloproteinases 2 and 9, inhibited invasion migration of cells, and prevented growth of tumor in mice. Nutrition remains a critical area of study. Data on the dietary pattern are emerging. The Mediterranean diet includes high intake of vegetables, legumes, fruits, nuts, and minimally processed cereals, moderately high intake of fish, and a high intake of unsaturated lipids, coupled with a low intake of saturated fat, low to moderate intake of dairy products, low intake of meat products, and moderate intake of alcohol. The Mediterranean pattern was recently reported to lower overall cancer risk. A case control study among Greek Cypriot women found the Mediterranean diet may favorably influence the risk of breast cancer. The Western patterns includes higher intake of red and processed meats, refined grains, sweets and desserts, and a high-fat dairy products. Evidence exists that alcohol consumption increases breast cancer risk. In a report on carcinogens, the National Toxicologic Program of the U.S. Department of Health and Human Services suggests and lists a consumption of alcoholic beverages as a known human carcinogen. The IARC also lists alcohol, with sufficient evidence in humans, as a carcinogenic agent for cancer of the breast as well as other cancers. More than 100 epidemiologic studies have looked at the association between alcohol consumption and the risk of breast cancer in women. These studies have consistently found an increase in breast cancer risk with increasing alcohol intake. A meta-analysis of 53 studies with a large sample size found that women who drank more than 45 grams of alcohol per day had 1.5 times the risk of developing breast cancer as non-drinkers. The Million Women study in the UK produced a slightly higher estimate of breast cancer risk at low to moderate levels of alcohol consumption. Every 10 grams of alcohol consumed per day was associated with a 12% increase in the risk of breast cancer. The mechanism by which alcohol intake increases the risk of breast cancer are unknown. However, proposed mechanisms include acetaldehyde as a toxic chemical and can damage DNA and proteins, generation of ROS, impaired nutrition, decreasing absorption of certain vitamins. Alcoholic beverage may contain carcinogenic contaminants, and physiologic studies have reported an estrogen level increase in women taking menopausal hormone therapy, and IGF-1 level increases with alcohol intake. Alcohol may increase breast cancer risk through increasing mammographic breast density, especially in women at high risk. It is not known whether reducing or discontinuing alcohol consumption in midlife decreases that risk of breast cancer. Obesity, excess body fatness, is known to increase cancer risk from cellular pathways that involve hormonal regulation, cellular proliferation, and immunity. Obesity, measured as body mass index, has been associated with a reduced risk of premenopausal breast cancer. Recently reported, however, was that weight gain or weight loss since age 18 did not significantly decrease the risk of premenopausal breast cancer. Other data measuring adiposity using waist-hip ratio have not found a reduced risk, but rather no association, nor an increased risk. Excess adiposity is positively associated with breast cancer recurrence and breast cancer-specific mortality, among both premenopausal and postmenopausal women. In 2002, the International Agency for Research on Cancer concluded that excess body weight increased the risk of developing postmenopausal breast, colorectal, endometrium, kidney, and esophageal adenocarcinoma. Numerous studies have observed increasing adult BMI and postmenopausal breast cancer, particularly for estrogen receptor positive tumors. The World Cancer Research Fund concluded that evidence is convincing and that a probable association exists between body fat and postmenopausal breast cancer. Weight gain may be more strongly related to postmenopausal breast cancer risk than attained weight. A meta-analysis of 11 studies suggests that adult weight gain is predictive of twofold increase in the risk for ER+, as well as ER+ and PR+. Breast tumor with a greater risk in postmenopausal women. Premenopausal and postmenopausal weight gain also is associated with higher estradiol and estrone levels and lower SHBG levels as a transporter protein. Low levels cause high bioavailability of estrogen. This increase in estrogens, particularly estradiol, is from aromatization in the adipose tissue. Second, use of exogenous hormones postmenopausally obscures the variation in endogenous estrogens caused by adiposity and elevated breast cancer risk regardless of body weight. Excess body fat and weight gain are stronger risk factors for women who do not use hormone therapy. However, a prospective study found weight gained at multiple time points throughout adulthood of 44 to 63 pounds was associated with a 56% higher risk of breast cancer, and weight gain of 88 to 108 pounds doubled the risk of breast cancer among hormone users. Recent animal study shows obese animals deposited excess calories into the tumors themselves. These tumors from obese animals had an increased expression of progesterone receptors. Obesity is associated with poor survival among women with breast cancer, and the association of obesity with mortality from breast cancer appears to be stronger than its association with incidence. The increase in breast cancer risk with increasing BMI among postmenopausal women is most likely the result of increases in levels of estrogen by aromatase activity in adipose tissue. However, studies of hormones secreted by adipose tissue, leptin and adiponectin, may underlie the association between obesity and breast cancer risk. Increasing BMI and central fat deposition are associated with increased risk for breast cancer in prospective studies, and in vitro studies have shown leptin-stimulated breast carcinogenesis. From molecular mechanism studies, leptin enhances breast cancer cell proliferation by inhibiting cell death, signaling pathways, and by increasing in vitro sensitivity to estrogens. Leptin secreted by adipocyte and fibroblasts in the microenvironment act on the breast cancer cells in the paracrine manner. Adiponectin has been shown to exert anti-proliferative effects in vitro on human breast cancer cells. Additionally, factors that may be related to recurrence of breast cancer in women with excess adiposity at the time of diagnosis include cytokines, IGF, or immune function, or a combination of both. Leading us to the synthetic chemicals. Evidence for linking synthetic chemicals to the cause of breast cancer is difficult to obtain. It is challenging because it is a life history of exposure that is important, not just a single chemical, but also complex mixtures of chemicals and their interactions with endogenous hormones. The highest rates of breast cancer are found in super-industrialized countries, such as North America and Europe, and the lowest rates in Central Africa and Asia. With industrial development, breast cancer rates increase. An estimated 100,000 synthetic chemicals are registered for use today in the US. Another 1,000 or more are added each year, and toxicologic screening for these chemicals is minimal only about 7%. In 2006, more than 35 million metric tons of chemicals were produced or imported into the United States every day, and chemical production is projected to double over the next 25 years. Current approaches to chemical screening are being re-envisioned. Several major federal research initiatives were instigated, including the EPA, ToxCast, and National Toxicology Program, high throughput screening initiatives, and the interagency Tox 21 initiative. New important endpoints will include altered mammary gland development, HER2 activation, progesterone receptor activity, prolactin effects, and aspects of estrogen receptor beta activity. Chemicals persist in the environment, accumulate in the adipose tissue, interact with local adipose tissue physiology in the endocrine-paracrine manner, and remain in breast tissue for decades. Some of these chemicals are known human carcinogens, and many have been linked to mammary tumors in animals. Women who emigrate to the United States from Asian countries experience an enormous percentage increase in risk within one generation. A generation later, their daughter's risk approaches that of women born in the United States. This change in risk suggests that in utero exposure affects subsequent decreased risk. However, it is difficult to know whether these changes in risk are derived from nutritional content, pollutants, cosmetics, food additives, or other factors. Xenoestrogens are synthetic chemicals that mimic the actions of estrogens and are found in many pesticides, fuels, plastics, detergents, and drugs. Because many factors correlate with breast cancer and are associated with lifetime exposure to estrogens, researchers reason that environmental chemicals affect estrogen metabolism and contribute to breast cancer. The most significant chemicals may be polychlorinated biphenyls, pesticides, BPAs, tobacco smoke, dioxins, alkylphenols, metals, phthalates, parabens, food additives, MHTs, and others. By bisphenol A treatment of breast epithelial cells cultured from premalignant biopsy tissue elicited a genetic exposure or expression profile associated with a large, high histologic grade breast tumor. Some chemicals are fat soluble, and the estrogenic effect would require either that they bind to the nuclear estrogen receptors and then cause cell division or gene transcription, or that they activate reactive oxygen species through oxidative catabolism of estrogens. So you can see that here in this following chart. So here's a good spot to hit pause so you can review all the selected chemicals and the risk of breast cancer. And I'll try to stop it so that it makes, sense where you can pause and read all of it at once. Which brings us to physical activity. Physically active individuals have lower rates of many cancers and improve cancer outcomes. Activity also may reduce the invasiveness of breast cancer. A sedentary lifestyle may increase cancer risk through several mechanisms, including increased insulin resistance, increased inflammation, and a decreased immune function. Epidemiologic studies demonstrated that physical activity lowered the risk of breast cancer mortality in breast cancer survivors and improved their physiologic and immune function. In 2013, a meta-analysis of 31 prospective studies, the average breast cancer risk reduction with physical activity was 12%. Although the evidence is stronger for postmenopausal women, Physical activity has been associated with reduced risk in both premenopausal and postmenopausal women. Mechanisms for this protective effect are not known, but include alterations in endogenous free radical formation and oxidative damage, effects on DNA repair, changes in circulating insulin and insulin-related pathways, inflammation, alteration in carcinogen metabolizing enzymes, increased intestinal transit times, weight loss, and changes in the endogenous sex hormone levels, and possibly immune cell levels, leading us to the inherited cancer syndromes, genes, epigenetic consideration. The cause of breast cancer have been difficult to define because each woman has a different genetic profile called genetic heterogeneity. Genetic heterogeneity is common among individuals, but also at the level of the tumor itself, involving both genetic and epigenetic processes. Phenotypic heterogeneity is the result of tumor cell plasticity, and together with the genetic background of the tumor determines whether cells resist environmental stress, such as microenvironmental stressors, and metastasizing. The genetic factors interact with environmental factors. These facts are sobering and make the understanding of the genetic driving force behind tumor initiation, progression, and metastasis very complicated. Driver mutation are causally implicated in tumor development. Researchers examined the genomes of 100 tumors for somatic mutation and found they varied markedly between individual tumors. Several new driver mutations were identified, including the ACT2, ARID-DIP, the CASP8, the CDKN1B, the MAP3K1, MAP3K13, NCOR1, SMARCD1, and TBX3. A novel 95 gene signature of residual breast cancer risk, which integrates lymph nodal status, has better clinical utility for the early recurrence than the current available multiparametric test. So here you see the driver mutation and the copy number changes in breast cancer. A history of breast cancer in first-degree relatives. Increase of women's risk about 2 to 3 times. Risk increases even more in two first-degree relatives are involved, especially if the disease occurred before menopause and was bilateral. A small total proportion of breast cancer is the result of highly penetrant dominant genes. The most important of the dominant genes are the breast cancer susceptibility genes, your BRCAs 1 and 2. BRCA1, located on the chromosome 17, is a tumor suppressor gene. Therefore, any mutation in the gene may inhibit or retard its suppressor function, leading to uncontrolled cell proliferation. BRCA2 is located on chromosome 13. A family history of both breast cancer and ovarian cancer increases the risk that an individual with breast cancer carries a BRCA1 mutation. Carriers of the BRCA1 gene also are at a higher risk for ovarian cancer. The risk for breast cancer or ovarian cancer or both, however, are not equal in all mutation carriers and have been found to vary by several factors, including the type of cancer, age of onset, and the position of mutation. This observation variation in penetrance has led to the hypothesis that other genetic and/or environmental factors modify cancer risk in mutation carriers. Men who develop breast cancer are more likely to have a BRCA2 mutation than a BRCA1 mutation. Options for those who have a positive test for BRCA1 or 2 mutation include surveillance to find cancer early, prophylactic surgery, risk factor, avoidance, promotion of breastfeeding, and chemoprevention. Several other genetic alterations can increase the risk of breast cancer. So it's pathophysiology. Most breast cancers are adenocarcinomas and first arise from ductal lobular epithelium as carcinoma in situ. Carcinoma in situ is an early-stage, non-invasive proliferation of epithelial cells that is confined to the ducts and lobules by the basement membrane. Ductal carcinoma in situ and lobular carcinoma in situ are discussed next. Breast cancer is a heterogeneous, not a single disease, with diverse molecular genetic, phenotypic, and pathologic change. Tumor heterogeneity results from a genetic, epigenetic, and microenvironmental influences that tumor cells undergo during cancer progression. Cellular subpopulations from different sections of the same tumor vary in many different ways, including growth rate, immunogenicity, ability to metastasize, and drug response, demonstrating significant heterogeneity. The biologic attributes of a tumor as a whole are strongly influenced by its subpopulation of cells, with cellular populations communicating through paracrine or contact-dependent signaling from ligands and media from components of the microenvironment, such as a blood vessel, immune cells, and fibroblasts. The rich microenvironment of breast tumor is highly dynamic and heterogeneous. Cancer cells behave as communities, and the cooperative behaviors of these subclones can influence cancer progression. Recent research suggests that breast cancer is heterogeneous from its initial pre-invasive stage and within the same tumor. So here we're taking a look at the types of breast carcinomas and their major distinguishing features. A good spot to hit pause. Let's see if I can get all of it in one spot. No. Despite heroic effects, this heterogeneity has greatly challenged the understanding of breast cancer evolution and the development of therapeutic strategies. Gene expression profiling studies have identified major subtypes, classified as luminal A, B, HER2+, basal-like, claudin low, and normal breast. These subtypes have different prognosis and responses to therapy. Tumors can be stratified with gene expression profiles, such as oncotype diagnosis, prosigna, and mammaprint on the basis of genomic profiles. This information helps personalize breast cancer treatment and determine which women need aggressive systemic treatment for high-risk cancers versus close surveillance for indolent tumors. Many models of breast carcinogenesis have suggested, and the expanding themes include gene addiction, phenotype plasticity, cancer stem cells, and hormonal outcomes, affecting cell turnover of mammary epithelium, stem cells, extracellular matrix, and immune function. Cancer gene addiction include oncogene addiction, whereby these driver genes play key roles in breast cancer development and progression, and non-oncogene addiction, whereby these genes may not initiate cancer but play roles in cancer development and progression. Examples of key driver genes include the HER2 and MYC, and examples of tumor suppressor genes include TP53, BRCA1 and 2. Once a founding tumor clone is established, genomic instability may assist through establishment of subclones and contribute to both tumor progression and therapy resistance. Phenotypic plasticity is exemplified by a distinctive phenotype called epithelial to mesenchymal transition. EMT is involved in the generation of tissues and organs during embryogenesis, is essential for driving tissue plasticity during development, and is hijacked during cancer progression. The EMT-associated programming is involved in many cancer cell characteristics, including suppression of cell death and apoptosis, and senescence, is reactivated during wound healing and resistant to chemotherapy and radiation therapy. Remodeling or reprogramming of the breast during post-pregnancy involution is important because it involves inflammatory and wound healing-like tissue reaction, known as reactive stroma or inflammatory stroma. The reactive stroma releases various signals and interleukins that affect nearby carcinoma cells, inducing these cells to activate their previously silent EMT programs. The activation is typically reversible, and those EMT programs may revert through mesenchymal epithelial to the previous phenotypic state before the induction of the EMT program. Reactive stroma increases the risk for tumor invasion and may facilitate the transition of carcinoma in situ to invasive carcinoma. Activation of an EMT program during cancer development often requires signaling between cancer cells and neighboring stromal cells. In advanced primary carcinomas, cancer cells recruit a variety of cell types into the surrounding stroma, including fibroblasts, myofibroblasts, granulocytes, macrophages, mesenchymal stem cells, and lymphocytes. Overall, increasing evidence suggests that interactions of cancer cells with adjacent tumor-associated stromal cells induce malignant cell phenotypes. Several types of carcinoma cells are reported to acquire tumor-initiating capability after induction of the EMT program. The tumor-initiating traits are depicted as cancer stem cells. Tissues with residing carcinoma cells in the CSC state seem critical for progression through the invasion metastasis cascade as founders of new metastatic colonies. With increasing acquisition of the mesenchymal traits as driven by EMT program, it is reported to increase the resistance of carcinoma cells to both radiation and chemotherapy. So here we're taking a look at different types of cancer-associated fibroblasts, the cells of tumor microenvironment. A good spot to hit pause. And here you see the signaling interaction in the tumor microenvironment during a malignant progression. Again, a good spot to hit pause. Invasion by the primary tumor cells typically involves the collective migration of large, cohesive groups of cells into adjacent tissues, rather than scattering of individual carcinoma cells. Still, unknown are the precise events occurring at the invasive edge. Critical to the understand is the process of the invasion as it relates to the treatment. The possibility of displacing tumor cells into the biopsy needle tract is a concern, although reported, although reported as a low incidence. Mechanical disruption from surgery can lead to displacement and seeding of tumor cells. Dormant carcinoma cells appear to perpetuate carcinogenesis and form the precursor of eventual metastatic relapse and sometimes rapid cancer recurrence. These dormant cells are called minimal residual disease and may remain after initial chemotherapy, radiotherapy, and surgery. Dormant cells have excited the cell cycle. Thus, they are not proliferating, and current treatments preferentially kill proliferating cells, rendering dormant cells intrinsically more resistant to almost all current treatments. The benefit of surgery is reducing the number of cancer cells and diversity of neoplastic cells, and perhaps increasing the chance of getting rid of therapy-resistant cells. So here you're taking a look at invasion. A large number of reports identify the existence of the partial EMT state and its ability to enhance tumor progression and metastasis. The phenotypic plasticity associated with the epithelial mesenchymal spectrum appears critical to the founding of metastatic colonies. Invasive clusters or individual invasive carcinoma cells eventually invade into the vasculature of either adjacent normal tissue or the neovasculature that has been assembled within the tumors themselves. The resulting intravasation is an avenue for circulating tumor cells to distant sites. Using a mouse model of tumor heterogeneity, researchers demonstrate that different clones of memory tumor cell lines possess different abilities to the formation of metastasis. More simply, different clones with the heterogeneous population had distinct properties, such as an ability to dominate the primary tumor, or to contribute to the metastatic population, or to enter the lymphatic or vascular system. The expression of two proteins, SERPINE1 and S1PI, correlates with lung metastasis, and similar associations were observed in the human dataset. SERPINE2 and SLPI act as anticoagulants and allow tumor cells to undergo vascular mimicry, whereby the tumor cells themselves form part of the blood vessel and contribute to increased intravasation by building more leaky blood vessels. Vascular mimicry was first detailed in 1999 in aggressive melanomas and involves the formation of vascular-like networks by aggressive tumor cells that have similar characteristics to the endothelial cells that line normal blood vessels. These networks are rich in extracellular matrix and allow perfusion of blood and fluid through tumor tissues. So here you're taking a look at vascular mimicry. Carcinoma cells may promote the growth of lymphatic vessels that, through the process of lymphangiogenesis, the process is correlated with disease progression. It is not yet defined what specific factors determine the efficiency of clinical metastatic disease and why some patients present with metastasis and other patients experience years before a relapse and present with metastasis. The emergent evidence supports three main prerequisites that must be met in order to metastatic colonization to succeed: the capacity to seed and maintain a population of tumor-initiating cancer stem cells, the ability to create adaptive, organ-specific colonization programs, and the development of supportive microenvironmental niche. So here you're taking a look at the three requirements for metastatic colonization. Traditionally, metastases has been considered a late event in the multi-step tumor progression. Recent reports, however, suggest that dissemination can occur early during the process of neoplastic transformation. One explanation has been attributed to the presence of pre-neoplastic cells residing within inflammatory microenvironments that through signaling can activate EMT programs, causing the development of invasive phenotypes. Additionally, from murine models of HER2+, breast cancer and early stages of primary tumor formation, a migratory and stem-like program predominates before the proliferative pathways occur during the later stages of tumor growth. In other cases, however, metastasis appears to be a late event. Ductal carcinoma in situ, or DCIS, is a heterogeneous group of proliferative lesions, clinically, radiologically, morphologically, and genetically. DCIS is limited to breast ducts and lobules without invasion of the basement membrane. When DCIS breaches the basement membrane and invades adjacent stroma to a depth of 1 millimeter or less, microinvasion is said to be present. About 84% of all in situ diseases in DCIS. The remainder is mostly LCIS disease. DCIS occurs predominantly in women but can occur in men. It has a wide spectrum of risk for invasive cancers. Since 1980, the widespread adoption of screening mammography has led to an epidemic of diagnosis of DCIS. With the introduction of screening mammography, there have been a 500% increase in the diagnosis of DCIS, which represents about 25% of mammographically detected breast lesions. Since 1983, there has been a 290% increase in DCIS among women younger than 50 years, and the incidence is still increasing. Because of the large number of cases diagnosed yearly in the United States, the debate is whether mammography is causing the overdiagnosis of potential pseudodisease. For example, the Canadian National Breast Screening Study 2 of women aged 50 to 59 years found a fourfold increase in DCIS cases in those screened by clinical breast examination, plus mammography compared with those screened by CBE alone, with no difference in breast cancer mortality. So here you're taking a look at a normal duct versus the DCIS. The perspective on DCIS is changing. The cells of DCIS look like invasive cancer, both pathologically and molecularly, and therefore the presumption was that these lesions were precursors of cancer and the early removal and treatment would reduce cancer incidence and mortality. Long-term epidemiologic studies have demonstrated that the removal of 50 to 60,000 DCIS lesions annually has not been accompanied by the reduction in the incidence of invasive cancers. Contrarily, the removal of colonic polyps and the intraepithelial neoplasia lesions of the cervix and precursor lesions has led to a decrease in the incidence of colon and cervical cancers, respectively. It is now known that breast cancer has a range of behaviors, aggressive to indolent, and screening mammography increases the likelihood of indolent lesion surfacing. New data from NORAD and colleagues add to the growing concern to rethink the strategy for the detection and treatment of DCIS. In a large observation study of 100,000 women with a diagnosis of DCIS, the risk of dying from breast cancer is low. Less than 1% of women in this 20-year study died of breast cancer. Surprisingly, the overall death rate for women with DCIS is lower than that of women in the population as a whole. Aggressive treatment of almost all DCIS does not lead to the reduction in breast cancer mortality, confirming the conclusion from the NSABP trials. Because of these findings, some argue that the term DCIS is misleading and should be replaced by ductal intraepithelial neoplasia, similar to the term used in prostate cancer, and the breast cancer statistics should exclude those DCIS cases with invasive breast cancer statistics. This is very critical news, suggests a treatment change as an alternative to surgery and radiation. A study of 6 months of letrozole therapy is one example of a new approach along with observation and may increase clinical trials of observation and endocrine risk-reducing therapy. Prevention or risk-reducing strategies are discussed next and need initiation and study. Stratification of risk is mandated to avoid overtreatment, unnecessary morbidity, and the same treatment as invasive cancers. Factors to help risk stratification of DCIS include grade and comedonocrosis. However, these factors are not predictive. Molecular tests, such as the Oncotype DCIS score, have been shown to predict the 10-year risk of invasive cancer following surgical excision alone. Therefore, some direction is solving the overtreatment dilemma is emerging. For example, the emerging data suggests that it is safe to eliminate radiation for luminal A invasive tumors in postmenopausal women. Then radiation should not be routine in low-grade or low-risk DCIS. The majority of DCIS is detected in women for screening and who are recalled for biopsy or calcification. Importantly, to minimize the risk of overdiagnosis or overtreatment or both, reassessment of whether clustered amorphous calcification should be a target for screening, recall, and biopsy, especially in older women. Increased mortality risk from DCIS is associated with risk factors, age at diagnosis, ethnicity, and DCIS characteristics such as estrogen receptor status, grade, size, and comedonocrosis. DCIS lesions diagnosed before 35 or 40 years of age do pose an increased risk of breast cancer mortality. These lesions are likely different from those found from mammography, since screening before age 40 is rare and may be associated with a symptomatic event, such as a mass or a bloody nipple discharge. Black women should continue with today's aggressive standards. In total, these high-risk groups account for 20% of the total population of women with DCIS. Although DCIS may remain stable and never progress, for invasive DCIS, the cells within the DCIS breach the myoepithelial layer and the basement membrane, defining the moment when an invasive carcinoma is formed. Importantly, the layer of myoepithelial cells is thought to be natural tumor suppressors and critical to maintaining tissue polarity, a role that is lost in invasive breast carcinoma. Excuse me. Investigators and clinicians are intensely studying this key step or breach in terms of cellular alteration because of tumor biology or iatrogenetic stimuli, or both. So here we're taking a look at the role of the myoepithelial cells in invasive breast cancer. A good spot to hit pause. DCIS represents an opportunity to alter the breast environment. Alterations may be done with increased exercise, decreased alcohol intake, and avoidance of postmenopausal hormone therapy with progesterone-containing regimens. Stratification of the DCIS lesion may be accomplished through available tools such as Oncotype DCIS. Unfortunately, according to one population-based study, only half of such women are tested with genetic testing. So in summary, based on large numbers and long-term follow-up, given the low breast cancer mortality, DCIS is not an emergency. The detection and treatment of non-palpable DCIS often represents overdiagnosis and overtreatment. So, data now suggests the following. Much of DCIS should be considered a risk factor for invasive cancer and targeting for preventative strategies. Radiation therapy should not be routinely offered after a lumpectomy for DCIS lesions that are not high risk because it does not affect mortality. Low and intermediate grade DCIS does not need to be targeted for screening or early detection. And lastly, continuing study is needed both of the biologic nature of the high risk DCIS and the target approach to reduce death from breast cancer. That brings us to lobular carcinoma in situ, or LCIS, which originates from the terminal duct lobular unit. Unlike DCIS, LCIS has a uniform appearance, thus the lobular structure is preserved. The cells grow in non-cohesive clusters, typically because of a loss of the tumor-suppressive adhesion protein, E-cadherin. Also, unlike DCIS, LCIS is found in an incidental lesion from a biopsy and not from a mammography because it is not associated with calcification or stromal reaction that produce mammographic densities. LCIS has an incidence of about 1 to 6% of all carcinomas and did not increase with mammographic screening. With biopsies in both breast, LCIS is bilateral in 20 to 40% of cases, compared to the 10 to 20% of cases of DCIS. The cells of atypical hyperplasia, LCIS, and invasive lobular carcinoma are structurally identical. Dysfunction of the E-cadherin results in a loss of cellular adhesions, and lesions have a rounded shape without attachment to adjacent cells, increasing the risk of invasion. Invasive carcinoma from LCIS develops in 25 to 35% of women over a period of 20 to 30 years. Unlike DCIS, the risk is almost as high in the contralateral breast as in the ipsilateral breast. Treatment include close clinical follow-up and mammographic screening, tamoxifen administration, and bilateral prophylactic mastectomy. So, its clinical manifestations. The outer quadrant, where most of the glandular tissue of the breast is located, is where the majority of carcinoma of the breast occur. The lymphatic spread of the cancer to the opposite breast, to lymph nodes in the base of the neck, and to the abdominal cavity is caused by obstruction of the normal lymphatic pathways or destruction of the lymphatic vessels by surgery or radiotherapy. The less common inner quadrant tumor may spread to mediastinal nodes or rotor nodes, which are located between the pectoral muscles. Other common sites of metastasis include the internal mammary chain nodes. Metastasis from the vertebral veins can involve the vertebra, pelvic bone, ribs, and skull. The lungs, kidney, liver, adrenal glands, ovaries, and pituitary gland also are sites of metastasis. The first sign of breast cancer is usually a painless lump. Lumps caused by breast tumors do not have a classic characteristic. Other presenting signs include palpable nodes in the axilla, retraction of the tissue, or bone pain caused by metastasis to the vertebra. The following table summarizes the clinical manifestations of breast cancer. Manifestations vary according to the type of the tumor and the stage of the disease. So here you see the retraction of the nipple caused by a cancer. And here is a great spot to hit pause so you can see all the clinical manifestations of breast cancer. Again, I'll try to see if I can put everything into one area. If not, I'll make it make sense to hit pause in several spots. So it's evaluation and treatment, therefore. Clinical breast examination, mammography, ultrasound, thermography, MRIs, biopsies, hormone receptor assays, and gene expression profiling are used in the evaluation of breast alterations and cancer. Treatment is based on the extent or stage of the cancer, the extent of the tumor at the primary site, the presence of the extent of lymph node metastasis, and the presence of distant metastases are all evaluated to determine the stage of the disease. Treatment includes surgery, radiation, chemotherapy, hormone therapy, and biologic therapies. Strategies for the risk reduction of breast cancer are evolving and include implementation of a modified diet, including decreased alcohol consumption, utilization of an exercise program, and avoidance of postmenopausal hormone therapy with progesterone-containing regimens, and possibly others. That concludes this chapter. I thank you all for watching as always, and I hope you have a wonderful rest of your day. And we'll see you next time. Till then, take care and goodbye.